Now we are proceeding for the next session. We are already running late. I request all the delegates to be alert. And our next session will be Tufani. Dr. Ganesh Wagmode and myself, Dr. Devdikar, will be conducting the session. We have first topic. Dr. Manisha Ghate will be speaking on approach to first trimester bleeding. And I request our chairpersons, Dr. Ashutosh Bahulekar, Dr. Dattatray Sarje, and Dr. Sujata Gundevar ma'am to chair the session. I request the chairpersons to introduce the speaker with a short introduction. Ashutosh sir, please introduce Sujata ma'am fast.
Good morning, everyone. Good morning, Dr. Manisha. She is the president of Chandrapur OBGYN Society. She is a West Zone Coordinator, Food, Drug, Medical, Surgical Equipment Committee, FOXY. She is Secretary General, ISOPARB with a chapter. She is Chairperson's Women's Doctors Wings IMA, Chandrapur. She is the Secretary of Chandrapur OBGYN Obstetrics and Gynec Society. She is the Vice President IMA Chandrapur. She is a Director of Chandrapur Test to Baby Center. She has a recipient of National IMA Dr. Kanak Goyal Award for Safe Motherhood. She is a Director of Santaji Mahila Nagri Sahakari Bank Chandrapur. First to bring a state colposcopy in Chandrapur.
Thank you, Chairperson, for the kind introduction.
So there's a lot more things, but
Yes.
welcome, ma'am.
Yes. Thank you, sir. At the outset, I would like to give my thanks to the organizing team for giving me the opportunity, Dr. Madan, Dr. Revati, and the whole organizing team of Barkha. A very good morning to all my respected seniors and dear friends. I bring regards from my own city of Black Gold, Chandrapur, which is situated near Nagpur. The topic given to me today is approach to the case of first trimester bleeding. Now, this first trimester bleeding, it is common in the first trimester and experienced by 20 to 40% of the pregnant women. Source of vaginal bleeding is virtually maternal rather than the fetal and is mostly due to the disruption of the blood vessels in the decidua or the discrete vaginal or cervical lesions which are associated with it. Now, let us see the causes of vaginal bleeding in the first trimester. Now, we will categorize it into related to pregnancy and the second, those are associated with the pregnancy. So, the related to pregnancies are most commonly the miscarriages, then the ectopic pregnancy, then comes the hydrated form mole or the vesicular mole, then vanishing twin, implantation bleeding, and many a times hormones like thyroid level disturbances, they also may cause vaginal bleeding. So in short, those which are related to the pregnant state, abortion, ectopic, vesicular mole in the more common trends. Then few lines about the vanishing twins. Most commonly the singleton pregnancy, very early loss of one member of the multiple gestation, which is more common the product of ART and can be associated with vaginal bleeding. Then the causes of vaginal bleeding which may be associated with pregnancy, they are unrelated to pregnancy but may be pre-existing or are aggravated during the pregnancy. They are the cervicovaginitis, then vascular erosions, polyp, fibroid, maybe malignancy or trauma. So the commonest are cervical erosion, cervical polyp or malignancy. Now few words regarding the physiologic or implantation bleeding. Small amount of spotting or bleeding 10 to 14 days after the fertilization, which is the time of missed menstrual period. This we can see some type of bleeding. Implantation of the fertilized egg in the decidua is the cause. However, this hypothesis is being questioned and it is a diagnosis of exclusion and no intervention is indicated most of the time. Now, vaginitis, trauma, tumor, warts, polyps, fibroid, they all can be excluded by and diagnosed with the visual inspection. Then additional tests are to be indicated like wet mount, pH of the discharge, cytology, biopsy of the mass lesion. Again, the ectropion. It is the most common normal findings in the pregnancy, especially in the multis. The exposed columnar epithelium is prone to light bleeding when touched, such as during the coitus, insertion of the speculum by manual examination. And therapy is unnecessary most of the time. So, how to approach to the diagnosis? Mainly, it is the history. First of all, calculate the gestational age. See the character of the bleeding, whether it is light or heavy, whether it is associated with pain or painless, it is intermittent or there is a constant bleeding. Then comes the examination, the laboratory test, and finally the gold standard is TVS to confirm or revise the initial diagnosis. Now, few lines about speculum examination. Yes, it may change the management and the diagnosis some of the times. Now, the NICE guidelines 2012 has given very nice flow chart regarding the approach to this first trimester bleeding. Now, the diagnostic approach to vaginal bleeding in early pregnancy. First of all, the history, the physical examination, which include the speculum examination and ultrasound is done. And we confirm whether it is an intrauterine pregnancy or if we don't see any intrauterine pregnancy. No, if we don't see any intrauterine pregnancy, and the speculum examination findings, if we see the internal os is closed, then first of all, we have to rule out the ectopic pregnancy, and the differential diagnosis also includes a very early viable or a non-viable pregnancy, which is too early to be appreciated during our TVS examination, and also the complete miscarriage is also to be the one of the possibility. Sorry. If the internal cervical os is dilated and the products of conceptions in the vagina are seen, or if they have previously discharged, then we can label the patient as complete miscarriage. Again, if the fetal cardiac activity is absent, then the differential diagnosis includes non-viable pregnancy, that is incomplete miscarriage may be also there, missed miscarriage, and very early viable pregnancy, just we have talked. And if the specular examination will also give us the idea about it, that internal os is closed, visible source of bleeding in the lower genital tract can be seen. Now, let us talk the gold standard in this approach and management of the transvaginal scan, because it plays a very important role in diagnosing the early trimester bleeding sources. So, TVS, it is the cornerstone of the evaluation of bleeding in the first trimester, most useful to rule out intrauterine or extrauterine if the pregnancy is viable or non-viable, whether there is any heterotrophic pregnancy, one in the intrauterine or extrauterine, then the gestational trophoblastic disease, that is hydatidiform mole, if there is loss of one fetus from the multiple gestation. Again, it is very vital to describe clinical and ultrasound findings in early pregnancy using appropriate terminology. Now, most of the time miscarriage, it is to be replaced by abortion in the clinical practice. Now, regarding PUV, that is pregnancy of uncertain viability. If we see intrauterine gestation sac of 20 mm with no obvious yolk sac or embryo, or 6 mm CRL with no obvious fetal heart activity, in these circumstances, always repeat a scan at a minimum interval of 1 week so that we can give the final diagnosis to the patient. Then TAS, transabdominal scan, has a little value, but it is most useful for assessing the free fluid in abdomen, especially when we are dealing with a case of ectopic pregnancies. Now, regarding the ultrasound findings of the threatened abortion patient, we all know In threatened abortion, we can get a viable intrauterine pregnancy up to 50%, but always the bad signs where there is bradycardia, fetal heart sounds are low, less than 85. If there is a bleeding and a small sac, then they are very bad indication that the pregnancy may not survive. The non-viable intrauterine pregnancy, miscarriage, again delayed miscarriage and incomplete miscarriage, ectopic pregnancy and hydatiform mole. Let us talk about one more term, that is pregnancy of unknown location. Here we get a positive pregnancy test, but no intrauterine pregnancy is seen, no extrauterine pregnancy is seen, and no retained products of conceptions are also seen. So here we go on repeating the serum HCG levels, and most of the time if they are declining, then it is considered that the pregnancy is not viable. But then we have to do a close follow-up of such patient. And this term should replace the pregnancy of indeterminate location and positive pregnancy test, but no signs of intra or extrauterine pregnancy or RPOCs. So now these most PULs are at low risk for an ectopic pregnancy, provided the sonography is sufficiently done by the skilled person, and HCG level are of prime importance, and the cutoff value should be closely monitored. Let us talk few lines about the blighted ovum, which is one of the cause of first trimester bleeding. It is an anembryonic pregnancy, we all know, where no fetal parts, no yolk sac, irregular sac contour, and if we are unsure, then we can repeat the scan in 1 week to confirm the diagnosis. Again, then comes the missed abortion, where in CRL 6 mm and no cardiac activity and no change at the time of repeat scan on 7 days later. As we all know, the growth rate is 1 millimeter per day normally, and we will often get a abnormal form of gestational sac. Then in incomplete abortion, what will be the picture? The endometrial midline echo will be distorted more than 15 mm. External os will be seen open, and the POCs may be most of the time seen protruding through the os. In complete abortion, yes, there will be the homogeneous endometrial thickness less than 15 mm. We can appreciate the empty uterine cavity and no evidence of RPOCs. Then in inevitable abortion, the gestational sac, it is usually situated low to the uterus or in the cervix, and most of the time it is in a process of complete abortion. Now, moving on to ectopic pregnancy, we all know the definition. So, here we are not going to get any intrauterine gestational sac. Normally, the beta HCG, we all know that it doubles around 48 hours, but if it is not seen, then consider a bleeding, and if there is bleeding, then think of ectopic pregnancy if uterus is empty on scan. Then again, this is also seen in some cases of ectopic pregnancy, that is pseudo-gestational sac. We can see here no yolk sac is seen when the gestational sac is even more than the 20 mm. Then regarding the adenexa blob sign, by pressing the vaginal probe gently against the ectopic, it moves separately to the ovary, and it is more sensitive. Then we can get a ring form also. Sac and embryo, yes, it is seen in 10 to 20% of ectopic pregnancy, and the ipsilateral side we can appreciate the corpus luteum. Now, seeing to the pouch of Douglas POD in the ectopic pregnancy, in the ruptured cases, we can see the fluid with or without blood clots located behind the posterior wall of the uterus. This was all about the ectopic. Let us move towards the another cause of first trimestral bleeding, that is hydatiform mole. Yes, we can appreciate the snowstorm appearance on the sonography, but the differential diagnosis in early phase, missed abortion with hydropic degeneration and degenerating fibroid may give some of the picture, but this can be ruled out. Now, definitive diagnosis is made by the histological examination. Early detection is reduced from 16 weeks by the passage of vesicles to 12 weeks by the nice USG examination, and usually it is seen that beta HCG levels moreover increase by 2 multiples of the median in these types of pregnancy. Again, the partial mole in most patient clinical and US diagnosis is usually missed or incomplete abortion. But in these cases, thorough histopathological evaluation of all missed, just 2 slides, thorough histopathological evaluation of all missed or incomplete abortion is to be done. And classically, we can see the placenta and the fetal and embryonic tissues. The management is according to the cause: threatened abortion, bed rest, paracetamol, progesterone support, HCG therapy. In missed abortion, if uterine size is less than 12 weeks, then medical or suction evacuation, and in inevitable abortion, typically it is treated surgically with suction DNC. Management of ectopic pregnancy, yes, the medical management by methotrexate if the sac size is less, and the preferred method, the other management is laparoscopy if the patient is hemodynamically stable. Salpingectomy is usually done if we see the ruptured tube followed by but it has been seen that we get a similar number of uterine pregnancy in further life of the patient, and it has a shorter operative time. In hydatiform mole, we all know evacuating the uterus followed by series of HCG levels and monitor for the thecal lutein cyst after the evacuation. Thank you for the patient hearing.
Thank you, ma'am, for throwing light on such a sensitive topic. Once there is spotting in early trimester, patient is also scared and doctor is also scared because prognosis is always guarded.
Yes.
Thank you for elaborating this topic so nicely. Thank you, ma'am.
Thank you.
We request our chairpersons to felicitate Dr. Manisha Khade, madam. She wants to go. So felicitation of Dr. Manisha Khade, madam, by the hands of Dr. Gundewar, madam. Other chairpersons, please join, ma'am. Thank you so much. We have an audio-visual presentation by our founder, Dr. Vandana Gandhi madam, who is giving her presentation from Canada. We request Dr. Bharat Pawar sir to introduce Dr. Vandana Gandhi madam. Sarji Rao sir.
I am very glad to introduce my mentor, Dr. Vandana Gandhi. She is MD DGO and she had done diploma in pelvic endoscopy from Germany. She is founder of Female Fetus Protection and Save Girls Counseling Center, Akluz, since 1992. She is founder of AOGS in 2013. And she was president of AOGS in 2018-19. She was member of Contraception and Family Planning Committee AMOGS in 2018 and 20. She was active under Safe Motherhood and Anemia Challengeout program of FOXY in 2006 and 8. And she has innovated a program that is Anemia Prophylaxis Model, which has been accepted by Satara district, and recently it is accepted by Solapur district also, and it is role model under UNICEF support in 2006, and which has been implemented for 1.5 lakh school girls. So, Madam, dais is yours.
Give me a second. If my screen is seen.
Yes, ma'am. Can you please put it on the slideshow mode?
Yeah. Is it seen?
Yes, ma'am. Please go on.
Okay. Very good morning to you all. after an hectic and entertaining Barkha night. Thank you organizers for this opportunity. Today I'm sharing the concepts about communication skills in obstetrics. Dr. William Osler says 90% of diagnosis comes from the history. The fact being, my doctor doesn't have time for me. Pardon? Something you said?
No, ma'am.
Okay. My doctor does not have time for me. My doctor does not listen to me. All he or she does are many tests. These are the general comments. Also, the healthcare system is imploding because of spiraling cost for care and dissatisfied patients. So, is there any solution? There is growing evidence that the key to success in patient's care is a good patient-doctor relationship. Communication skills are essential as most of our time is spent with patients talking to them and listening to their history and problems. The intimate nature of both the patient's condition and the examination requires that an obstetrician like us should be able to put the patients at ease while asking highly personal questions. Because obstetrics is one of the higher risk clinical area from liability and patient safety perspective, it is essential to implement a communication protocol to standardize the information exchange among obstetrics caregivers. In practice, what do our patients tell us? When we ask them in local language, पहिली डिलिव्हरी नॉर्मल आहे का सीझर? सीझर झालंय. काय अडचण होती? माहित नाही. डॉक्टर म्हणाले सीझर करावे लागेल. Most of our patients don't know what the problem was, and it is actually a thing they must know. Doctor-patient communication is a major component of the process of healthcare, and doctors are in a unique position of respect and power. The art of medicine consists in amusing the patient while nature cures the disease. Well said by Voltaire. So we need to give reassurance and support. Medicine is an art, magic and creativity of which lies in the interpersonal bond that is doctor-patient relationship. Willingness for the best outcome equalizes assured success of doctor. He needs to have or acquire artistic, personal and academic skills, education and experience, ability to correlate knowledge to facts and problems. Tongue and Group reported that 75% of the orthopedic surgeons who were surveyed believed that they communicated satisfactorily with their patients. However, only 21% of the patients reported satisfactory communication with their doctors. So patient surveys have consistently shown that they want better communication with their doctors. Effective doctor-patient communication is a central clinical function in building a therapeutic doctor-patient relationship, which is the heart and art of medicine. Much of the patient dissatisfaction and many complaints are due to breakdown in this relationship. The game over is over. However, many doctors tend to overestimate their ability in communication. So what we need is a holistic approach which involves considerations beyond treating a disease. It warrants several skills in a doctor along with their technical expertise. Studies have shown that good communication skill in a doctor improves patients' compliance and overall satisfaction. Communication skill is an ability to use the language that is receptive and to express the information. Effective communication skill are a critical element in your career and personal life too. Communication medium have come a long way since the Sir Alexander Graham Bell's original telephone was invented. Most common ways to communicate are speaking, writing, visual image and body language. As a surgeon, we are concerned for the direct communication by verbal, written, where it helps for the consent taking and simplifies the complex concepts and ideas. And third is the gesture or non-verbal, never go casual. We must plan and learn to present normal. Key to avoid litigation is effective communication, which is itself a key for good doctor and patient bonding. Communication is an aspect of taking care, and of course, we are the caretakers. So, effective communication leads to avoid litigations and productive relationship. So, how to achieve this? If a doctor effectively uses empathy, he gains trust and confidence of the patient. It creates bond of friendship. These patients develop full faith in the ability and the sincerity of the doctor. Then only they tend to accept the unfavorable outcome without any ill feelings and develop no malice towards the doctor. So we ensure acceptance and compliance from the patient. Most complaints about doctors are related to issues of communication, not their clinical competency. As such, our patients don't exactly know how competent we are, but our miscommunication can go in vain every effort. Patients want doctors who can skillfully diagnose and treat their sickness as well as communicate with them effectively. So medical legal cases begin mainly with breakdown of the bond of faith and doctor-patient relationship. To prevent medical crisis, communication skill is the mainstay. Considering one case scenario in obstetrics, a day-to-day practice, we often witness a registered full-term primary comes with leaking meconium at 2 to 3 centimeter first stage of labor with head high floating. Indication is of course clear and we know the fact. But immediately on admission, if we say that we need to do a C-section and we can't wait, the relatives interpret first that you don't wish even for some time to give a fair trial of vaginal delivery. They simply feel it as a monetary issue, so here starts the dispute. The offense is simply lack of rapport. So, gap of timely and proper communication for counseling is the problem which we should overcome. We can call them in our cabin and talk freely with some audiovisual help. At the end of my talk, I am going to show you a 1-minute video which can be helpful for good counseling. There are many barriers to good communication in the doctor-patient relationship, such as patient's anxiety and fear, doctor's burden of work, fear of litigation, fear of physical or verbal abuse, and unrealistic expectations from patients. It has been observed that communication skills tend to decline as medical students progress through their medical education. And over the time, doctors tend to lose their focus on holistic patient care. Also, the emotional and physical brutality of medical training, particularly during internship and residency, suppresses the empathy, substitutes the techniques and procedures for talk, and may even result in derision of the patients. So, to avoid personal barriers in communications, if it is a superior, there may be attitude of superiority that should be avoided. The lack of time should be overcome. If it is subordinates, there is unwillingness to communicate. All these problems should be overcome by a proper planning. Effect of failure to communicate. A patient or his family's questions when goes unanswered, the unanswered question becomes an anxiety. The aggravation becomes anger, and the anger goes looking for an advocate or antisocial worker and media person. So never ever directly declare the decision. Instead, yourself call all relatives in your cabin instead of involving your staff in the serious case discussion. Discuss about the facts and counsel, though in brief. Use digital media like your personal computer, smartphones, Google Images or video clips to explain what is the problem with the patient. Basic principles of communication, we need to create an open and honest communication in any situation. Each person's communication style is a unique combination of their own innate skills, and those learned formally and through experience. Medical education being so vast, even in 5 years, we could hardly learn these skills. But need has arisen in last decades as increasing cesarean rate, increasing disputes, media publicity, medical legal cases, and even physical attacks on us and hospitals are increasing. So, We need to be ready with all weapons, and good communication is a safe weapon. So keep ice on head and sugar on tongue. That is the best policy. Communication skills in healthcare and nursing tips. We know we have to communicate verbally, so be brief and specific, communicate timely and easy for listener to understand. Be cautious about tone of our voice, body posture, facial expressions, etc. Body language too speaks a lot. Listening. Listening is the least taught in four walls of medical schools, and even our primary and secondary schools we were taught reading, writing and speaking, never about listening. Better learn the difference between mere hearing and listening. Listening is an art and skill, not to neglect. A common complaint from patients is that doctors just do not listen. We have got to listen to what patient is trying to ask or trying to say. Attentiveness is the basic requirement of two-way transfer of information. Communication is in fact a two-way process, and doctor's job is to communicate in simple language the complexities of disease and treatment. Active listening. Avoid barriers. Don't jump to conclusions. Premature response before the person has done speaking should be avoided. Arguing, debating, misinterpretation. Even if they have complaints, listen carefully. Give time so that they become calm. So active listening is a model for respect and understanding. Show them that you are listening. We have to listen to his or her concern, not just the words. Good listening helps to assess the intellectual, emotional, social, and financial capacity of the patient, and importantly, the inclination of the patient or relatives for medico-legal mischiefs if they are in planning. Our gesture, how to greet her, welcome your patient with a smile. It helps to remove the anxiety and respectful fear about us. Just welcome them in the local language. Say, ye Gayatri, bas, kashi आहेस? या कुलकर्णी, बसा. These are the simple words, but they
Sorry
create
to say,
a
ma'am,
friendly.
last 2 minutes remaining.
Okay. Distractions. We have to avoid and say no to distractions. Avoid distractions by phone calls, especially by mobiles, which we lose our easiness and flawless of the work. Mobiles really have made us immobile. Either keep your phones on silent mode or give them the message that I am busy. Eye contact. Always make eye contact before you start talking. You can do one job at a time. Eye contact is important. Notes taking. When you are writing, it shows that you are not listening. Handling the anger. Dealing with angry or upset patient, it is best to let him speak and get his anger out of the system. At this stage, silence by doctor and his team can diffuse the emotionally aroused patient. What we need at that moment is to cool down. Calming down is the apprehensive relatives is a skill. So be always cool. Get trained in soft skills. Probably next CME is needed to teach soft skills to the medical students as well as practicing doctors. Your presentation in your cabin, always be fresh looking. Patients are ill and in trouble. They feel comfort with your fresh looks. You are icon of health. Look healthy, take effort as a daily life in fresh and healthy appearance. Well dressed, it is must. Preferably in white apron. Doctors are considered cream of intelligence of society. They are always taken for granted. White apron is a status symbol of responsible, reliable and confident doctor. Better never avoid. Event memory. You have scolded your staff in front of patient for silly behavior. Your patient remembers that. Never leave these such ugly footprints on patient's memory pad. Conversation matters. First, listen to patient. They have come to your doorstep with something to share. So listen, think, and then talk. Don't be busy on mobile in front of patient. They feel neglected. So the take-home message is, involve both your style and content, increase patient involvement, train yourself for improvised communication skill. Breaking bad news, do it yourself. Miscommunication has serious implications. It may hinder patient's understanding and expectations from treatment. Why to learn the ways to polish your communication skills? Because patient satisfaction is directly proportional to communication skills. Patient satisfaction is the key to get optimum, comfortable, and stress-free working environment as well as job satisfaction. Monetary gain is a byproduct. An American Academy of Orthopedic Surgeons vice president said, Terry Kennel, the patient will never care how much you know, but until they know how much you care. So it is recommended that formal training in communication skill in medical curriculum and training of practicing doctors in the form of CMEs is must. Accept
Ma'am, we'll
this
have to
need
end the
of time.
topic. Yes.
I'm finished with the talk. Just I want to share 1 minute video which will be useful for communication. By that video, I end with my talk. We can use such information videos, especially when in obstetrics we have to explain the problem of labor. I hope I have completed my task, and I wish all the doctors a very nice communication and a nice practice too. Thank you.
Thank you, madam, for nicely elaborating this topic of communication skills. So many breakup between patient and doctor are because of lack of communication. So we should improve our communication skill because knowledge and expertise in surgery is as important as the communication skill. Thank you.
Thank you all.
Ma'am, considering this problem, NMC has introduced one ATCOM module in MBBS syllabus, new syllabus, that is attitude and communication. So medical teachers, they are supposed to spend 4 hours teaching MBBS student how to communicate with the patients, how to tell any bad news to the patient. So this is included into recent syllabus right now, since 2020.
Thank you. That is a nice, good news.
Thank you so much, ma'am. We invite the next speaker,
Dr. Anil Sakre. He is an assistant professor at GMC Nanded for 11 years, a graduate and postgraduate teacher. He has conducted many live surgical workshops at national and international conferences. He has many scientific publications to his name, has contributed in Williams' Book of Obstetrics and Operative Obstetrics. He has operated more than 7,000 NDVH cases, which is really creditable, and an organizing secretary of AMOGS 2012 and 17 Nanded. I was one of the faculties at that time and received many awards for his social service and field of.
Introduction. Today we are going to talk on a topic of which is most of us might be having experienced this condition, but we might not have diagnosed it. That is shoulder dystocia, and the objective of this talk is to know what is meant by shoulder dystocia, what's its incidence, its consequences, what are the risk factors, and the most important part is the management. The presentation is of level B, level C evidence because shoulder dystocia is such a accidental condition. We hardly have any level A evidence to recommend anything for it. So all the recommendations in these presentations are of level B or level C recommendations. So what is meant by shoulder dystocia? By definition, and there are various definitions for to define it, and that's why to diagnose this condition varies from area to area, country to country. But the Williams textbook said that head to body delivery time more than 60 seconds due to impaction of the shoulder against the symphysis pubis can be labeled as a shoulder dystocia. The RCOG in 2005 defined that use of any of obstetric maneuver to release the shoulder after gentle downward traction has failed. that can be labeled as a shoulder dystocia. So what is the mean time for normal delivery after delivering the head and to deliver the shoulder? It is just ranging from 4 seconds to 24 seconds. And the mean time of delivery with dystocia, with applying some maneuvers, it is ranging from 60 seconds to 79 seconds. So, according to the maneuvers, shoulder dystocia is graded, it has been graded by some authors. A mild shoulder dystocia is where simple maneuvers like macrobots or suprapubic pressure delivers the impacted shoulder. Shoulder dystocia can be called as a moderate one when we need to apply the enter maneuvers like Rubin's or corkscrew maneuvers to deliver the impacted shoulder. A severe degree of shoulder dystocia is when we have to fracture the clavicle or humerus to deliberately deliver the shoulder, and the undeliverable is the 4th grade where we have to do cephalic replacement and abdominal rescue of the baby. So according to these grades we can describe the shoulder dystocia. So what is incidence? It is 0.6 to 1.4%, and as the definition changes, the incidence rates also changes. Nowadays the incidence is increasing because of 2 reasons. One is the delivering a healthy babies is rising one, and the second thing is that the documentation is going on properly in many medical institutions to diagnose this condition. So if a obstetrician is saying that I have not seen in a case of shoulder dystocia, it means that obstetrician have missed the diagnosis of that condition. So if the incidence is near about 1% overall, so that obstetrician might have come many cases of shoulder dystocia that might be of a mild grade where simple maneuvers might have delivered the impacted shoulder. So how to recognize shoulder dystocia? It is very simple, because shoulder dystocia is unpredictable. It is really an unpredictable condition, but it can be diagnosed very easily, and few warning signs as that if there is a history of prolonged first and second stage, you may suspect that it might be a shoulder dystocia. But the most important sign is head bobbling, that is turtle sign. And you can see in this video how the head try to go inside the vaginal canal after delivering. That is called turtle sign. What turtle does to its head, that after drawing out and it tries to go in back. So it is, this turtle sign is the diagnostic to often shoulder dystocia. And the third sign is that even a minimal, we always give a minimal downward traction to deliver the shoulder, and if it fails to deliver the shoulder, that is also in a diagnosis of shoulder dystocia. So why it is important to diagnose this condition? Because it is a serious obstetric emergency. It increases maternal morbidity and it increases fetal morbidity and mortality. So to diagnose it properly is very important. So what are the maternal impacts? That it causes PPH in 11% cases, that might be of an atonic or might be a traumatic one. It may increase the incidence of peripheral infections. Symphyseal diastasis, though rare, but it might be there, and very rarely uterine rupture. Particularly in those cases, we try to do an examinalis maneuver. So what is the fetal impact of this shoulder dystocia? That is fetal injuries, the brachial plexus injuries, the incidence is of almost 4 to 16%, quite high, and the fracture of clavicle and humerus. And the more serious impacts on fetus are neurological damage if you get late in delivering the baby, and sometimes death. So brachial plexus injury is the major setback of this serious condition, and it is observed in 60% of cases. Why it happens? That due to downward traction on the neck, most important fetal effect is that it stretches the brachial plexus, and few MRI scans have shown that these brachial plexus, they may mimic like strings of some musical instruments. So this causes this brachial plexus injury. It might be an herbs or clump case, but it is the most common cause for litigation in the court of a shoulder dystocia. But the good news is that the 80% of cases with this brachial plexus, they may get resolution or they may get reward. But what about 20% of cases? And these 20% of cases have a permanent disability, and there is no any method that which baby may come under this 20%. We don't have any prediction score or prediction value to determine that this baby is at high risk that she may have a brachial plexus injury. The risk factor to predict shoulder dystocia are there. The maternal, if there is a history of previous shoulder dystocia, there are 25% chances that mother may experience shoulder dystocia in forthcoming labor. Obesity, multiple parity, diabetes mellitus is one of the most important high risk factor for shoulder dystocia because of macrosomic babies. Short stature, abnormal pelvic anatomy. These are the maternal factors, and the fetal factors are macrosomia, post-date babies, intrauterine fetal death, instrumental delivery. Even with an anencephaly baby, a small baby, that we may experience a shoulder dystocia because some anatomical disproportion between fetal head and shoulder. So can it be prevented? No. But there is a room for prediction and anticipation. So we can't prevent shoulder dystocia, but there is some possibility that we can predict or anticipate it. So prevention of shoulder dystocia with cesarean section prior to labor should only be considered under unusual circumstances. Some may say that this case is of I am predicting a shoulder dystocia and we will do a cesarean section. What will happen that we have to perform 1000 cesarean section to prevent one case of shoulder dystocia. So we have to perform more than 1000 cesarean section for the prevention of one case of cesarean section for shoulder dystocia. So the indications for elective cesarean sections are where the fetal weight is in diabetic mother is more than 4250 grams. Expected fetal weight in non-diabetic mother is more than 5000 grams. If there is a history of prior shoulder dystocia with injury to the infant, these are the indications where you can do an elective cesarean sections. Also, the good glycemic control of weight gain, and identifying the risk factors are the other factors where we can predict the shoulder dystocia. But more than 50% of shoulder dystocia cases occur with average weight babies less than 4 kg. So we always be ready. We can't predict. It is unpredictable and it is unpreventable. So only thing what we have, once it recognized, act quite nicely to deliver the shoulder. So the diagnosis is very easy. The turtle sign, and try few don'ts. Do not ask patient to push. Do not apply fundal pressure and do not panic. Regarding fundal pressure is the most important don'ts. It must be remembered that strong fundal pressure applied by assistant at wrong time may result even in further impaction of shoulder dystocia. Fundal pressure in absence of other maneuvers. That means you can apply fundal pressure gentle when you are applying the maneuvers. Otherwise you should not apply a fundal pressure. So management is the most important part. The most prepare the patient, educate, involve the patient ahead of delivery, declutter the room, involve the senior person, empty the bladder, stay calm, and always remember the helper in cases of shoulder dystocia. So what is this HELPERR? We will see. Helper for shoulder dystocia is H, call for help. Call for help. We have a bell in our labor room for calling for help for any emergency situation, and in such situation this bell is very useful. E, evaluate the episiotomy. If you have not given the episiotomy, give the episiotomy, or if it is a small one, increase the length of episiotomy. L, legs, that is McRoberts maneuver. P, suprapubic pressure. E, enter rotational maneuvers. R, remove the posterior arm. And second R is the roll of the patient to her hands and knees. These are all the things which you have to do in case of shoulder dystocia. When to do and what to do. Each step should last only for 30 to 60 seconds. That is for total of 3 to 5 minutes, all maneuvers. And no indication that any of these maneuvers is superior. They represent a valuable tool to help clinician take effective steps to relieve impacted shoulder. So it is not like that the helper, you should go HELPER. You can take L first, then R first, and then. There is no advantage of taking this step first, this step second. But the helper is arranged in a such a way that the easy steps are taken first and the difficult steps are taken later. So benefit that it increases the size of bony pelvis, decrease biacromial diameter, change the relation of biacromial diameter within the bony pelvis. So call for help, and the most important that you have to call for help when you need, but how the person whom you are asking to come for help, that he can understand that you want help. So you should have a shoulder dystocia drill at your labor rooms. It is not when the situation arises, it should be in a drill, and we have conducted many drills at GMC Nanded to mimic a condition of shoulder dystocia. That will be easy when actual situation will be there, and the proper documentation is very important. When the head is delivered, what maneuvers you have done for medical legal issues. Evaluate for the episiotomy, not for all cases, but before delivery, helps the generous episiotomy helps when you are applying the maneuvers. Mac Roberts maneuver, that is legs. L for legs, and that is Mac Roberts maneuver. This is the most safe, simple, effective technique to disimpact the shoulder. You need two assistants and place the legs over mother's abdomen. What it does that this flexion, sudden flexion will move the symphysis pubis to the maternal head, and which frees the impacted shoulder, and it also straighten the sacrum. Third thing it does that it reduces the inclination angle of bony pelvis, and fourth thing is that it reduces the required force to apply on the fetal head. So these are the advantages of Mac Roberts maneuver. Suprapubic pressure, while giving the suprapubic pressure, see where is the anterior shoulder and apply the suprapubic pressure like we are giving the CPR like, and you have to apply posterior to the impacted shoulder, and you have to give a gentle traction on the head to deliver the impacted shoulder. The other two internal maneuvers are wood screw and Rubin's maneuver. Wood screw is the maneuver where you have to introduce your hand posteriorly and rotate the posterior shoulder in 180 degrees like wood screw, so that it will disimpact the shoulder and you can deliver the baby. So this maneuver is quite easy internal maneuver comparing to all other maneuvers, and that's why it has to be followed first. The other maneuvers are Rubin's 1, we are rocking the fetal shoulder from side to side, and the Rubin's 2, where you reach the most easily shoulder, push it forward, decrease the which decreases the biacromial diameter and release the impacted shoulder. So what to do if all maneuvers fail? We can try the reverse wood screw or a posterior, you can deliver the posterior shoulder from behind. And the best maneuver is that remove the posterior arm. You have to gently sweep the arm over the fetus chest and deliver the posterior arm, and move the shoulder girder in any of the oblique diameter of the pelvis, so that it will disimpact the shoulder and you can deliver the baby. This was the last resort, and if still the baby is not delivered, roll the patient in knee chest position and apply all maneuvers in this position. And this position increases the obstetric conjugate by 1.5 centimeter, and even in gravity and movement itself help in delivering the baby. It might be disorienting for the unfamiliar obstetrician, this position, but it really helps. It really helps. So all fails, if at all fails, what the resort? Deliberate do the clavicular fracture, other is Zavanelli's maneuver, symphysiotomy, clitotomy, or abdominal surgery plus hysterotomy. Zavanelli's maneuver is many times tried, but it is difficult to reposit the fetal head in the vagina. You have to use tocolysis and replace the head. Just I am finishing. So, last slide. So take home message, shoulder dystocia is unpredictable and most occur in patients with no risk factors. Always be ready and calm while dealing with shoulder dystocia. Know your helper, HELPERR. Permanent fetal injury may be prevented by limiting non-axial traction on fetal head. Mock drill in labor rooms proved to be helpful in need of action. Documentation and debriefing after shoulder dystocia is an essential part of good patient care. Now we will move to practice, please. Thank you.
Thank you so much, sir. With
Thank you, Dr. Sakre, for such an excellent presentation. The point I liked was the mock drill, because we should be prepared for the worst. No obstetrician will like to have a shoulder dystocia case in her labor room, but then we should be prepared for the worst. Thank you.
I request all the speakers to please felicitate Dr. Sakre, sir. I request Dr. Savita Gujar, madam, to felicitate all the chairpersons.
Hello. The next, there will be panel discussion, medical legal issues in OBGYN practice. Speakers would be Dr. M.C. Patel sir, Dr. Girish Kumthekar sir, and moderators, panelists will be Dr. Alka Kuthe ma'am, Mandar Kanbekar sir, Kanchan Jadhav madam, Indranil Jadhav, Dr. Varshal Hade madam, Dr. Meena Gunjutikar madam, Dr. Ashutosh Bahulekar ma'am, sir, Dr. Ujwala Bardapurkar ma'am.
I'm so sorry.
ठीक कौन है नहीं ठीक बस तीन उधर तीन उधर भी आ जा सकते हैं लोग भी वहाँ जा सकते हैं अगर सबको ये करना है दोनों को वहाँ जाना है तो भी ठीक है नहीं खाली है कुर्सियाँ भी
सगळे तिकडेच बसतात.
ये अच्छा है कि सबका हमारा ध्यान भी रहे सबका. Should we start?
Yes, sir, we please start with the session.
Yes, we can start.
Yes.
We can start.
Screen. So, myself, Dr. M.C. Patel from Ahmedabad and Girish Kumthekar from Solapur. We are moderating panel today, and let us discuss very interesting cases which we see in our day-to-day practice. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. So warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank organizers on behalf of Girish and myself, Dr. Madan, Dr. Vinod, and all the team of organizing this Barkha 2023. So, before I go, only 1 minute video with my request for my candidature for post of President Foxy this year 2024. Awaj.
नहीं है.
Serving Foxy for years together on this auspicious day with folded hands and down head. I seek your guidance, blessings and support to endorse my candidature for the post of Foxy President year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना. So please endorse my candidature for the post of President Foxy election year 2024. So warm welcome all the panelists, and let us see very interesting situation one by one. I never learned from someone who agreed with me, and this is very important. If two people agree on everything, then one of them is not required. But let us see for today's panelists how they differ with each other at the time of discussion. So medical legal issues in OBGYN practice. So first question, is it worth discussing? Any panelist can take. In any conference, in any CME, any workshop, now medical legal issues a part is taken for discussion. So is it worth discussing?
Yes,
Yes, why?
Because nowadays the thing is like, कि doctor should save himself and then he think of saving patient. Because परिस्थिति ऐसी है कि मैं ही था जो बच के साहिल तक आ गया. समुद्र ने बहुत मौके दिए थे डूब के मरने के. तो in obstetric practice there are so many slippery things where we definitely have to need. We don't do anything intentionally, but still we need to learn, educate ourselves about the legal things and take care of all the medical legal allegations and things.
I'll just interpret. Friends, this just started, as you know, when we were included in and we came under the purview of Consumer Protection Act. All these things started, and practice and medical legal aspects and defense of medicine, everything started. When the things started, there were hardly 5 to 10 medical legal consultants all over India, and now there are hundreds or thousands of them. So you are at comfort, and almost every conference, medical legal platform is given, some platform is given for discussion, but that's a good thing because legal awareness is increasing. So it is always necessary to discuss medical legal issues in every conference of any specialty, particularly more in OBGYN.
And medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. As far as statistics of litigations are concerned, during my medical legal practice, if we see gynecologists in a driving seat as far as number of litigations are concerned, and that is why it is very much needed to discuss this type of situation, not to end up into litigation, and if at all we ended into, then how to get rid of this is the motto for today's discussion. Let us see very interesting case scenario. Patient undergoing cesarean section gives a provisional consent for tubal ligation along with cesarean section. Many a time we see, let's say for example, if she is having 2 female children prior, and this time if it is male, then you please go for female sterilization operation. That way she gives conditional consent as far as female sterilization operation is concerned. However, when delivery occurred, baby was tachypnic, so patient was under regional anesthesia. Pediatrician and yourself, that gynecologist, appraise her of situation, decide not to go ahead with tubal ligation. Many a time we also have to take such type of decision. 1 year later, she became pregnant again, goes for termination of pregnancy outside, and she had a uterine perforation, bleeds torrentially and landed into hysterectomy, and a case is put up against gynecologist. So allegation was, I had already signed a document for tubal ligation along with cesarean section, but doctor didn't do it, and that is why this pregnancy happened, and I had to go for termination, and there was perforation. So what is the comment from panelists one by one? In this type of cases, what could be the outcome and what should be our precaution at the time of taking this type of case? Anybody can take.
When we are cancelling tubectomy, we are supposed to take a second written consent. That patient was given already prior consent for tubectomy, and we are cancelling tubectomy for the same reason, and patient is advised to use another methods of contraception, or patient is supposed to come for tubal ligation after 6 weeks or 6 months, either for perpetual tubectomy or laparoscopic tubectomy. If it is on the paper, patient cannot sue you. If it is not written on the paper, and if you have taken verbal consent, you are supposed to face medical music. Legal music.
Yes.
I'll
Anybody
clarify
have
one
to
thing. Whatever you do think, don't undergo an assumption that patient cannot sue you. Patient can sue anytime. Yeah, you can sue anytime.
So we have to go, we have to send somebody outside the OT and again get the written consent of husband and in-laws, for we are not doing the tubal ligation at the same time, so that we are safe.
Actually, what doctor said is correct. For the sake of baby's interest, that time we did not conduct that TL operation. But somebody should communicate with the patient afterwards and the relatives then only. And again, contraception advice, written advice on the OPD discharge card, so that she will be prevented from further pregnancy.
Yes.
After the baby grows 6 months or after vaccination, primary vaccination, then TL can be done.
It's fine, but my contention in this type of situation is, patient has given a consent for female sterilization operation, and you deferred not to go for sterilization operation. In law, in any case, it is a common dictum. Whatever you do, you should be in a position to justify it. So if you defer not to go for sterilization operation, then you should be in a position to prove in court of law why you took that decision. Then you are out of problem. So there are some point in issue in this type of situation.
Sir,
Yes.
I think there is no word like provisional consent. Consent has to be with all those characteristics.
Agreed. So post-operative counseling is very important in this type of situation. So explain why tubal ligation was not done. Advise tubal ligation afterwards also. It is not an emergency. Patient is not going to be pregnant next day only. So it is not an emergency. You can advise to go for ligation afterwards also. Advise to adopt any other method of contraception, just rightly mentioned by one of our learned panelists. Mention everything in your discharge card. Whenever you discharge patient, all the details you have to mention, why you didn't go for sterilization operation. If patient doesn't follow instruction, then it becomes a contributory negligence on part of patient. Because if you have advised that we have not gone for sterilization operation, and you are advised to adopt any contraceptive measure, and patient doesn't follow, and she becomes pregnant, you are out of problem in this type of situation. If complication of MTP occurred At the second time when she became pregnant, she had been to some gynecologist for termination and perforation occurred. But is that complication of MTP directly related to action of first doctor? No, not at all. So in this type of situation, only one. So it is very clear what is negligence. There are 4 ingredients of negligence. First, legal duty. Whenever you accept any patient to treat, your legal duty starts from that very point of time. Breach of that duty due to your inadequate service, if it is a breach of that legal duty. One more. Number 3, damage occurred by patient. And number 4, is action of doctor directly and proximate to cause that very damage. So in this particular case, not doing tubal ligation was not direct and proximate reason to go for perforation during MTP. So in this situation, doctor is totally out of problem. But in this type of situation, whenever you are facing litigation, you should present your case before honorable court in a very efficient manner. So this is the carry home message.
Yeah.
Post-operative counseling, proper instruction in discharge card, it is very much must.
Sir, I would like to add,
Yes.
sir, in this. Now the patient demanded tubectomy and you did not do it, fine. But just, this is a warning, just don't go only because patient demanded it. This brings us under our review, the cesarean on demand, or a patient says that anyway you are doing hysterectomy to appendicectomy at the same time, or if the patient is undergoing some lap cholecystectomy and do hysterectomy at the same time. So don't do just patient demands it. Ultimately, you have to put your clinical experience, whether it is actually needed, whether things should be mixed up or not. And this is a warning for cesarean on demand also, because just patient wants a muhurta cesarean on demand at the such and such date, and the things are not really good, and if you do it, that will amount to negligence. Thank you.
So on demand cesarean section, just before 3 days, there had a phone call from one gynecologist from Jamnagar in Gujarat to me. She did cesarean section 1 year prior on demand. At that time, pregnancy was only 30 weeks. But her father-in-law was Vastu Shastra, Jyotish, etc. And he not only demanded, but he forced to go for cesarean section. He was reluctant not to go for, and he fired. Why you are not taking our request in a positive way, and why you are not going to go for cesarean section? I will change gynecology. And she did that cesarean section. And just 3 days prior, there was a phone call. Now that lady has filed a case against gynecologist, against my will. Only on pressure of my father-in-law, she went with cesarean section, and preterm baby was delivered. And preterm baby was not mentally sound. So in this type of situation, on-demand cesarean section also, we should be very alert, we should be very careful. If at all we are going to entertain them, then also we should be in a position to justify in court of law. And if you deny, then also we should be in a position to justify our decision in court of law.
That's perfect. That's perfect, sir. So the second case we are discussing is going to discuss a 1.5 months amenorrhea. Urinary pregnancy test is positive. Obstetrician advised investigation is ultrasound. They show the prescription to the front desk. Receptionist advises her to go for a health checkup package that would cover all investigations advised. Concession rate. She opted health checkup package. Unfortunately, health package had chest X-ray also, and she did it as well. Now, after knowing X-ray should not have been done, and after proper counseling, she wants to go for MTP. She wants clinic to pay for MTP charges. Clinic refuses to take any responsibility. Obstetrician also refused to pay as he was nowhere involved. The patient complains against the staff who advised her health package. Now, this is a typical scenario. A package has been done, and X-ray has been inadvertently X-ray has been taken. Now, what will be your advice to the patient, and what will be possibility fallouts of this case? A panel.
Or simple question: who is negligent?
Who is negligent?
Patient, doctor, receptionist, hospital. Very interesting situation.
Who is to be held neck by neck?
I would say it's moral responsibility of the doctor, because staff, they work
I
under
don't
us,
agree
and what
with ma'am.
staff does is directly, indirectly moral responsibility of the treating doctor.
But madam,
In law, morals don't take precedence over evidence.
But doctor advised to go for certain investigation, he prescribed in case paper. When patient came out from consulting room, receptionist advised her to go for package. And
See,
she
again I would say-
only one.
Sir, again I would say कि it was doctor's responsibility because patient was of doctor.
Please listen me. So, patient opted advice of receptionist. How doctor will be responsible in that? She didn't follow instruction of doctor.
Sir, receptionist is there because of doctor.
Say for example, if it is a corporate hospital and doctor is visiting gynecologist only, in this situation, is doctor responsible for act of receptionist?
Sir, when doctor advises health checkup, that time he must be learn that what I am advised and what is included in that health checkup. If doctor knows she is pregnant and blindly is advising health checkup which includes X-ray.
No. He has written everything. Which investigations she has to undergo. She has gynecologist has written everything. But gynecologist didn't advise X-ray chest. The gynecologist didn't advise to go for package. This advice was only on part of receptionist, and that patient opted that advice. Yes.
I would like to throw some light on this case. If it is a private hospital and that receptionist is working under the... If it is a private hospital and the receptionist is working for the doctor, then it's doctor's responsibility, because whatever action has been done by the receptionist, that receptionist is not trained by the doctor. If it is a multi-speciality hospital, doctor is exempted because he has not advised. The hospital management is supposed to train the receptionist, so that blame goes to the hospital management.
This is something called as vicarious liability.
Sir, I think one word
to add here something.
Yes, please.
I would like to say.
Yeah, actually, if the test requisition which is prescribed by the doctor and signed by the doctor includes chest X-ray, then he is under vicarious liability.
No.
If the investigation doesn't say it is chest X-ray and receptionist is advised, then if there is no sign of the doctor on the test requisition slip, I guess doctor is not responsible.
Okay. In this scenario, see, if the doctor is individual, probably doctor may be vicariously responsible, right?
So
but if he has documented all the investigations on paper or the prescription paper or his OPD paper, and in spite of that, the receptionist advises package, and package is inadvertently includes X-ray, now the responsibility will be shared. But vicarious liability is always it is the master who pays. That is the first dictum in the law. Secondly, I will put a next scenario. I will add to it. Now, okay, fine, doctor has not advised, receptionist included it, patient out for it and X-ray is undergone. Now, isn't it a duty of a radiologist to ask a young lady to ask whether she is pregnant or not? Answer my question first. Is it not a duty of a radiologist to ask the patient if she is carrying or not?
Ask for at least LMP.
Actually, sir, one word I would like to say, contract. So the contract to treat the patient is between doctor and the nurse. So whatever advice has been given in his premises, he will be indirectly liable because vicarious responsibility. Question you have asked about radiologist. It is said that whenever a woman of reproductive period approaches to anyone, he should first ask about her menstrual history properly. If she is LMP having 3 months or 2 months amenorrhea, so it becomes like shared responsibility of that also, because though he is not directly concerned, because he is undergoing such an investigation which can give rise to fetal anomaly or something adverse effect on the fetus. So I think it is like a shared responsibility in that case when radiology is also involved. But somewhere the contract is between the first doctor, treating doctor, and the patient who has entered his OPD and the premises of that consultation.
Yes, Anja, you want to add anything?
I would say कि anything which is advised, CBC, urine, whatever, actually it is signed by consulting doctor.
Oh yes, consultant has not advised X-ray chest. It is the receptionist to offer the package.
Yes.
I would like to add that if any consultant or any owner of the hospital is keeping some nursing staff in the hospital, that nursing staff should be trained. I think, according to my opinion, they should be trained. They should be told what all things to be seen, what all things should be asked, whether a patient is pregnant. As an obstetrician, you should train your nursing staff so that the responsibility is shared, so that the patient may not sue the doctor for anything. So first, where the patient reports is the receptionist. Receptionist should also know what is good, what is to be done and what should not be done.
See, suppose in this case, the case is ultimately filed. Believe me, the opposite parties will be the doctor first, hospital second, the nurse third, and even if a vice person and if a vice medical legal advisor works with the patient, radiologist, they all will be sued. And who is to share the responsibility? It will be ultimately the court's decision to how to put in the vicarious liability and share the burden. But definitely, this patient is definitely entitled to compensation, believe me. Sir, you agree with me?
Oh, yes. So, that is different story because say for example Rajiv, if I am a lawyer of that very doctor, I will save him. How? Because if at all he has gone with MTP, then there are some indications given in MTP Act 1971, and one indication is mental trauma to the patient if pregnancy is continued. Because once he came to know that X-ray chest should not be done in first trimester of pregnancy, and she opted to go for termination of pregnancy, doctor will be saved.
Sir, we can compare.
Provided Dr. MC Patel should be a legal consultant.
Sir, we can compare this case with another case having a correctable anomaly. We can say this is correctable anomaly, but still the patient insists upon MTP because it is said that ज्याच्या घरी होतं त्याला कळतं. असा जो असतो ना मेंटल ट्रॉमा वगैरे ज्याच्याकडे जी केस होते त्याला कळतं. सेम सिमिलर सिच्युएशन. इट विल नॉट गिव्ह राइज टू एनी हार्म, बट इवन द स्लाइटेस्ट 0.00001 whatever possibility, patient doesn't like to have that possibility also.
Yes. So ultimately what I want to tell the audience is that in such a case, the responsibility will be shared by almost...
Some question from the... Yes, sir. Yes. Yeah. Please identify yourself and have a question.
Yes, I am Dr. Ajit Gandhi.
Yes.
There are 2 points in your case. Number 1, the package system which hospital has adopted, has it been approved and is been examined by the management that this is to be used? Number 1. And if they have,
I'll answer.
And second point is, by outside every X-ray department, it is mandatory to put a board that if you are pregnant, you should not go for X-ray.
Yeah.
That is mandatory for every X-ray. Has the patient not seen that board?
Yeah.
Is she literate?
Yeah, I'll answer one question. When the package, if it is provided, there is never a single package, and it is a patient's discretion to opt for package or not to opt for package. Packages are offered; it's a marketing gimmick, and packages they don't need any approval of the hospital. And there is, I'll clarify, there can be separate packages for pregnant women in which X-ray will never be included. Now this is definitely a fault of the receptionist to offer her package. She shouldn't have it. But there is nothing like approved packages from the hospital. By various packages are designed and they are as a protocolized. So approved package by whom to approve? Hospital management has prepared them. So they are approved by the hospital. That's one question. And secondly, there is always a warning. In radiology, pregnant women should not come around inside, even they are not allowed to enter the radiology room also. But again, I have told you, was it not the responsibility of the radiologist to ask whether the patient of a reproductive age, it was the responsibility of the radiologist to ask whether she is pregnant or not. That is also been, there is a lapse of duty. So the take-home message in this case is...
One more thing I will involve.
Yes.
I will involve receptionist of radiologist. He should, receptionist of radiologist also, he should have confirmed whether that referral sheet is signed by doctor or receptionist.
That is it. So ultimately, I'll tell you, ultimately your point is, communication is very important in this case. It ultimately boils down to communication,
but
how to share the responsibility.
One important question, nobody has pointed out against patient. Should we expect that patient should have gone again to doctor? That she has given me his offer
According
of
to me, patient
this
should have
package.
reported back to the
Should I go with package
Yes.
or should I go with your instruction or advice which you have? So patient is equally responsible in this situation.
Though she is equally responsible, now today's scenario, patient always keep their hands up. and put all the responsibilities on the doctors saying we are paying you. It's your duty because there is medical legal something and we come under that.
But in court,
So we, being doctor, we should be, again I'm saying we should play safe and nothing expecting for the patient ki they will understand, they will come, they will ask and nothing. They will
Actually,
doctor
sir,
आम्ही ki तुम्ही a common dialogue असतो.
but in court
Actually,
of
sir,
law,
what you have said is correct. Patient is also equally should ask to doctor, sir, मुझे ये दिया गया है, should I do or not?
Yes, yes.
Because, but something happens, so what she is saying correct. जो भी होता है वो डॉक्टर के सर पे ही फोड़ा जाता है.
ठीक है.
लेकिन she should also ask.
फोड़ा जाता है, लेकिन doctor has also all the options
of course.
to go for defense. Yes. Screen. Yes. So this is also very interesting situation. Sorry, 25 years old patient, marriage life 2 years, came as an emergency case at middle of night or almost at 1 a.m. or so with her mother-in-law only. Only her mother-in-law is accompanying the patient, almost full term, with complaint of profuse bleeding per vagina. You are working at primary health center. See the situation. How will you manage? One, you have lack of facility or staff, you are working at primary health center. Can you refuse to treat? Can one select patient to treat? Any panelist can take.
We can refuse the patient as we are not having the
But even if she is bleeding profusely, straight away you will refuse not to treat?
Actually, refusing patient is a right of doctor, but not in this case because she is profusely bleeding. So we have to manage emergency first, and after managing the vitals and emergency, like we start drip, we tranexamic acid add किया जाता है, whatever management is required, we will do that. उसका pulse BP यदि low है तो उसको हम settle करेंगे. Then we can report it because it is primary health center. Suppose she is having some placental problem, anything related to fetus and mother. So in that case, if we are not able to manage at that primary health center because of lack of infrastructure facilities, we always can refer to nearer tertiary care center, but the emergency management we can't refuse. Because the Supreme Court judgment, we have to manage emergency.
If we are working at a primary health center, it is our responsibility to start first aid treatment, that is IV line, and access all the things and arrange the transfer for the patient. That is our responsibility. If it is at the private hospital and if you are writing 24 hours emergency service, then also it is our responsibility. But if you are writing only from morning to evening and no emergency duties, then we can refuse the patient if you are not open at night.
So in short, in this type of situation, even if you are working at primary health center, you will have to treat patient in that very given situation. Well, we can say stabilize the patient, and then you can refer to higher center. Because in 2014, the same question was asked in Parliament, and then Health Minister Dr. Harshvardhan had given a reply that stipulate that in case of emergency, a physician must treat patient and no physician shall arbitrarily refuse treatment to a patient except where patient is suffering from an ailment that is not within range of expectation of that treating doctor. But in later case, physician may refuse treatment, refer patient to higher center, but he will have to stabilize the patient. So we are under obligation to stabilize patient in this type of situation, and then only we can refer patient to higher center. Yes.
Sir, I would like to put in one warning signal. Now, a stabilized patient only up to the extent of what your establishment can provide. That is first barrier you should do only up to your capability of your establishment. Secondly, always document what you had done. Why? Because even in case of emergency, just to stabilize the patient, you have given some IV fluid and some injectable into that IV fluid, and the patient, some mishap happens on the way. Believe me, the whole blame will come to that injection given to the patient rather than what the patient's condition was. And then only documentation is going to save you what you did to treat and stabilize this patient at the onset, and then what precautions you took to shift that patient to a higher center.
So at the time of stabilizing patient, quick counseling with patient or relative whosoever accompanying the patient, that this is the situation, I am giving only emergency treatment, and then we have to refer patient to appropriate center. During this stabilization, if something goes wrong, please do not blame me, please do not consider me responsible. because if I do not do nothing and straightway I refer you to the higher center, anything may happen on the way of transit also, and that is why I am doing this. So this type of quick counseling is also important, because many a time this is double-edged sword. Because many times there could be allegation, why you didn't refer patient well in time and why you wasted time in stabilizing patient at your center when you were not well versed with all the facility to deal with the situation. And if you do not do, then also there will be allegation that why you didn't stabilize the patient and straightway you refer patient to the higher center. Because the same incidents happened in state of Karnataka. Patient had a convulsion, 2 to 3 seizures at home, one at the time of transfer, one on the examination table only. Doctors, when examined patient, it was blood pressure was 220 by 120, edema all over, and history of all this seizure. So straightway he told that nothing can be done here, and patient was shifted to Bengaluru. One of our Foxian friend, Dr. Prakash Mehta, was in charge of that very hospital, and patient was attended by Prakash, patient was delivered well in time, patient was saved, baby was saved, everything was fine, patient was discharged. But patient lodged complaints against that doctor working at primary health center without doing anything. Why you refer patient straightway to Bengaluru? Because at least he should have given Maxel also. So in this type of situation, at least do something to show your consent to save life of patient, and then refer patient to higher center.
And document it,
Yes, of course document it.
One line I will like to quote, sir. While referring the patient, write time, exact time when you are referring, and call for 108 ambulance, at least in government hospital. What we see many times, हमारे patient कैसे रहते हैं? We are refer the patient to tertiary care center. Sir, आप सब कुछ करो, हमें जाना ही नहीं, आप क्या ही रहना है? We explain everything day, हमारे यहाँ facility नहीं है, limited facility like the primary center. Still they say, so the timing why important is something happens in between. The patient can blame to you again, कि why didn't you refer in advance? So writing down time, call, send to ambulance, all these matters.
Sir, I think two things are most important here. First is that what all you have done for stabilization of patient should be documented on the paper. Second and foremost important, which I think, is that there should be informed consent stating that why this may have happened and what are the further complications of this, and for these reasons you have been informed that you have to be shifted to a higher center for proper treatment, and untoward situation may occur in the way also. So this second informed consent is also important in this case.
But in this situation, just Dr. Alka has mentioned, patient is not ready to get shifted to another center. Whatever you do, we are not going to go anywhere. In this type of situation, what will you do?
What will you do?
First thing I told you, sir, write down the time when you are referring, when you are send a call to ambulance.
How much
Second
time we
thing,
have?
you can inform to your
How much time?
superintendent.
10 minutes. Yes.
Sir, we are explain everything, counsel everything, inform consent that if you are shifting, you are not getting shifted as per our advice. This thing can occur with the patient. So take informed consent, again high risk consent, and write down time every time when we are refer the patient. Patient sometimes मुझे mother-in-law को पूछना है, मेरे father-in-law को पूछना है.
Got it.
हाँ, you can ask.
In this situation, if patient and patient party is not ready to give negative consent also, then what will you
We
do?
can inform to our civil surgeon, our MOH also, even our in charge of the hospital.
You are working in a private hospital, you are only owner of your hospital, and in this situation, no superintendent, nothing, what will you do?
MOH and civil surgeon, they are important for us.
Yes.
Actually, I had same situation 3 months back. There was a 4th gravida. Breach came as 8 to 9 centimeter dilated. Only one relative, and that time unfortunately my OT was not working. It was under construction. So I told them to go to hospital. So that grandfather of that patient told, we had 3 deliveries at your hospital. If you send us, I'm going to jump from 2nd floor. I didn't say anything. I took the patient, put her into an ambulance, and dropped her to another hospital. I didn't speak a single word. Next day, everything was all right.
Good. Yes.
And secondly, I would like to say that you must learn to say no. You must be frank enough to say no, I can't do this. You have to forego your ego, forego all the other aspects of the practice, and say no, I can't do this, and be very clear to the patient and document it. That's it.
Yes. Take it?
Yeah. Now the last case, maybe we have enough time to discuss this last case, where things went wrong. A couple visits gynecologist for MTP. Following consent, MTP done.
Sir, display.
नहीं डिस्प्ले होता है ना? हाँ ठीक.
Following consent MTP done in 2003, patient files complaint against in-laws for forceful abortion in 2004. Doctor called as a witness, asked for records, that is Form C, Form 1, etc. Doctor could not produce records, arrested in the court under IPC 312. That is a part of scenario. This is only a part of scenario. So, what is the precaution you can take up to this stage? Panelist, please.
Only 1 minute.
Huh.
Still, it is very interesting part.
Okay.
Yeah.
After 3 days, doctor was put behind bar in this particular situation.
Sir,
This
that I was coming next. After
this is real happened case in city of Ahmedabad only.
This is a part situation.
Yes.
What precautions you should have to this stage?
Actually, documentation plays very important role. He is asked to produce records. Form C, consent form, Form 1, opinion form. So all these documentation play very important role because nobody can do MTP of any patient without her consent. So if the patient's consent is sufficient, no need to take patient consent of husband or in-laws. So if he has taken consent of patient in Form C, Form 1, opinion form, he will be protected. So he is strong defense in MTP forms. If he follow the provisions of MTP form, anything in the court of law will not be against him.
Also put down the names of the person who accompanied her and take their signatures as
Like
witnesses.
witness, like. Yeah.
Yes. Now, the parties had compromised after 3 days. Case was withdrawn. Doctor was free from bar. Can one be prosecuted under IPC 312 and 316? Now, this is a section.
This is the important question.
Yes. Now, come on. Analyze.
Sir, MTP, as far as MTP is concerned, MTP Act is like our protection. It has superseded all these IPC sections. Previously, before MTP Act, there were IPC sections. Anything done against consent, whatever will be, under whatever indication, it would have been made doctor criminal. But at MTP Act was there.
Question on part of Girish was,
saved doctors.
Can one be prosecuted under Indian Penal Code section 312 to 316 when you go with termination of pregnancy in any patient?
Not at all, sir.
Why?
MTP Act.
And how you can be saved?
MTP Act is superseded all the IPC provisions now. MTP Act is specialized act for MTP. If the doctor, as per the MTP Act, who is a registered medical practitioner, has done the MTP Act registered center and he follows the rules and regulations of MTP Act, he will not be held responsible under 312.
Yeah, I will clarify on this. The MTP Act provides us protection for performing MTP under eligibility, authorized center and permission and within the frame of the law. Now, section 312 to 316 that Indian, their penal code, they are come under the IPC, Indian Penal Code. This law gives us protection. But how? Only when you are authorized to do it. Yes. When you are following the MTP Act, you cannot be prosecuted under 312 or 316. You cannot be. But if there is any lapse in following the procedure under MTP Act, and MTP Act stipulates one very important clause, anything done in good faith. And this good faith has tremendous importance in the eyes of courts of law. That's it.
So even today, to conclude very quickly, under Indian Penal Code 1860, voluntarily terminate pregnancy is criminal offence. Even today. Even today. But Medical Termination Pregnancy Act 1971 allows termination of pregnancy by medical doctor with specified specialization on certain ground, and under section 3 of MTP Act, this is very nicely mentioned, and it is protection of all our registered medical practitioner. Notwithstanding anything contained in Indian Penal Code, a registered medical practitioner shall not be guilty of any offence under that code or any other law for time being in force if pregnancy is terminated in accordance with provision of this act. So here word accordance is very much important. If you have terminated pregnancy in accordance with provision of MTP Act 1971, then you are out of purview of IPC section 312 to 316, but for that pregnancy should have been terminated in accordance with MTP Act. So you should practice as per provision of MTP Act only.
So don't get afraid of MTP Act or MTP Amendments Act. It is like protector to all of us.
So it means the fault only was not of the patient?
Mike, please. Mike, please.
Means in all these things, the fault of the doctor was only not getting the records with him.
Perfect. It was a lack of records which made the court to convict the doctor, to make the doctor party as a guilty under section 312. Had he well documented C form and form 1, well, he was authorized to do it. He had nothing illegal, so the court wouldn't have charged him.
So it is very important to go for consent in form C. It is very much prescribed form of opinion as per gestational size, and as far as consent is concerned, we have to take consent in form C, which is prescribed form. But that form is not informed consent, because in that form it is only mentioned, I give permission to terminate my pregnancy. So you will have to go with two consent, one informed consent and one consent in form C. And now it is available on Foxy website. We three medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared almost 30 different consent in that very situation, that very operation, how we have to go for consent. And in those consent, we have to prepare consent for termination of pregnancy also by both method, medical method and surgical method. And you have to go with both the consent, informed consent, as well as consent taken in form C. Consent taken in form C cannot replace consent to be taken in informed consent, and vice versa. If you have taken consent in informed consent as we take in any other surgery, and if you have not taken consent in form C, you may be put into trouble. So you have to go for this, and all those consent we have prepared with two major part, information part. All these points are there in that consent. We have taken page of famous case of Samira Kohli versus Prabha Manchanda, and part 2 is undertaking. So we can go with those consent, and now it is available in Marathi also. So whosoever is interested, soft copy is with me. They can contact me. I will send.
Yes. Dr. Ajit Gandhi has some question. Yes.
Well, does the investigating officer has the right to open the sealed envelope of all these forms?
Under court order only. Under the court order only. Under the court order. If he is ordered by the court to investigate the case, he is entitled to all the documents related to case.
If there is no order?
Huh?
If there is no court order?
No court order he cannot. But he can confiscate it and produce in front of the court.
But he opens it?
He has the right to confiscate the records.
If he opens it, is it a breach of investigation?
It is a breach of investigation.
What you can do for it?
You can tell the court that this is a malified investigation. That's it. But how the court takes cognizance is the court's decision. If you find that the
investigation, I was never called for any evidence, but then I was called for the papers. I produced the enclosed sealed envelope.
Yes.
He opened it.
Yes.
I want him. You don't have the right to open it. The court has to do it. But then he didn't listen to. He opened it.
You could have complained to the court.
I recorded all this in my phone.
Yes. You can complain.
Nothing has gone ahead.
The last, I think we will have to stop it here.
Yes.
Just like regarding MTP, apart from this, I would always tell my colleagues to take umpteen precautions in MTP Act while doing MTP. First, take identification of the patient, government identification of the patient. Second, always identify the accompanying person and their witness and their identification. Third, always document identification marks of the patient. Just to enumerate one very simple example, in my own case, I had terminated an MTP and I had to go as a witness. And then the prosecutor started asking me, is this the same lady? I had the documents, C form and everything. He said, is she the same lady you terminated pregnancy? I said, yes. How could you identify? I said, I could identify. But then he said, in his defense, he said, no doctor, you are wrong. The patient you terminated was her twin sister, and you can't prove that it was her or her. If at that time I had two identification marks of that patient, I would have said, yes, this patient has these identification marks, this is that patient.
An Aadhaar card. And one important situation, only 1 minute, one important situation which happened in state of Tamil Nadu only, patient gave Aadhaar card also, but it was fake one. Patient was minor and patient gave that Aadhaar card to be major, and doctor was in a trouble. So in this type of situation, whenever you attach Aadhaar card of any patient with your case paper, get that Aadhaar card attested by patient herself. Because if patient signs that document, then it is a forgery on part of patient. So you are out of problem in this type of situation. So to wind up our panel,
So I think we are started taking the Aadhaar cards signed by patient.
We are running short. Final word for panelists, only in one line, carry home message to the audience. Yes, Indranil.
Sir, just one case scenario. Beyond 24 weeks also we can do MTP.
Yes.
So one case was there. She had done 12 weeks NT scan, directly came at 26 with TGA. Now the patient wants to terminate that pregnancy. The issue is that TGA can be corrected. So like it is approval of the medical board which has to be taken prior for termination.
Naturally.
On our basis we can.
No,
you can't do it.
If pregnancy is more than 24 weeks, you have to go with opinion from medical board. And if medical board is of opinion that pregnancy can be terminated, then only you can terminate.
But still, sir, after 20, one minute, I'll clarify. Even after, sir, can I interrupt? Even after 24, just a minute, just last one. Even after 24 weeks, even if the medical board certifies termination is required, still after 24 weeks, court order will be required.
Yes.
Thank you so much, sir.
Very quickly, one by one, final word. Yes.
Documentation of everything is important in the written, and if it is not, patient is not giving in written, take a video recording of the same.
Yes, ma'am.
As soon as patient reports to the hospital, the communication, the explanation of the procedure should be done in their own language. If the patient is getting admitted, get a written informed valid consent of the patient. And if you are not treating the patient, you refer with the proper documentation, primary care should be taken of the patient. And the thing is the patient should get good counsel by the doctor.
Yes, ma'am.
All the things are told by them. Today I learned one thing from Girish. Along with consent, you should write birthmarks of the patient on the consent form or your MTP form. That will save you forever. Thank you.
So identification mark. Yes, ma'am.
Documentation and consent by all relatives, maximum relatives.
Follow the law of the land. That will protect us in the court of law.
Thank
And
you.
of course, documentation, communication and counseling. Before I hand over to our MO's expertise, I would like to request, sir, I am going to contest for Chairperson Foxy Ethics and Medical Legal Committee. I request all Vice Presidents, Chairperson, different committee chairpersons, Foxy committee chairpersons, and President Secretaries of our organization to please cast vote in my favor. I had done post-graduation in law and I am working in the committee since 20 plus years. So I require your support
on behalf of Girish and myself, I am
the-
concluding, medicine is science of uncertainty and art of probability. And people with word is the problem with the word is that intelligent people are full of doubts while stupid ones are full of confidence.
Yes.
This gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have, if you do not know how to use them, they will never be enough. There are so many provisions in Act in our favor, but if you do not know, then it won't be useful. Have some basic legal knowledge, always obtain medical legal advice whenever you are in doubt. योग करे या ना करे, लेकिन एक दूसरों का सहयोग जरूर करें. And God bless you. Have a litigation free medical practice. With regards, all the best and salute to all. Thank you very much.
Thank you everybody.
Please,
Thank you very much.
We are ready.
On behalf of our panel, request the moderator. I would like to thank you, MC Patel sir and Dr. Girish Kumtekar sir for the wonderful panel.
Yes, thank you very
so
much for Occlusive Society for giving us this opportunity in this
And big round of applause for all the panelists making this panel very interesting and vibrant.
Hands of our moderators, Dr. MC Patel sir and Dr. Girish Kumtekar sir, please
Screen
felicitate the panelists for the same.
Yes.
We are running short of time, sir, so we want a group photo immediately after the panels. Take the trophy.
Photo.
Kindly note this two vehicles MH24BL 9108 and one more MH24BL 8288 are just in the parking lot and they are interfering the traffic. So the concerned person, please take care of that. The numbers are MH24BL 8288 and MH24BL 9108. And also on occasion of Nag Panchami, we have arranged a stall for mehendis and kindly enjoy.
Yeah.
है नहीं, अगर आपकी डिस्ट्रिक्ट में बोर्ड फॉर्म हो गया है तो पेशेंट करेगा, हमें नहीं करना है. मेडिकल बॉडीज एंड
next session
विद इन 3 days.
to chair the next session we call upon Dr. Satish Doshi sir.
एडवांस नहीं होगी.
सर वो कंसेंट हम यूज कर रहे थे.
Hello. Yeah, it's working.
Our next speaker,
Chairperson. Dr. Yeah. Our next chairperson, senior most OBGY past president, Dr. Satish Doshi sir, Dr. Meghna Gulzar madam, Meghna Gugre madam from, ek minute. Dr. Meghna Gugre madam from Latur OBGY, and she is the president of Gynec Society. And the next chairperson, Dr. Vidya Tirankar madam, HOD OBGY, Solapur. Yeah. Dr. Meghna Gugre will introduce Dr. Sunita Tandolkar madam.
First of all, hearty congratulations Dr. Sunita Tandulwadkar madam for being President-elect Foxy 2025. Madam is Head of Department and Chief IVF and Endoscopy Center at Ruby Hall Clinic. She is Advisor and Consultant at D.Y. Patil IVF and Endoscopy Center as well as Solo Clinic IVF Center. She is Founder and Medical Director, Solo Stem Cells, a Stem Cell Research and Application Center. Her extraordinary achievements are India's first stem cell baby and world's first at the age of 45. And also she has founded the world's first Society of Ovarian Rejuvenation in 2023. Madam is now President-elect Foxy 2025. She is Founder President of Society of Ovarian Rejuvenation, President POGS, Chairperson, Founder and Honorary Secretary ISAR MSR, Second Vice President ISAR.
Due to some reason.
Hi Meghna, thank you so much.
Ma'am.
My most important introduction is Miss Solapur.
Okay. To continue, ma'am has 8 books, 29 publications, many keynotes, 37 orations, and also she's been faculty to many national and international conferences. She was awarded with Icon of the Year 2022 for endoscopy, Pride of Foxy in 2020, Bharat Gaurav Puraskar in 2029, Best Medical Practice in 2016 by European Medical Association, Best Citizen of India Award, Glory of India Award, Punya Shloka Ahilyabai Holkar Award in 2015, Rashtriya Gaurav Award 2015, Sarvashri Award in 2012, and Letter of Appreciation from President of India in 2012. Ma'am, please. We are eager to hear your lecture.
Need to pull in a Foxy because more than they need Foxy, Foxy needs them. I'm so glad to be here on this Amox platform. Believe me, I wanted to be physically there, but unfortunately I landed from Delhi now and by no way I could communicate. And I'm so thankful for taking me on the Zoom platform because being in Sholapur, at least on a digital platform, is my pride. I'm so glad that they accepted this, and I know we are going too late, so I will start immediately the lecture. So thank you once again.
to each and every one what I saw the brochure, and they pulled Dr. P.C. Mahapatra from Extreme East. I was talking to him on Friday when he was in Latur. That shows the popularity of this program, popularity of AMOGs, popularity of ACLUs, and popularity of the organizers. Advances in science, friends, is always for the betterment of a human being. And in science, it is important to modify and change one's idea. 4 decades ago, the way we learned FGR and today we practice FGR is totally different. It's because we got advances in the radiological field, we got advances in the neonatal field, with the babies which we could not save at 35 weeks. Today at 25 weeks we are able to save them. We were not able to modify or learn so much of a Dopplers, and that's why we used to be taking out the baby unnecessary early. Today our understanding is different, and we don't label every FGR is a fetal distress and rush to deliver. So what are the clinical updates? First is there is a paradigm shift. We all know less than 10 percentile growth is small for gestational, which may be a constitutionally small or pathologically small. Constitutionally small means there are no maternal or Doppler pathologies, while when they are growth restricted, there has to be some recognizable maternal pathology or Doppler pathology. And the idiopathic one means there is no maternal pathology, but there is an abnormal Doppler, and we are not able to correlate at present the cause of it. Common etiological factors in the given time I cannot speak about, but we should be knowing is maternal factor there may be, placental factor there may be a fetal, just the genetic anomalies in the babies, or the cord, excessive long cord, the knotting of the cord, coiling, single vessel. There may be so many other, and I will not be going into detail because time will not permit. But one thing is very important, that FGR is principally not the consequence of reduced maternal nutrition, but of the reduced maternal-fetal supply of nutrients and later for oxygen through the damaged placental vascularity. So it can be classified as early onset, less than 32 weeks, and late onset. I remember in my residency, we used to label it as a symmetrical and asymmetrical IUGR, where these terminologies are completely replaced by early onset and late onset. So what is early onset? Early onset is 0.5 to 1% incidence only, but it is more severe and more likely to be associated with Doppler abnormalities in it. Underlying placental pathology is probably the most common, that is a preeclampsia, more common, and it is easier to detect because there are series of predictable sequences which will happen in Doppler. While late onset is more in incidence, 5 to 10%, but it is usually milder, less likely to be associated with other pathologies or Doppler pathologies. And because baby is reaching near to the term, it is relatively easy for us to manage that. How do we diagnose late onset? Is the redistribution or a brain sparing effect. That is the most important thing. That is a middle cerebral artery vasodilatation, which we need to understand. Now, what is important in all FGR irrespective is you need to early predict this. And when I say early prediction, when the patient come for an ANC registration also, we used to call. Now, I always feel 2011, the Nicholas has used the word inverting the pyramid of antenatal care. But I remember when we started the ART practice, Dr. Pooja Loda, who was with me in 2007 residency, I used to call them as a preventive obstetrics. At 12 weeks only, we diagnose, we predict what will be happening to this patient just by their history, by their mode of conception or by their Doppler or a marker studies. And that is what is very important. So the history, today the residents and what we used to take a history was too different. Maybe I feel sometimes our teachers, I'm so proud to be a student of Dr. Munod, who has made our foundation very strong on which we built up. I feel very proud that you are student of VMMC because we were taught the importance of a history which is neglected. Whatever I say today to my student, even those MD reproductive medicine fellows who come and accidentally, if they get a ANC patient, just 2 minutes may, this many weeks of gestation, this is what this is, and this is our EDD. Detailed history is so damn important. With this history, you can detect the markers which are there. You can put them into the risk stratification. So we have different color of files. The color coding of the files is very important because those who are high risk into those, they will be always seen by seniors. That is very important. Apart from the history, biological markers, I do only PAPE in this. I don't do PIGF or AFP in routine, but this is ultrasound markers we do routinely at 12 weeks. If I find high pulsality index and a low PAPE, I know I'm going to land up and I start my echospleen to these patients immediately. If I have not done the immunological test, I will do the immunological test for these patients, especially they give me history of infertility treatment, elderly patient, or a recurrent pregnancy losses. Very important to give this, start thinking with this low PAPE and high pulsality index, very important for this. So if you want to predict, there is no single screening test. Your detailed history, your markers, your Doppler study, all this comes together. And low level of a PAPE, you need to do these patient serial sonographies. You need to think that these patient will go into the FGR. These will have oligohydramnios. They may have a PIH in a pregnancy, and I need to monitor them very clearly. Now, if this is the risk stratification, but how do you diagnose it? First, most important is confirmation of a gestational age. Just ensure that you are not mislabeling, you are not unnecessarily putting this patient into the high risk category. So apart from the last period of menses, the first crown limb is the most specific. And if patient comes to you with 24 weeks saying that I'm labeled FGR, you have to go backdated with her first sonography if you can get in her file, very important. Second most important thing is abdominal palpation. Today, the residents, they go and they advise the sonography to the patient. The abdominal palpation is forgotten, which was a golden rule in our time, measurement of a symphysiofundal height. Only those who are doing a routine obstetric or in a medical colleges, probably this is followed, not necessarily in everyone's practice. And it's very important to do all these three things. Palpation, measurement, serial measurement, not one-time measurement, but serial measurement. And of course, the ultrasound plays a very, very important role along with the Doppler. Symphysiofundal height, friends, I want to tell you, I'm not going to read this crowded slide, but this is a very simple, inexpensive, and widely used strategies. And if you see the FIGO 2021, they said that if this single SFH measurement at 32 to 34 weeks of pregnancy can give you 65 to 85% sensitivity and 96% specificity. So don't forget to. Of course, obese patient, associated uterine pathologies, excessive fluid or a too less fluid, all can change it. But on an average, you should be able to help yourself or your patient by doing this single symphysiofundal height. Of course, sonographic measurement is a mandatory. I know many of you do the sonography of yourself, but those who are taking from the fetal medicine consultant or radiologist, they should know that the fetal weight is measured not by two indices. Let your sonologist take efforts and measure it with 4 indices. My fetal medicine consultant is Dr. Pooja Loda, and the delivery time, and if I happen to do her sonography for some reason at 36 weeks, we ensure that her weight measurement comes approximately proportionately, otherwise she receives a phone call. And this is what the accuracy you should be able to get from your, and you will be able to work only when it is, that they have to do this. The uterine Doppler, very important. 20 to 24 weeks, it has a moderate predictive value for a severe FGR. I though will say at 12 weeks only. If you have been showing high pulsality index, you should know that these patients probably will land up in FGR. I feel the importance of this is another thing. I tell all my patients, sometimes natural conception, no other cause you find, and you are finding high pulsality index and low PAPE. I sit with the entire family because I don't want them to blame me at 34 weeks of pregnancy. Alright, we were coming to you very regularly. How did this happen, doctor? Very important to protect your reputation, and that's where I sit and I explain them that these are the problems I'm seeing on a sonography and on the markers, on the blood test, and with this I predict. So I control, I give them importance of taking aspirin for not only that, but also the importance of her care, her weight during pregnancy, high protein, low carb if I'm suspecting PIH in that patient. So all these, if I predict, the entire family is tuned towards the close monitoring. They don't take an objection in more frequent sonographies. They don't take objection on your advices. And when you have those predictive sonographic finding coming in, then they don't have objection. They feel we are so thankful that we are in right hand who detected at the end of 3rd month only our problem, which we are going to develop at 8th and 9th month. So this is very important, friends, for a counseling of our patient. But I'm not going to talk about twin gestation, but always remember the twins adapt themselves in a smaller space so that their weight may be little less, but they are not FGR. So they should have a separate parameters. There are separate soft markers by the sonologist. I know I have shifted from radiologist to sonologist because I feel fetal medicine consultants are the OBGY who have entered. So baby is taken as a separate patient, separate entity, and they are doctors of that. They will be able to predict better than what radiologist can predict. They can go in more detail. No radiologist of mine used to go in a detail of the obstetric history, but my fetal medicine consultant, she guides, she writes it. These are the positive findings. She is aortic conceived, she is high risk, she had a PCOS. So we are expecting the PIH and she has a low markers. All these she combines together and give a ready to think all matter to you on her sonography finding, which helps because it's a team which is involved when you involved with the high risk pregnancy. How do I manage it? The primary management always is a challenge. It arises from the risk of fetal deterioration. Suppose at 28 weeks, I have severe IUGR, and whether I deliver or I don't deliver, if I continue, will I land up in an intrauterine death? And if I deliver, whether I am going to have neonatal morbidities and mortalities about the prematurity, all this is very difficult. And I always feel the role of obstetrician, your fetal medicine consultant, neonatologist, and entire family. Because when you are giving a baby, it is not only the lady or the husband, it is the entire family, which is important. Sit with them. Otherwise, later, these in-laws will come and eat your head. Better you have a meeting with all of them, and it should be a combined decision, and try to see that they are more into the tertiary centers for a delivery than in a smaller nursing home. You may be very good as an obstetrician, but if you don't have those facilities for a fetal monitoring or a neonatal monitoring or neonatal care unit, then better you land up in trouble, you refer this patient. And I always feel it is better to refer the baby in utero, that is the mother, than referring the baby alone in an incubator and transferring the baby. So, interpretation of all this. Now, if I go for this, one thing I want to tell you very important. In a high risk population, umbilical artery Doppler, yes, very Dopplers. Alone CTG cannot be. You cannot say that I'm monitoring her every 4 days on a CTG. CTG alone is not a good test of monitoring. It has to be along with the Doppler study we all. Now suppose the patient comes and I know it's an early IUGR which is going. She has a long way to go. Maybe she is at 32 weeks. What shall I do? What is the empirical therapy? First is do no harm. Don't waste too much money of patient and her time on this. If you base, it is should be on a least modicum of logic you should be. Aspirin, yes, when you are suspecting PIH. Aspirin has no role only for prevention of FGR. Remember this. So it is in a woman where you are suspecting preeclampsia. We all by now knows that it should be started as early as 16 weeks if you want its result to be seen at third trimesters. Adjuvant therapy, for example, oxygen therapy, nutrient therapy, hospital bed rest, beta mimetics, calcium channel blockers. There are so many in treating, but there is no evidence again. 31 weeks of pregnancy, I'm seeing that it is 8 percentile baby is growing. What shall I do? Can I push just the proteins in her? Can I give her a complete bed rest? Can I put her in the hospital? How long you will keep in the hospital? What I do with my patient is I ensure the diet advice, nutritional advice very much in all irrespective of those who are aware, still it is better. Second is I tell them sit in a gallery morning 20 minutes, afternoon and evening and take a deep breath. If they have a garden in their gallery, in their society, it's fantastic. Get up at 6 o'clock. You know what, you yourself put up a clock and see 2 minutes becomes so much. You get exhausted of deep breathing. So it's easy to say 20 minutes, but it is difficult. But make it a point to take, I believe in oxygen very much, but not by hospitalizing, by taking air, oxygen in air. What are the evidences of adjuvant therapy? They do not show any significant effect on the perinatal outcome. Steroids, of course, steroids are important when you are delivering after 24 weeks of gestation. Betamethasone is preferred over dexamethasone, but there is no role of repeated steroids. It may give more morbidity of a decreased immunity and infections than the help for the fetal lung generation. One thing I would like to say here is we always say that after 26 weeks it is better, because if you see the lung development of the fetus, the canalicular stage of this happens at 26 weeks, it gets completed. And that canalicular stage is very important. So the chances of survival are always better after 26 weeks of pregnancy than later. And the steroid...
Last 2 minutes left, ma'am.
Yeah, I'm almost concluding. And the magnesium sulfate, we all know its neuroprotective role. This is the dose we give. Only one concern I will tell you, when you are giving a Maxel to the patient and you are delivering the patient, one, your neonatologist should know that there can be a respiratory suppression of the baby. So they need immediate attention, and a tonic PPH you may be giving, but of course only before 32 weeks. Now, last 2 minute slides are very important because this is not the way I used to manage. If you find isolated FGR, no Doppler studies, 37 to 39 weeks, yes, you should continue. If you find isolated severe IGR, means less than third percentile. Don't rush for delivery. If the Doppler, everything is normal, keep a close monitoring every weekly with the sonography, maybe twice a week in a sonography with the Doppler study, and please continue the pregnancy to 36 to 38 weeks, even with less than 3 percentile. I have never delivered even when it is less than 1 percentile growth, because every day in the maturity of the baby will change the prognosis of that baby. FGR with early Doppler changes, oligohydramnios associated PIH, you can still differ. In this patient, you should do their CTGs twice a week. You should do Doppler twice a week and continue the pregnancy as much as you can with the safety and of the mother and the baby. And in cases of FGR with umbilical artery end diastolic absent, remember this absence of end diastolic, you still can defer 32 weeks, but here up till now you were managing the patient on OPD basis with twice a week sonography and Doppler. Here I will admit the patient and I will do daily Doppler study, and I will still continue the pregnancy at least 32 weeks. Umbilical artery, reverse end diastolic flow, still you can continue, again admit, close monitoring. Here, though FIGO has not said, I do tremendous give importance to daily fetal movement count. It's very important. It was my thesis also, and I give tremendous importance. More than the Doppler, the baby kick count, if they are 10 in a day, I'm relaxed. This baby is fine. Decreased or excessive fetal movement are the fetal distress. But when it is a FGR with abnormal ductus venosus Doppler, then you should be delivering. But here, if it is before 26 weeks, you have to sit with the relatives and tell them the pros and cons of delivering such an early baby. FGR alone is not an indication of seizure, but if there are these Doppler studies, abnormal CTG finding, severe maternal indication, where there is a contraindication of vaginal birth, you can think about. Otherwise, normal delivery should be. But two important things: shifting the baby in utero is better than shifting the baby after delivery at your place. And the placenta, don't forget to send it so that you can predict in a future subsequent pregnancy. Don't forget to sit with the mother and a father who are taking the baby happily at home. The long-term consequences of the fetal and baby, all these, we all know that Barker's hypothesis, adverse preconceptional and intrauterine environment may give later the adulthood diseases. So maternal reproductive, last slide. Maternal reproductive health is a reflection of events over generation, multifactorial, environmental sensitivity, involves gene undergoing reprogramming, because in ART, why they at high risk? Because of this stress, because of these factors. So it's turning a full circle. There is no single test. It is our awareness, our way of thinking, segregate the OPD between the low risk and high risk and keep a close watch. Most important is the trouble with so many of us is that we underestimate the power of simplicity. We tend to make a movement of achievement by delivering in hasty at 28, 30 weeks, where we would have allowed nature to take care of that baby. So science is not only compatible with spirituality. Ask the universe to help you. Ask the universe to see the power of a baby to give you indication for when to deliver. And we don't stop when we are tired. We stop when we are done. And I'm thanking you, each one of you, for giving me an opportunity to be with you. Thank you.
Thank you, ma'am. Thank you for updating us with this, for this basic but very complicated topic. Thank you so much, ma'am.
It was so lovely to see Vidya there. And we all have done our residency together, and we used to see this and we used to discuss it, and we always felt that we don't have adequate facilities of sonographies and Doppler to monitor this more quickly and in more better way.
Ma'am, your trophies will reach you soon. Thank you so much for this wonderful lecture. We call upon yes.
And thank you, Solapur OBGY Society, Akluz OBGY Society. I see my dear friends Ujwala and Supriya, the glances of them I saw there. Girish Kumtekar, I saw. I loved your new hairstyle. And thank you for supporting me during my election period. It was tough, but it became easy because of support of you all. Thank you.
We invite our next speaker, Dr. Parag Biniwale sir, for the next lecture.
Hi, Parag.
Good morning, everybody. Now, Dr. Parag Biniwale, वाटतं सरांची ओळख फार करून द्यायची काही गरज पडणार नाही. पुणे आणि पुण्याच्या आसपास सर्वच लोक त्यांना चांगल्यापैकी ओळखतात. ही इज अ टीचर अँड हेड युनिट ॲट Kamla Nehru Hospital. He is chairperson ICOG, Resident Menopause Society, Secretary ICOG, National Website Editor Foxy 2011-17. So he is a Reserve General of the Obstetric Gynec of the India. Peer Review Chairman Young Talent Promotion Committee Foxy, co-editor of book Gynecological Manual of the Adolescent Girl and Young Woman, Yearbook of Gynec 2019. Sir has written number of articles in the books, and he delivered number of round about 150 Foxy societies. Now I am presenting such a brilliant personality, Dr. Parag. Thank you, sir.
Thank you for the kind words. Good morning all. I bring greetings from ICOG, and it's indeed a pleasure to be part of Barkha. Thank you Madan, thank you Revati, and thank you Akluz OBGY Society for inviting me here. In next 12 minutes, slides. Yeah. All right, in next 12 minutes, I am going to try and finish one very difficult task, that is managing preterm labor. All of us know that preterm labor is a big challenge, and whenever any delivery takes place before 37 weeks, we call it as preterm. There are more than 15 million preterm births world over and 1 million plus neonatal deaths. And we, unfortunately, as a country, are one of the biggest contributors to it. It is not only mortality, but it is also morbidity we should be looking at, because these babies, even if they survive, they face challenges like RDS, sepsis, intraventricular hemorrhage, and last but not the least, necrotizing enterocolitis, which make life of that tiny little newborn hell. When we talk about preterm labor, we should always be thinking about the factors which are associated with it. So traditionally, we've always said that whenever the uterus is over its distended, so may it be a multiple pregnancy, polyhydramnios, we are probably heading towards a preterm birth. But previous preterm birth is one of the major risk factors which will make a woman prone for another preterm birth in the future. So whenever we come across a woman who's in her second or early third trimester who comes with any of these symptoms, so may it be a menstrual-like cramping or low backache or vaginal discharge or even little bleeding or spotting, please don't ignore it. Take history in detail, examine her in detail, and then don't delay making a diagnosis of preterm labor. So initial evaluation is important. Correct gestational age by last menstrual period, by an early ultrasound should be done. Find out whether the labor has already begun or is it imminent, and whether there is early intervention indicated. So if a mother has chorioamnionitis, we will try not to stop this labor and try and deliver her early. Similarly, if there is something like abruption or cord prolapse or even abnormal CTG, we may have to think of delivering the baby rather than prolonging this preterm delivery. Digital examination, always thought to be controversial. All of us know that we won't do it in the case of PPROM. We won't do it when we know that we are dealing with a case of placenta previa. But sometimes, if we are suspecting something like cord prolapse, digital examination is important, and we should be doing it judiciously with utmost precautions whenever needed. Role of ultrasound, extremely important. It will not only tell us about the number of feti, the cardiac activity, the presentation, etc., but it will tell us information about the cervix and how likely it is to be heading to preterm labor. There are certain investigations we would certainly like to do: hemogram, CRP, urine culture sensitivity is important. Please note that urine routine microscopy may not give you any conclusion, but if you do a urine culture sensitivity, you will come to know whether she has underlying asymptomatic bacteriuria or pyelonephritis. Testing for sexually transmitted infection is important. GBS, favorite of the Western world, none of us are doing it, and fetal fibronectin in select patients where we are suspecting that she may land up in a preterm labor. So this is a busy chart, but it is important, and we have to first understand and make a decision whether the patient is in labor or not. If she is likely to be in labor, we strictly follow it, and then if she is not likely to be in labor, we obviously observe her and continue the pregnancy as it is. Coming to the therapy, and all of us are fond of using tocolytics, and for years, for last almost 60 odd years, we've used tocolytics, and tocolytics also have evolved in a longer way. So people have used alcohol in the 60s, and now we are using something like atosiban or nifedipine in order to arrest the preterm labor. So when we talk about uterine relaxants, there are specific categories that we use. Calcium channel blockers, that is nifedipine, is one of the most commonly used drug. Oxytocin antagonist, atosiban, that is the new kid on the block. And all of us have used isoxaprine, terbutaline for years together. And of course, there are other agents which do have uterine relaxant properties. So which is the agent that you would like to use? So world over, beta agonists are most popular. There is some amount of evidence that talks about it in its favor, but nifedipine and atosiban are supposed to be safer than the beta agonist. Till when will you continue tocolysis? Now, the idea is to arrest the preterm labor, but the minimum that we talk is delaying birth by at least 48 hours, because that is the time we want either to the baby to be shifted in utero to a higher center, or we want the steroids to act and deliver there. Of course, in some women, we are able to delay birth up to 7 days, and very, very rarely beyond that, though we should not be aiming at of about 37 or even 40 weeks. Coming to the first drug, that is atosiban, and it is the only tocolytic without any adverse side effects. It acts only on the myometrium, so it is uterospecific. I know it is an expensive option, but it acts as a competitive antagonist of oxytocin receptors, and it inhibits the PGF2 alpha induced contractions and inflammation by inhibiting PGF2 alpha. So all in all, it works well. It is, of course, given in an injectable form. So we first give a bolus over a span of 1 minute, followed by a drip, and this can be continued for about 48 hours. The cost is exorbitant, but the help that it gives to the woman in preterm labor is important. I personally have limited experience with atosiban. What we are using more commonly is nifedipine, and we start as a 20 milligram stat dose, repeat it after 30 minutes if there is no relief. So we can definitely give up to 160 milligrams per within first 24 hours. Of course, we try and continue nifedipine for a longer duration of time. One of my students did present a thesis to DNB where we were able to prolong the pregnancy for up to 3 to 4 weeks, which may not be what is desirable, in fact, in management of preterm labor. Isoxaprine, all of us have used it. We've used it in the drip form, we've used it in injectable, intramuscular form, or even tablet form. Mind well, we have to be very, very particular in monitoring these patients, because these patients can land up with tachycardia, hypotension, and even cardiac failure. So one has to be really vigilant when we are using it. Please note that these are potent vasodilator drugs, and ACOG recommends beta symptomimetic as the first line treatment for management of preterm labor. This is one of the latest papers which talks about efficacy of isoxsuprine, and it was found to be an effective and well-tolerated tocolytic agent in arresting preterm labor, in turn resulting into overall improvement in the maternal and perinatal outcome. Safety profile, all these drugs do have their pluses and minuses. There are certain contraindications to all of them. We have to be very particular when we are administering them. Please note the side effects also, because the mother will also complain of certain side effects, and the neonatal side effects have to be taken into account. Now, after your treatment, the preterm labor has subsided. What next? And these will be the questions the patient will ask you. Day-to-day activities, yes, she can continue. A big no to travel or to sexual activity. Exercise can be done in moderation or in very limited quantity. And as far as work is concerned, if the work involves night shifts or prolonged standing, it is prudent that we avoid it. There are certain interventions which do not have scientific basis. So a maintenance tocolysis is something which does not have any scientific support, though many of us tend to use it. Antibiotic prophylaxis limited only to women who have PPROM rather than preterm labor. There was a time we did give antibiotics to women with preterm labor. Initiation of progesterone supplementation after an onset of preterm labor, it has limited role. Well, if you are using it for prevention of preterm labor, it is one of the excellent drugs. And because you have arrested preterm labor, does this baby require special antepartum fetal surveillance? The answer is no. The baby has to be managed as per other routine risk factor. But there are two interventions which we must not forget. The first one is antenatal Maxsulf. Now, this is worthwhile giving it to babies who are less than 30 weeks. But it can be offered, even we are using it even up to 34 weeks, and what it does is the neuroprotection of preterm infants. How do we give it? We give a 4 gram of loading dose over 20 to 30 minutes, and if you feel that the patient is not going to deliver soon, you can continue in the dose of 1 grams per hour as a maintenance dose, generally for up to 24 hours. So what we are doing is, now there are preparations available. You can in fact see one of the posters at the rear end of the hall, which works really well as a single dose. And the second intervention, which is extremely important, is the steroids. Dexamethasone is supposed to be better to be given in the dose of 6 milligrams, 12 hourly, 4 doses. So it may be worthwhile admitting the patient and observing her. Giving 6 milligrams is a challenge, because in our country we get dexamethasone which comes in a vial of 8 milligrams. So we have to adjust the dose accordingly. And betamethasone, 12 milligrams, 2 doses, 12 to 24 weeks apart. We will be judicious when we are using it in chorioamnionitis. Generally, 1 dose is enough, but if you've administered the dose, arrested preterm labor, and maybe after 4 or 6 weeks, if the patient goes in preterm labor again, one may consider giving additional single dose of steroids. Emergency succulage, I believe there was a talk yesterday, so I will not talk about it. It has its own role in management of preterm labor. A few slides about PPROM, because here we are always worried about infection prevention. We have to ensure that the lung maturity is enhanced, and continuation of pregnancy has to be safe. Of course, these women do require close monitoring, not necessarily in the hospital, but these can be managed even on an OPD basis. So repeated hemogram CRP done every 48 to 72 hours, and serial ultrasound and Doppler is important. basic of PPROM is antibiotic therapy. There are a lot of benefits associated with it. Most of us are using ampicillin followed by erythromycin. This is what was recommended earlier. Now we've changed erythromycin, rather we've replaced erythromycin with azithromycin in the dose of 500 milligrams a day. It works wonderfully well, and then there is good amount of evidence supporting it. A big no to amoxicillin clavulanic acid, because all of us know that it may lead to necrotizing enterocolitis. It is really important for all of us to take the decision in women who come to us with PPROM, because there are certain reasons for us to wait to achieve the fetal maturity, corticosteroid effect or even antibiotic cover, and in utero transfer. And there are certain reasons where we need to intervene earlier, which includes acute complications, avoidance of infection, and preventing fetal complication. So managing preterm birth is a challenge, and it's a joint decision between the neonatologist, the obstetrician, and the parental wishes. And these are the three factors which will guide us as to how we do it. So for us obstetricians, the decision has to be a balanced one. C-section is not the only answer. We can definitely attempt a vaginal birth if things are okay. Electronic monitoring is important. Give antibiotic cover. Make sure that delivery is atraumatic, and presence of neonatologist is a must. While performing C-section, we have to understand the difficulties, because many a times the lower segment is poorly formed. There are extensions, bleedings noted, and then these are the poor surgical risk candidates. Can we prevent it? Yes, we can certainly prevent it by a good cervical screening. These are the SMFF guidelines, which are even valid today, and they should be strictly followed. And progesterone, either a hydroxyprogesterone caproate, though it is controversial for the time being, but a vaginal micronized progesterone does have a good role to play in prevention of preterm birth. So to conclude, preterm birth is a preventable problem. It's a major challenge we all are facing. Vigilant monitoring and aggressive treatment is essential, because we want to prevent the birth, and if not prevent, we deliver the patient at an appropriate pace. Tocolytics have a certain role in acute preterm labor, no role for maintenance tocolysis. Steroid administration is extremely important, and Maxel for neuroprotection should be administered as and when needed. Decision about preterm birth has to be taken jointly, so you, the neonatologist, and the parents, and C-section is to be performed for obstetric indication only. Thank you.
डॉक्टर पराग बिनिवाले, आपण थोडक्या वेळामध्ये भरपूर मोठा प्रवास घडून आणला. जसं आम्हाला वाटतं आम्ही रॉकेटमध्ये घुसलो असं वाटलं आम्हाला ते. Short but sweet. Thank you very much.
Thank you.
We call upon the next speaker, Dr. Vaman Godke sir, for delivering his next lecture.
Welcome Dr. Vaman Godke sir. He has done his diploma in endoscopy in Germany, diploma in reproductive medicine Germany. He is heading the Vaman Institute for Advanced Laparoscopic Surgeries Research and Training Center in Sangli, exclusive center for endoscopy. Welcome sir.
Thank you so much, madam, for your kind introduction. Today we'll see regarding the congenital anomalies, and being topic is for the Mullerian anomalies being a vast topic extending from the introitus up to the ovarian IP ligament, but I think we will try to see how much it will cover in time. That I'll cover. So, shall I start now? Yeah. So, we'll see the Mullerian anomalies, evaluation and management. So, evaluation will be cut short here. Basically, it develops from paramesonoperic duct and the urogenital sinus. So, irrespective of the gonads. So, most of the cases, gonads are normal. So, what happens in congenital anomaly? Only three things we have to remember. First thing is migration, second is fusion, third is canalization. If any problem in this will lead to a congenital anomalies and the growing phases. If there is a defect in organogenesis, means if organogenesis completely failed, lead to agenesis, half portion of paramesonoperic duct fails, then it will be a unicornate horn, and fusion anomalies like vertical and transverse fusion. A horizontal fusion anomaly can lead to a bicornate uterus, and a vertical will lead to a septum, that is vaginal septum and all. And third phase is defect in resorption or canalization can lead to a septate uterus. Now there are different systems like AFS, ISHRAE, Z, ASRM who classified the different classes of Mullerian anomalies and can be diagnosed with the invasive modality, that is histolaparoscopy, and non-invasive, that is the 3D and MRI. So HSG, 2D, these are the screening tests, but 3D gives correct idea. So the 3D is the gold standard investigation to diagnose the Mullerian anomalies. So in 3D, what happens? The double endometrial echoes, when they are nearer, is septate, apart is bicornate, and it has used 3-4 criteria, like the interosteal line is the red first, second is yellow, that is the serosal surface line, third is the uterine wall thickness, and fourth one is nothing but the indentation length. So these criteria are used for 3D. Now we will see the MRI is specifically reserved for dilemma cases and renal scan because it is associated with the urogenital development. Then invasive modalities, vaginoscopy gives idea regarding the vagina, then cervicoscopy to the external os, internal os, cavity, ostium and all. Now no role of medical management, but surgical management definitely we can help by correcting the anomalies. So the vaginal anomalies, these are the, we will start from below upwards. So imperforate hymen, then septum, that is transverse vaginal septum or longitudinal, then the proximal, distal or complete vaginal agenesis, and cervical agenesis, which is responsible for the vaginal outflow obstruction. Now imperforate hymen, diagnosis, clinical and ultrasound, simple incision will solve the problem. Then the transverse vaginal septum is common type of septum, vaginal septum, upper, middle and lower portion, the three different varieties. We can diagnose on ultrasound and MRI and simply to treat like imperforate hymen only. So longitudinal vaginal septum is this kind of septum. Excision is the treatment for longitudinal vaginal septum. Then proximal vaginal agenesis. Basically what happens, the communication between the endometrial cavity and vagina lost lead to retrograde menses, endometriosis, adhesions and so on. So this is the place where the yellow arrow is showing the vaginal end, cervical end, and arrow is showing missing of the upper vaginal portion. We will see the surgery in subsequent slides. Then the distal vaginal agenesis, again diagnosis on ultrasound, MRI, and clinically this is the case where uterus and cervix is there but no lower vaginal end developed. And the thing is here, one can create the lower vaginal portion and communicate the upper vaginal portion with the lower vaginal portion as in the transverse vaginal septum. Next is the complete vaginal agenesis. Here the treatment depends on functional endometrial tissue. If functional endometrial tissue is there, treatment is new outflow tract should be reconstructed. If no functioning endometrial tissue, then it lands in a MRKHS. So MRKHS or the vaginal agenesis, the treatment is widely accepted treatment and widely practiced is the Davido's peritoneal flap vaginoplasty. So here the first step is introital portion creation or lower vaginal portion is created, then vaginal apex, then the tube is kept there just to judge the vaginal capacity, peritoneal sutures taken, pull down suture to the introitus, then fourth step is apex, where the uterine buds are used to get the strength at the apex, and this is the vaginoplasty. This is the mold which easily fits into the vagina, is having good capacity, and this is last one is the follow-up. Now somebody is having double vaginas, so don't be so jealous and hurry to treat it, let it be. So evaluation of the cervical canal, beautiful mucosa on hysteroscopy, you can have internal loss, external loss, and you can diagnose it correctly. Two things, cervical agenesis or failure of canalization. So here there is cervical agenesis. You can see the endometriosis on the right side. So the fundus is open, hematometra was drained out, cervicovaginal communication is established. Here there is absence of cervix, so we have to communicate the lower endometrial portion with the vagina. And the left side, right side, there is a hysteroscopy is going on for the same case, follow-up hysteroscopy, and you can say this is the cervix. This cervix is without fornicis and without external loss, because directly we have communicated the endometrial cavity with the vaginal canal to avoid the outflow obstruction and to conserve the uterus. So here, now in this case, the right horn, no cervical canal, and left horn is having cervical canal, but there is a loss of communication between the cervicovaginal canal. So the horn without cervix on right side is resected, and left horn cervicovaginal, this is the sound from the vagina into the endometrial cavity over which the vagina is sutured over the cervix, and the left horn is communicated with the vagina. Now the rare anomalies which is reported in literature is that single endometrial cavity, two cervical canal and two vaginas. But this is again a rare most anomaly which is not yet reported. This is double endometrial cavities, but three cervical canal. One is the blunt cervical pouch. This is the blunt cervical pouch. Then septum, which is one of the commonest congenital anomaly, we have to see it in details. For septum, the treatment management line is resection, transection or excision. So how septum is classified? Basically by Butram's classification, that is a septum extending from the fundus not up to the internal os is incomplete, up to the internal os is complete, in the cervix, in the vagina, wherever it may be, but it is a complete variety of septum. So this is partial or incomplete, and this is the complete septum. 100% accuracy of diagnosis is 3D and combined hysterolaparoscopy. So we can have a look on each and every variety of septum within a minute. So this is the thin variety of incomplete septum, this is the thick variety of incomplete septum, then septum extending, this is the complete variety, extending up to the internal os, thick, up to the external os, thin and thick variety of septums. So septum extending into the vagina but not up to the introitus, and septum extending up to the introitus. So we have seen all the varieties of septums from the fundus up to the introitus. Now we will see the management. Management, septal excision with energy and without energy. On the right side, it's with energy, ostium is under vision all the time, and we can retain a good cavity. Same thing with scissors also. Now to excise or transect the septum. Now if you see the complete septum, upper portion septum is more of muscular origin and it will contract, but lower portion it is more of fibrous origin. So the remnant of septum will remain and someone has to excise it. Excision again with energy or without energy. So here excision is with energy with loop. This is how the septum is excised. Or someone can excise with scissor. Now here complete septum is shaved off. You can see it nicely with the scissor without energy. The septum is excised with the scissors. See, it is just swept up, and you can see the myoma, this bed of the septum from which it was completely shaved off with the scissors. Now, the thick septum extending into the cervix up to the external os, what to do? So, there are different thoughts, like the cervical septum here is excised with scissors simply, but sometimes it's a difficult in some cases. Here cervix 1, cervix 2, thick septum, thick cervical septum, cervix are apart from each other, and it is very difficult to resect with the scissors. So what we did is put one port closure finger in one cervical canal and with the resectoscope resect the septum from another cervical canal, and then you can communicate both the cervices together. This is how the single cervical canal is created, and then the cavity septum is completely resected. Now, in this case, the septum extending from the fundus up to the external os, what to do? Here the septum is perforated, half the septum, that is septum from the endometrial cavity, is resected, and cervical septum is left as it is. This is follow up after 3 months for the same case. This is the thick cervical septum, body septum was resected. So there are different thoughts to resect or not to resect, but instead of confusing you, I will give the final conclusion that any septum extending from the fundus up to the external os, one should resect the complete septum. That will make our life easy by making the procedure safer, easier, and less complicated. Next thing is Robert uterus, which is a variety of variant of the septate uterus only, where septum is attached to one of the lateral wall, and it can lead to a obstructive horn. Like here, right horn is obstructed, hematometra, left horn hysteroscopy, single ostium is there, left tube is patent, right tube is blocked because of non-communication of the cavity. So one has to resect the septum and communicate the right cavity with the left cavity. Like the same pictures, hematometra was drained and both the cavities are connected together. Now, bicornate uterus usually is diagnosed on 3D. This is a fusion deformities, complete fusion deformity or incomplete, that can lead to partial bicornate or the complete bicornate. Is treatment required for bicornate uterus? Usually not, but in recurrent pregnancy losses, one has to think twice regarding the communication of both the horns, and this is nothing but the surgical repair. Now, this is two horns, right, left, vasopressin injected, incision is marked, both the horns, endometrial cavity is opened over both the Foley catheters, endometrial cavity, then remove one Foley, kept one Foley as it is, over which the myometrium is sutured, and you can communicate both the cavities together. So this is the single cavity, hysteroscopy, and follow-up 3D is here. So what happened? 2 minutes, yeah. So this is how the outcome and oblique pregnancy on 3D also. Now, unicornate uterus again does not require treatment, but in some cases we may do metroplasty and widen the horn in this way. In cases this is a non-communicating, non-functioning horn, should not be resected, but functioning horn one can resect to avoid the complications like ectopic or retrograde menses adhesions. Then acute accessory cavitatory horn, one has to resect it completely nicely. Then the uterus diadelphys does not require treatment, but sometimes a metroplasty can be useful. Then this is another case where left horn is communicating, right is non-communicating, but right horn is good horn. So what to do is, right horn instead of resecting, it was communicated with the vagina and saved for that poor girl in good faith that it will be useful for her in her future obstetric outcome. For arcuate uterus or T-shaped uterus, it doesn't require treatment for all cases, but in some cases one can go ahead with metroplasty and one can widen the cavity. So this is frontal metroplasty and lateral wall metroplasty. In hypoplastic uterus again, the ovaries are usually good, does not require treatment, but if at all required, one can do metroplasty. This is a case report where this case, what happened? She landed into a hypoplastic uterus with premature ovarian failure. I did metroplasty twice, then stem cells was injected. Endometrial thickness optimum we achieved is 6. Then we did donor program for her. She became pregnant and 5 months back she delivered. And this is again my own study regarding the hypoplastic uterus, metroplasties and all. And this is prospective study of 30 cases I have published in International Journal of Stem Cells for endometrial rejuvenation. So after all, other anomalies like here, selective right ovarian as an assist, right femoral as an assist, right IP ligament as an assist, and so on. This is the pelvic kidney, so one has to do renal scan along with that. So to conclude, uterine anomalies are commonly seen in women presenting with the history of reproductive problems or menstrual problems. Today in HSG are best for screening. 3D is gold standard for diagnosis, and hysterolaparoscopy is gold standard for treatment. So bottom line to say is, the recurrent pregnancy loss without any other infertility issues, to reconstruct the God's house with hysterolaparoscopy definitely will provide the shelter for the growing fetus with fruitful outcome. Thus it will reduce the rate of pregnancy losses in the congenital anomaly cases. So thank you so much.
Thank you, sir, for your very elaborate
We request
talk, right from diagnosis to the management on a very complicated topic. Thank you.
We request the speakers to felicitate Dr. Vaman Gudke, sir.
Thank you, madam. Thank you, my teachers and my friends. And thank you, Achilles OBGYN Society, for giving me this opportunity. So thank you so much.
Hello.
We request Dr. Shetty, sir, to please felicitate the chairpersons.
Next will be the panel discussion on sudden maternal collapse. Moderator will be Dr. Sneha Buyar madam, and Dr. Vidya Tirinkar madam. Panelist will be Dr. Vinaya Khedkar, Dr. Jyoti. Hello. Panelist will be Dr. Praveen Mundura, Dr. Jyoti Sul madam, Dr. Shobha Shah madam, Dr. Kavita Kamble, and Dr. Anuradha Garad madam. And lastly, Dr. Sachin Pawar sir.
Sachin Pawar. By the time the display is on, I just finish all the formalities. A very good morning to
Please
all of you.
put up CV slides. Excuse me, audiovisual team. Yeah.
I think I just wish all of you a very good morning, and thank you for being here on such large numbers. And at the outset, I would like to thank especially the AMOX President Dr. Rajendra Singh Pardesi and Madam Sujata Darvi, and I would like to thank and congratulate
Dr. Madan Kamre, Dr. Revati Rane, and the entire team of organizing committee, rather I would say the team Akluz, Osmanabad, Pandharpur, and the society who has, with a golden heart accepted this opportunity to host this conference, Solapur Society. So, without much ado, sudden maternal collapse. So, the topic for panel discussion is sudden maternal collapse, and I welcome my co-moderator, Dr. Vidya Tirankar, professor from Solapur. All of you know her very well, and I would like to request all the panelists just to say one very important point for your introduction. You can start from Dr. Shobha. Mike. Please change. Yes, yes.
Working in Solapur.
Introduction, please. Yeah.
I'm Dr. Kavita Kamre from Akluz Obsgynae Society, Clinical Secretary.
Welcome.
Myself, Dr. Anuradha Garad from Usmanabad.
Welcome, Anuradha.
I am Dr. Jyoti Sul, Latur OBGYN Secretary.
Yes.
Myself, Dr. Sachin Pawar, Secretary, Pandharpur Obsgynae Society.
Yes, welcome. I had a privilege to visit Akluz as well as Latur, both the societies, and I'm very happy to have all of you here. So I just hope that the panel PPT is presented here to open. Yes. So just to start with, all of you are well versed with the situation what we are talking about, sudden maternal collapse. So friends, yes, since yesterday we are hearing that the maternal mortality rate has been reduced from 500 to now, almost 39 for Maharashtra. So we are talking about maternal mortality rate. So it's not just the rates and ratios and numbers. Friends, these are women and they have their faces, and I'm sure all of us who are managing these situations, we have witnessed these faces in the phases of their pain, distress and agony. And I'm sure those who have faced these kind of situation will never forget the face of that woman. So, this is what is expressed by the past FIGO President Mohammad Fatala. Also, Ian Donald expresses this as looking back over the clinical times, one tends to forget the failures. It's a success we always keep it in mind, but these are the failures which stand out like keloids. So the one who suffers always, looks at it as a lesson. And of course, it's a lesson to learn for the others also. So I will not talk about this theoretical aspect. I will just say that the near-miss situation, this is a term which we have borrowed from the airline industry, and it tells you that how serious is the situation and the urgency to intervene that it indicates. So that is what is near-miss situation. And considering the changing scenario and the demography, that is the increasing age of the woman who is, of the childbearing age now, her habits, her living style, increasing obesity, smoking, alcohol, even the IVF procedures, multifetal pregnancies, medical and surgical comorbidities because of the increasing age as well, increased operative interventions and placental complications. These all can, make you face more and more of such kinds of situation. So I'm here to learn with all of you. So please do not stop learning, because life never stops teaching you. Every case is a challenge for all of us obstetrician. With this, I hand over to Dr. Vidya for the first case.
Okay, this is the first case, and it is always a nightmare for the obstetrician whenever there is a sudden maternal collapse. So the first case is second gravida, previous cesarean section, last childbirth 1.5 years back. She comes with only 7 days overdue menses. Her urine pregnancy test is positive and she wants a medical abortion. So the doctor prescribes her a medical kit, abortion kit, and she's called for follow-up after 7 days. She only had spotting, and giddiness and pain in abdomen. And on the 6th day, at 11 p.m. at night, she collapses at home and she's brought by the relatives to the hospital. Now what? Yes, so now I hand over to Madam.
Ma'am, I'll take this question.
Yes, you start from one end. I think Dr. Praveen Mundada will take up this question first. We start from that end and then we come here. What, basically, yes, you can start
in a
with this
scenario in early pregnancy, we have to remember certain things, that early pregnancy may be a normal intrauterine conception and it may be otherwise also, like extrauterine or ectopic conception. So anything in this case is suggestive of, first thing we have to rule out whether we are dealing with some ectopic gestation. The first thing comes in your mind as patient is come in the emergency room, we have to settle down patient hemodynamically and immediately go for the confirmation of the diagnosis by ultrasound.
Yes. I would request all the panelists to be very crisp and precise to the point because we have very less time and we have interesting cases. So my other question here is, what is your diagnosis for this patient? That's the first question.
Yeah, it's ectopic pregnancy.
Okay, ruptured ectopic pregnancy, I would say, to be very precise. So what precautions you should have taken, I mean the doctor who is prescribing should have taken, how you should have counseled the patient also?
Patient coming from medical MTP as well as a part of practice, we must go for the ultrasound before confirming.
Is it a must? That is the next question. Whether ultrasound, Dr. Shobha, you can take up this question. Whether ultrasonography is a must before prescribing the MT pills.
Yes, ultrasound is must.
Does everyone agrees to it?
Yes, ma'am.
And look for the adnexa. Early gestation.
So I would answer your question to be more precise. Ultrasonography is not mandatory. It is not a must, but it is recommended for the safety of the patient and yourself. So we have to go for ultrasonography just to rule out the ectopic pregnancy. Okay. What bedside investigations has been done and the patient is in shock? All of you know what is the treatment of this patient. You have to go for emergency laparotomy. So we will not discuss this here. Only precautions, how you should have counseled the patient. That's the only question. Dr. Jyoti, you can take up this. How do you counsel this patient before giving the MT pills?
We can counsel before that. I would have counseled for the ultrasonography. If it is not done, then I must have told her that if there is bleeding or any kind of severe acute abdominal pain, whatever kind, you can come in an emergency. And before that, proper consent that should be there. And with her consent is most important. After that, basic investigations, CBC, we should do.
So the message here is ultrasonography is not mandatory, but it is recommended before giving MT pills, and of course the proper counseling of the patient along with the possibility of whatever complications can happen, and even if she lands up into any complications, she has to report to the doctor at the earliest, not only after 1 week. That is what should be explained and should have been written as informed written consent. So this patient, of course the management we will not discuss because of lack of time. So these are the learning lessons what we have discussed till now, and we can go over to the second case immediately.
Madam, I just want to add one thing.
Yes,
that
please.
this patient can also be a scar pregnancy because it is a previous LS season.
Yes.
So when we do only sonography, we are doing the sonographies, but two things are
Yes,
important.
so it is
One
a ectopic
scar.
pregnancy. It can be any type of ectopic, scar ectopic pregnancy, that
And,
is what we call.
one thing, ma'am, when sonologist does a scan and only gestational sac, we should not prescribe a pill. Yolk sac is compulsory because I faced the similar situation in my private sector. She gave a gestational sac and we prescribed the pill and the patient landed with collapse. Means confirming with a yolk sac is equally important rather than not only seeing the gestational sac on a sonography.
Okay.
Okay, you can go ahead. We move on to the second case. She is a 36-year-old woman with an IUI pregnancy. Husband is working outside India and this patient lives in a village, and she was under antenatal care till 24 weeks with normal investigations and scan. Patient came for checkup directly at 34 weeks with complaining of pain in abdominal edema. Her blood pressure was 176 by 116 millimeters of mercury. Fetal growth parameters were normal. Proteinuria present. Liver function test, renal function test and hematocrit was normal. Her blood pressure was measured at a primary health center. It was only reported that it is high and she was put on nifedipine. Patient was advised admission and counseled for possibility of early delivery. So, this patient received antihypertensives in the form of labetalol, nifedipine retard, magnesium sulfate and steroids were given. Patient got admitted after 1.5 days, though she was advised admission immediately. Her blood pressure was 168 by 110 millimeters of mercury. Rest of the parameters were the same. A cesarean section was done with a 1.8 kg live female baby was delivered. The patient's blood pressure was 140 to 180 by 110 to 110 milligrams mercury. Patient was put on tablet nifedipine and magnesium sulfate was continued for 24 hours. So on the second day, after 30 hours of cesarean section, patient had sudden severe cough, breathlessness and restlessness. Her pulse was tachycardia 115 per minute. Blood pressure shot up to 220 to 118 millimeters of mercury. Oxygen saturation was low, 70%. And on auscultation, there was wheeze and the breath sounds were not clear.
Yes. You can say.
Yes.
I think Dr. Sachin
Yeah.
has not spoken, so we can hear from.
The case is of severe preeclampsia, and according to the history, signs and symptoms, the diagnosis would be pulmonary edema, secondary to her preeclampsia, hypoproteinemia.
Correct. So
And,
how would you manage this patient now? We will
yeah.
discuss the management first.
First, the BP as it is shown, it is 220 by 118. First, the IV labetalol drip should be started to control her hypertension. And
It's a case of pulmonary edema first. So
Yes.
how would you start
with
the priority wise?
Oxygenation, proctor
yeah,
position.
first we will start high oxygen flow by nasal mask, and loop diuretics should be given.
How much? Which one and how much?
Furosemide, that is Lasix injection
How
should be
much?
given. Stat 40 milligrams can be
Yes,
given.
pulmonary edema you give 40 to 80 milligram.
80 milligrams.
Not very, yes, micro.
80 milligrams should be given. The physician should be consulted for her cardiorespiratory further investigation management. X-ray should be done. And in case after the steroid loop diuretics are given and she does not settle.
Whenever you manage some critical patient, you have certain algorithm as ABCD. So whether she is having her airway patent, whether she is breathing well, whether she needs ventilation, mechanical ventilations, all these, and any drugs. So you are giving her Lasix, that you have said. Any drugs, you said labetalol, how much and how?
Labetalol drip.
For this patient, how do you give labetalol? See, by the time the physician comes, it will be too late, because the patient is in your hospital.
Injectable labetalol.
Yes, how much?
20 mg IV, we can repeat it 2 hourly.
Yes, Dr. Praveen.
Labetalol can be given safely up to 80 milligram as a slow IV bolus or in 100 ml of
Yes,
normal
to start
saline.
with, you give 40
and we
milligram.
can then go on adding with the 10 milligram
Yes.
or the 20 milligram
Yes.
till the BP is settled.
Yes. So whatever regime you follow, you give 40 milligram as a slow bolus, intravenous bolus, and then you can start the infusion. But for this 40 mg, give 40 mg, wait for 10 minutes. If you don't get the desired effect, you can repeat it. You can give the second dose as 80 milligram. Even if you don't get the desired effect after 80 milligram, waiting for after 10 minutes, then you can repeat even 80 milligram once again. And maximum how much you can give labetalol?
Up to 200 milligram.
Up to 200 milligram you can give. But suppose now you have managed this patient, by the time the physician comes and you have managed this patient very effectively, you can see this patient has collapsed completely, the saturation has gone to 55%. This patient with AMBO assisted respiration, she was shifted to ICU and she developed cardiac arrest meanwhile. So you have to be very, very prompt and you have to do everything simultaneously. You can't decide that give this drug first and wait. You have to give the oxygen supplementation, the intravenous furosemide as you said, the intravenous antihypertensives, all the supplementation, life support measures also you have to take on your own, and by the time if the physician or the cardiologist joins you, well and good. Now this patient has landed up into cardiac arrest. What next? Yes, she needs a cardiopulmonary resuscitation, and then rest of the things we have done. Now we come to introspection. What has gone wrong and at what stage? Because we are the one who has done all these blunders and the patient has landed up into this problem.
BP was persistently raised. So
Right from the first, if you talk to the initial history, the patient was a case of IUI. She was infertility, a case of IUI. She came regularly up to 24 weeks if you go to the history. What investigations in the early pregnancy should have been done for prediction of hypertensive disorders?
For prediction, madam, we have to do for ultrasonography from 12 weeks. We have to see the uterine artery PI. If it is more than 2.5 in first trimester, start 150 ecosprin HS. If it is detected at the anomaly, sometimes patient do well in first.
We stick to 11 to 13 weeks only. Anything else apart from ultrasonography and uterine artery PI? Anything else in the history? In the history, anything else? All of us always talk of the hi-fi things. Yes, you have what is called as maternal characteristics.
Yes.
When you take the
Gastosis
history,
score, what you are talking about.
age of the patient, parity of the patient, whether she has got thyroid dysfunction, hypothyroidism, family history of hypertension, diabetes mellitus, any vasculopathies, you have what is called as HDP Gastosis score.
Yes.
The Gastosis organization has made this Gastosis score, and it is available on the Android app. It is totally free of cost. Even if you use for every patient, you can get the ready-made values. You just put all the information you get. So if this score is more than 3, then you have to start with what is called as the protective drugs, that is low dose aspirin 100 milligram. Till now it is accepted 75 milligram, but even today it is 100 milligram, and then of course high dose calcium and vitamin D3. So all these things. So right from history you have to be very cautious. She is a IUI, ART procedure. You have to go for, she is a high risk patient. So you have to do all the workup for high risk patient. In the bigger cities you have SLGF and PIGF and SFLT. All these markers are also done. So if possible you can do that, and then of course HDP Gastosis score we have. Now this patient who was prone for development of these complications, if you could have caught in the initial examination, you would not have allowed her to go from 24 to 34 weeks, 10 weeks she was missing. So if you go by the inverted pyramid of antenatal care, if you categorize the patient as high risk, she has to be under specialist care every time. Otherwise, if she is a low risk patient, she can be at the local level, or family physician also can manage this patient. So this is how. Now what went wrong while using the antihypertensives? Dr. Sachin, I want to know from him. The first visit, what was the blood pressure at first visit, and what was the antihypertensive given?
Antihypertensive nifedipine tablet was given.
See, for you I display here. What is the blood pressure? 176 by 116, and the antihypertensive given is tablet nifedipine. So that is absolutely blunder what is done at local level.
Capsule nifedipine should have been started.
Yes. So here at this point we had two options. Which were the two options, and if you were there, what you could have done?
Capsule nifedipine should have been given, as well as according to her BP level, IV labetalol should have been started earlier for control of hypertension, as well as magnesium sulfate should have been given.
Injectable labetalol.
Right. So basically the first antihypertensive was wrong. So you have put this patient at such a situation. If you had given the patient the right antihypertensives in right dose at the right time, this patient could have been controlled at that point of time, and we could have pulled her pregnancy also to term. So that is how it is, so even the mother and the baby has suffered because of the wrong management. So these are the various stages where we need to improve ourselves. Of course, the magnesium sulfate was given at PHC, that was only intramuscular. So that is one more lesson I think everybody, even at PHC, if you have severe hypertension, even the medical officers should give what is called as prophylactic magnesium sulfate, because for first dose of magnesium sulfate, you are not going to make the patient, you are not going to give toxic levels to the patient. So even if you have given intramuscular, you are supposed to give all the history examination, and a referring letter has to be so well maintained. You have to tell communicate with the doctor to whom you are referring, may it be a higher center. You have to tell them that these are the drugs which she has received, and that is how the next treatment should be, guarded or guided. Okay, so with this, I think we go on to the next case. You can take up this case.
The next case is,
yes, that is what we talked about. There are so many biophysical and biochemical markers, because hypertensive disorders of pregnancy will need one more panel discussion. Okay.
And
so
in previous case, ma'am, we should rule out magnesium sulfate toxicity also, because she is having low oxygen saturation, respiratory failure.
No.
No?
okay, moving on to the next case. She is a 20-year-old primigravida, full term, and she was referred at night with history of admission in a nearby nursing home with history of strong labor pains since 3 to 4 hours prior to admission. As there was no progress of labor, she was posted for cesarean section. Catheterization of the bladder done, but there was no urine, and hence she was referred. And on examination, this patient was having severe pain in abdomen, pulse rate with 110 per minute, blood pressure of 110 by 70 millimeters of mercury, uterine contractions severe in intensity, fetal heart rate only 100 to 120 per minute, cervical per vaginal examination 7 centimeters dilated cervix, membranes absent, station was 0. Her investigations were hemoglobin of 8 grams per set, platelets 1 lakh, prothrombin time PTINR 2, APTT prolonged, FDP present, fibrinogen 150 milligram per cent. So what is the diagnosis and how do you manage?
This is DIC, case of DIC.
Yes, I think you can take up Anuradha and Meghna, Dr. Josna. Yeah. Your mic is not working, I think.
This is accidental hemorrhage with her DIC, because her PT INR is 2 and APTT is also prolonged. She needs management, should I tell? Firstly, we have to go simultaneously, because she is having a DIC.
So what is your diagnosis? That
accidental hemorrhage in DIC, ma'am.
Abruptio placentae.
Abruption with DIC.
Yes. With? Yes.
Not needed.
Not necessary that this patient is in labor, no?
Yes.
So that you have to also mention that she is a case of non-progressive labor.
Yes.
There is no urine, so she is in acute renal failure.
With
so you have to give your complete diagnosis. Yes. Okay.
With organ failure. Firstly, madam, she needs to be corrected. First is the volume deficit needs to be corrected, because her HB is a 8. So firstly, we will like to order the MTP protocol has to be followed, massive transfusion protocol. So we will like to order the blood, and along with 1:1 FFP.
I would not say massive transfusion protocol here. You have to just manage this patient aggressively. Okay. Dr. Praveen, you want to take up?
Yeah, we have to manage this patient at 2 levels, at the fetal level and the maternal level.
Correct.
Maternal level, we have to stabilize her hemodynamics and whatever disturbed hematocrit and platelets and coagulation factor. And as well, fetus bradycardia is there. We have to make an attempt to deliver baby as soon as possible. Maybe
yes. What will you do here? Whether you will go for cesarean section?
If I have adequate supply of the blood and blood products, then I would have pushed for the
Whether you
cesarean
will
section.
wait for the blood products to get ready and go for Caesar,
things
or
has
you will...
to done at the same time at 2 levels.
Yes. So everything has to be done simultaneously,
time.
because you don't have much time. Abruptio is already, the placenta is separated.
Because once kidneys are shut down, you are nowhere.
Yes.
Before kidney shuts down, we have to make the
So
things.
whether the kidneys have shut down here, she's
Yes.
into
We can't
anuria
know
totally.
Unless we are KFT with us, we can't label it as a
Yes,
kidney
so basically she has anuria. So whenever you have hypovolemia, there is a decreased renal perfusion. So initially you have acute tubular necrosis. So that is a type of renal failure from where it is reversible. So if you correct the hypovolemia immediately, aggressively, you can improve the glomerular perfusion and you can get the kidneys back functioning. But if you allow this hypovolemia to progress further without any intervention, she will go into what is called as irreversible renal failure, that is acute cortical necrosis. So how do you go ahead with the management now? What kind of blood or blood product, whether you want whole blood for this patient?
PCV along with the fresh frozen
FFPs.
plasma should be breaded because her coagulation pathway is also deranged.
Yes.
There is consumptive coagulopathy, so the platelet depletion as well as coagulation factors are very less. So
Whether you want to give Paxil or you want to give something else?
Paxil with fresh frozen plasma, FFP,
Okay.
both should be given.
Okay. What about cryoprecipitate?
Cryoprecipitate, unless fibrinogen level has gone less than 400 or at least 300, if it is gone, it is 150. Yes, madam, if it is 150, yes, we are supposed to give a cryo along with the FFP.
Yes.
Because FFP has a very less cryoprecipitate.
So I hope all of you know what is the function of this. This is just theoretical aspect. We have tried to, just to complete the PPT, we have mentioned it here. The patient, our patient has which grade of abruptio here?
3.
Grade 2. Grade 2 to grade 3, because there is fetal distress, not fetal death at present, but grade 2 to grade 3, she has massive bleed inside, but the fetus is still alive. So this is how you are supposed to, you are supposed to manage this patient, correct the hypovolemia, arrange for blood and blood products, plan for emergency cesarean section immediately. And of course, you have to know how to calculate how much fibrinogen and how much cryoprecipitate is there. Can anybody talk about this?
If it is prothrombin time is, madam, less than 1.5, the FFP is 12 to 15 ml per kg of the body weight. And if the prothrombin time is more than 20, then it is 20 to 30 ml per kg of the body weight.
Correct.
And cryo, I think we give 10 ml per kg cryoprecipitate.
Okay. I would ask Dr. Josna to talk about, I think Dr. Shobha and Dr. Kamble, you can take up this, whether this patient is into frank or overt DIC or non-overt DIC. How do you calculate that?
She's not into overt DIC because the fibrinogen level is only 150
Huh.
and the clot, she's still in the reversible stage, and so we can correct the hypovolemia and give her the proper FFPs, so she would be returnable, the DIC can be
Yes.
corrected.
How do you calculate what is the scoring system for DIC from all these parameters? If you are given the platelet count, the fibrinogen levels, how do you know what is the score of this patient?
It depends upon, I think, madam, all the levels of fibrinogen and platelets
And prothrombin time also. Yes. So if the score is more than 5, she is in overt DIC. So if the platelet count goes below 50,000 and then the score becomes more than 5, as you said, fibrinogen levels goes below 150, then the score becomes 5, and then she goes into overt DIC. This patient is not into overt DIC. This is a occult or not frank DIC. Whether you want to make any comment?
No. So we move on to the next case. She's a 32-year-old, para 1, previous cesarean section, male child, 1 year, complaining of bleeding per vaginal. This is her first visit at 6 months as her husband's job transferred. After reaching the hospital, the bleeding has stopped. So history of early pregnancy spotting, old USG reports shows low-lying placenta. Her ultrasound at 26 weeks shows placenta previa with absent retroplacental leg. Anomaly scan was done, which did not show any abnormalities. At 30 weeks again, She started bleeding at home significantly, but stopped by the time she reached the hospital. And during investigations, she started bleeding significantly and collapsed. So what is the diagnosis?
Placenta previa.
You can take up, no problem. Anybody can take up.
Madam, this is a placenta previa with a, I think it is a placenta accreta spectrum because there is absent retroplacental leg.
Very
and
good.
we have to go for a good sonography, and I think anterior or posterior most
No,
probably.
we are
it is
asking you, we have given you the diagnosis, you have already said it is placenta previa accreta. How do you manage this case first? 30 weeks, placenta previa accreta, patient has collapsed.
Patient has, I would first like to resuscitate her. After resuscitating her, I would like to see how much is the separation.
How do you resuscitate this patient? What all things you will do?
It is again A, B, C, D, E, ma'am.
Yes, but you will send blood samples for investigations and to arrange blood by the time you resuscitate the patient. Because your blood has to be ready. Otherwise, you will just give IV fluids and that will not work. Okay.
Yes. Doing her after basic investigation, we will like to order the blood. We will see how much is the, if she has collapsed means she is in absolute shock. So I don't know if I should have, I have a time to do again a sonography to see how much is the placenta.
No, at this point of time, no sonography. Patient has collapsed.
Okay.
See, our panel discussion is very, very practical. We are not going into theoretical discussion.
Then, madam, if it is a patient is collapsed and it's a placenta previa, I think we have to take her to a theatre.
Put 2 IV lines, give aggressive fluid management from one side, you take blood and arrange blood and blood products. That is one. Meanwhile, you have to, the moment you see the patient, you shout for help. Call all your colleagues, your staff, maybe some senior obstetrician, your senior anesthetist, neonatologist. Even though there is a less possibility, neonatologist and your operation theatre has to be ready. Your blood and blood products have to be ready. Okay, by the time you aggressively manage this patient with fluids, then what next? You talk to the relatives because they are surprised with this situation. The patient has come to you twice with spotting, she has stopped bleeding. Okay, how do you explain? Doctor, मागच्या वेळेला का नाही सांगितलं तुम्ही?
I think we have missed placenta accreta diagnosis, or we were less in counseling the patient, but now we have to counsel as she has collapsed. Now she might need a obstetric hysterectomy for this case, and we have to counsel them about a massive transfusion and all.
Might need or she will need? What
she will need, ma'am. She will need.
Okay.
She will need. Actually,
agreed? All of you agree? What is the audience opinion? Whether for this patient we have to go for obstetric hysterectomy? Yes, we have to go because basically it's a life-saving one. You have to go, you have to take an informed written consent. That is before starting the procedure, not during the procedure. नाहीतर डॉक्टर म्हणणार डॉक्टर तुम्ही ते पेशंटचे रिलेटिव्ह म्हणणार डॉक्टर तुम्ही काहीतरी कॉम्प्लिकेशन केलं म्हणून तुम्ही काढता युट्रस तुमच्या हाताने फाटलं काहीतरी हां तर you have to tell them that this is a situation where you have to go for the obstetric hysterectomy. If you try to remove the placenta, the patient will bleed and you will not be able to, save the patient. So that's a reason, life-saving procedure, obstetric hysterectomy, the informed consent has to be written, informed consent, before starting the procedure. You have to take them into confidence that she will need n number of blood and blood products, which you are also not sure how many blood and blood products, but you have to take a separate consent for blood and blood products. Doctor सांगतील तसं ट्रीटमेंट करायला आम्ही तयार आहोत, ही consent valid नसते. Okay, so all of you you will be getting the uniform consent from the Foxy website, but just for practical purpose, I am telling you, you have to take a blood transfusion consent separately, whether it is elective or emergency. Okay, आता तुम्ही, you have taken all the consent, you have gathered the blood and blood products, you have taken this patient to OT. What are the precautions you will take for this patient during the procedure, maybe before starting the procedure? Who all do you want? I have told you senior obstetrician, senior anesthetist, neonatologist. Who else? Yes, Dr.
She is a
Sachin.
case of previous cesarean with past spectrum placenta accreta, might be invasion to the bladder. So
Yes.
the urologist, if available, neurosurgeon.
Very good.
He should be
If not,
informed.
if
Yes.
not urologist,
Any surgeon, madam?
Yes.
Any surgeon or oncosurgeon
Yes.
should be available.
by choice, urosurgeon or oncosurgeon who are well versed with stenting the ureters or handling with the bladders, because you know you have to actually sometimes separate the myometrium and the bladder together, you have to incise. Okay, so if not, one more, interventional radiologist.
Yes,
If
okay.
at all the facilities are available, uterine artery embolization to minimize the blood loss. Okay. Yes.
Incision should be taken on the upper
Vertical
uterine
Yes,
segment.
now one person
to
will
avoid-
describe what all precautions for the procedure.
But first, the incision should be taken above the
Abdominal
placenta.
wall incision,
Yes,
you are talking
and-
about, abdominal incision.
Yes,
How
and electively we can bilateral uterine ligation.
What
can-
incision you want to take? We start from
vertical
there.
incision,
Vertical,
upper classical
okay.
cesarean, like
Abdominal incision.
abdominal, midline or whichever the surgeon is comfortable
Okay.
to make a quick
We
entry.
start again from that
Vertical,
side.
madam.
Dr. Praveen, which incision
Vertical.
for this
Midline
patient?
vertical incision.
Midline vertical incision. The exposure has to be good. That is what, you know, it should be well exposed, and you have to be, you know, you may need internal iliac ligation, you may need other, you know, selective, the stepwise devascularization, everything. So you have to have a very good exposure. So midline vertical incision, okay. How should be the uterine incision? Dr.
Classic.
Shobha? Next, you can pass on. You can pass on. There is no problem.
Above the placenta.
How do you know that? So,
Upper segment of
yes,
upper
bas-
segment
yes.
has to be taken.
yes,
The
basically,
classical incision
for
can be
that
done.
you can just put a probe for mapping the placenta, that is called as. So, try and avoid reaching or cutting through the placenta. Just last minute, I think we'll finish up this case and that's all. So, mapping of the placenta, try to avoid cutting through the placenta. So, upper segment vertical incision or what is called as transfundal incision. Just deliver the baby. What next? What precaution, Anuradha?
Take out
Baby
the
काढलंय, आता प्लासेंटाला काय करणार?
No, don't touch the placenta, madam, because it is Acrita spectrum. I think we should go for a OH along
Yes.
with placenta in situ.
See, now I tell you, if it was a complete adherent placenta, she would not have bled, because she
Yes.
doesn't, if the placenta is not getting separated, how she will bleed? So she is bleeding. So there is a patchy adherence, okay? So for this patient, we change the line of treatment. Suppose there is only patchy adherence. Yes, then,
Triple P procedure is
yes,
there, madam.
tell me what is that?
I think the area of the uterus where the placenta is inserted, you just cut it. You cut it and then remove that area along with the myometrium and suture it.
Yes, very good. One something else, triple P, what is that? Okay, so placental mapping, selective devascularization, selective pelvic vessel devascularization, and what is called as patchy myometrial resection. If it is a complete adherent placenta, you leave it as it is, go for obstetric hysterectomy, that's all. प्रिव्हियसली आय एम शुअर मागचे जुने जे खूप ऑब्सेटेशन असतील, मी सुद्धा 31 वर्षापूर्वी त्याच्या आधी ससून हॉस्पिटलला आणि इव्हन माझ्या यवतमाळमध्ये सुद्धा मी केलं आहे की प्लॅसेंटा इन्स्टिट्यूट ठेवलं आहे, मिथोट्रिक्सेट दिलं आहे, फॉलोअप केला आहे 15 दिवस 2-3 आठवडे, आणि मग त्याच्यानंतर ते मोस्टली रिझॉल्व्ह होतात, ॲब्सॉर्ब होतात, लोकिया म्हणून निघतात, होत आहे. पण ह्याच्यामध्ये खूप जास्त हँगिंग सोर्ड असतं की ही पेशंट सेप्टिसिमियात जाईल, ब्लीड होईल, शॉकमध्ये जाईल एनी टाइम ऑफ द डे और नाईट, आणि तुम्ही तिथून हलू शकत नाही. What the evidence say, there is no place for conservative management, there is no role for methotrexate nowadays. If the patient is multipara, preferably obstetric hysterectomy. If no, if she is a primary, maybe if it is a patchy adherence, then you can try and attempt to save the uterus by triple P procedure. That is all, I think, what the message we have to give. Always, as everybody is saying, try to reduce the cesarean sections, primary cesarean sections only we can reduce. Otherwise, once a Caesar, always a Caesar, as the old dictum goes. I think previously, as 30 years back, we used to not follow this because we were delivering the patients what we call it as VBAC. But nowadays, it is becoming very difficult. Previous Caesar, nobody wants to take a trial, nobody wants to give a trial, and that's the very reason best thing to do is try and avoid the primary cesarean section. So optimize the cesarean section rates. And for just the last message, I would say, take home message, that all of you will agree to me that we have lots and lots of points to learn also, the cases also. I would just say that obstetrics is always high risk. There's nothing like high risk obstetrics. Every patient can turn into abnormality any point of time. So you have to be very cautious, follow all the rules and regulations, follow the evidence, and of course try not to go for any active intervention, as you have seen the WHO guidelines for point of care for laboring patient. So the best way is, we are going back once again to masterly inactivity, though meanwhile we have followed the active management of labor. With this, I think we conclude our panel, and thank all of you for being such a quality and interactive audience.
Thank you, ma'am.
Thank you, my co-moderator, Madam Vidya Tirankar, and of course my very esteemed panelist, very interactive. Thank you so much.
Thank you, ma'am.
Thank you.
I request moderators to kindly facilitate our panelists.
We are immediately going to start the next panel, and after that we will have a lunch. Kindly note. All please be present in the hall.
Oh, I request Dr. Rane madam and Dr. Madan Kamble sir to felicitate our esteemed moderators. Thank you, ma'am. Now we will start with next panel discussion on optimizing pregnancy in high-risk patients in preconceptional period. The moderators for this panel discussion are Dr. Revati Rane madam and Dr. Supriya Arvari madam. And the panelists for this panel are Dr. Vivek Virkar sir, Dr. Vaishali Datar, Dr. Pradeep Patil, Dr. Ajnath Rajguru sir, Dr. Preeti Deshpande madam, Dr. Meenal Chudgupkar madam, Dr. Sanjeev Karande, and Dr. Nitin Rane sir. I request all the panelists, please come forward. We are short of time.
I request all panelists to please come forward. At the outset, I would like to convey regards from Gorakh Mandrupkar sir. Because of emergency, he couldn't join. And I want to give big thank you to Supriya madam for stepping up at 11th hour. So, मी त्यांच्यासारखी शायरी मला जमत असती तर मी त्यांना शायरीनी थँक्यू केलं असतं. सो I would like to really thank madam for coming forward, and I would like her to say few words.
काही हरकत नाही, तुझ्या वाटची शायरी मी करते. आपण ह्या कॉन्फरन्समध्ये आलो, त्याचं नाव आहे बरखा. तिकडे मदनाचे बाण आहेत, रेवतीसारख्या तारका आहेत. तर ह्या कॉन्फरन्स करता दोन शब्द. जीवाचा प्राण आहे, मदनाचा बाण आहे. जीवाचा प्राण आहे, मदनाचा बाण आहे. रत्नाची खाण आहे, रेवतीचे आसमान आहे. थोडक्यात काय, बरखा कॉन्फरन्स तुफान आहे. तर एकदा जोरदार टाळ्या अकलूज सोसायटी आणि सर्व इकडे त्यांची जी टीम आहे, दे आर डुईंग अ वंडरफुल जॉब. अँड वन मोर कॉंग्रॅच्युलेशन्स टू स्नेहा मॅम फॉर वॉट अ फायरी पॅनल. म्हणजे आय एम शुअर एव्हरीबडी इन द ऑडियन्स गॉट दॅट ओल्ड फिलिंग ऑफ गिविंग MD एक्झाम अँड द ओनली टू फॅमिलियर फिलिंग की मी नक्की फेल होणार.
So thank you. Today our panel is on preconceptional optimization of high-risk patient. So let's optimize time first, and without any undue delay, we'll start with the panel. So to optimize the whole, we should sub-optimize the parts. So as we optimize so many events, so many machines, so why do we take pregnancy so lightly? Why don't we optimize them preconceptionally, emphasize on optimizing them preconceptionally rather than managing them after the complications? So as taught by all our mothers and our teachers, that well begun is half done. So we are going to emphasize on preconceptional optimization to have a better mother and pregnancy outcome. So as we know, the diabetes is now becoming a pandemic along with the obesity. So we are going to deal with the obesity in pregnancy case first. So she is 32-year-old, para 1, death when abortion were, married since 8 years. LAC has done 6 months back and she has come to you for preconceptional counseling. As we see that her HbA1c is 8, fasting is 105 and PP is 180. So she is not controlled at all and she is not even taking medicine. Her weight is 72, height is 160 and BMI is 28, so she is obese. And as she had her one abortion 1.5 months back, it was a spontaneous abortion, 1.5 months. And her previous pregnancy, she had no ANC workup and follow-up and was diagnosed at GDM at 32 weeks. And full-term IUD, she delivered a full-term IUD, 4 kg, LSCS was done for CPD. So when we deal with this case who has luckily come to us preconceptionally, we know that she has not done routine ANC follow-ups and for some or other reason, maybe for white dishes or something, she has come to you. So would you like to, this question is to Rajguru sir. Sir, would you like to advise pregnancy at this current scenario?
Basically, this is a patient of bad obstetric history. First, he is having the first trimester miscarriage. And second is a full-term IUD.
Yeah.
And her HbA1c is 8. And fasting blood sugar is?
It was 105.
105.
Yeah.
And post is 180.
Yeah.
So we have to investigate this patient. And ideally, the HbA1c should be in between the 6.1 to 6.5 before the pregnancy. And blood sugar should be fasting less than 95, and post meal blood sugar should be in between the 120 to 140.
And also her weight is not also mentioned.
Yes, we have to advise her to reduce her weight.
Yeah. So in short, even if she doesn't have any live baby yet, and even if she is 32-year-old, she might come. I mean, ask her that no, mala ghai hai ki nahi laukar havai baal. But we have to wait and optimize her before she, take any risk further. So my next question, you have already answered this. But sir, what is HbA1c? Can you just let us know?
HbA1c is a glycosylated hemoglobin. It refers
So it basically gives us
the
average sugar level, sir, you mean?
Sugar levels in the previous 8 to 10 weeks.
Yes, yes. So for around 3 months, we get to know her what is her sugar levels on an average. So in this case, her HbA1c is 8. So what you have rightly said, it should be ideally 6.1 to 6.5. There are 2 reference levels, but most of the studies say that at 6.1, the chances of abortions and anomalies are minimal. So for 6.5, we can allow her. We cannot say like 6.1 parant jau de, you cannot conceive. But 6.1 is the
When the levels of HbA1c are more than 8, the chances of anomalies are increased by 2 to 3 times.
Yes,
and but if the levels of this HbA1c is more than 12, then the miscarriage rate is high.
Yeah, but again, if a patient comes to you who's already pregnant and her HbA1c is more than 8, in such situations, what would you say? Would you like to, advise her about abortion depending upon just HbA1c level? Anyone would like to comment?
Hello. First, I don't think so we would advise abortion immediately to the patient.
Yeah.
It is about controlling the sugars of the patient because that has been there for last 3 months. And if the patient has conceived, I think so we need to continue with the pregnancy and aggressive control of the with the initiation of insulin as early as possible, and getting down the sugars to the normal range is important.
Yes, so
in that
important take home message here is, on the basis of HbA1c we cannot advise abortion. We have to counsel her to get her sugars level corrected. We have to ask her to get a good anti-scan and other things, and in case of anomalies then we can ask her to get this pregnancy terminated. But HbA1c cannot be the criteria for abortion. But obviously before she has come to us preconceptionally, so here we have to ask her to wait. So this question, we have one physician among us, and for diabetes, of course, this is for all the cases we are going to discuss. It is a team approach. We all know that we have to work hand in hand to manage these cases in a better way. So this question is to you, Dr. Nitin. What are the target sugar levels during pregnancy? हे खूप वेळा होतं, patient randomly sugars कधीतरी घेऊन येतात आपल्याकडे. So how meticulous is and how should we monitor sugars? Can you just tell us briefly?
Many times it is that the sugar reports are done at some lab, and the reports, the normal range is not what is there for pregnancy. The pregnancy levels are different, and the normal sugars in other people are different. So when we are treating a patient in pregnancy, the fasting sugars need to be less than 95. Postprandial at 1 hour and at 2 hours is different. At 1 hour is about 140, and at 2 hours is 120. So you can find various guidelines giving us different recommendations, but the DIPSI guideline, that is the diabetes in pregnancy study in India, this recommends these kind of sugars. So that is important. We need to stick to one guideline, because there are many other papers, we say 150 postprandial, 180 postprandial, so those are different reports. This is the one that we follow in India.
This is very important, I will say,
And many times the patient comes with reports and they show to us that doctor sugar तर normal आहे, ह्याच्यात 100 दिलंय आणि ह्याच्यात 160 लिहिलंय. So you need to tell them that the levels are different in pregnancy and non-pregnant patients.
So how do you monitor? So
the monitoring of the sugars is also different. So if a patient, if this patient is a type 2 diabetic or a GDM patient or is a type 1 patient, we need to classify that first. If the patient is type 1 diabetic patient and already on insulin, then we need to start the patient on what is called a 5-point profile or 7-point profile sugar monitoring. In that we get different sugars done in the form of fasting, prior to breakfast, post breakfast, prior to lunch, post lunch, and prior dinner and post dinner, and 3 AM sugars. And specifically the 3 AM sugars need not be less than 60, otherwise the patient might have grave complications due to it, because those hypoglycemias occur at night in the sleep, and that might lead to sudden IODs of those cases. So monitoring is important, and those 7-point profile sugars need to be done till the time the sugars are controlled properly.
Yes, so this is very important, and this is what we routinely do in our hospital also. We have that 7-point profile chart made, and for the practical this thing, for initially when you need to start insulin to the patient, we can do those 7-point profiles while admitting her for 1 day at least, but later on she can do 1 sugar per day, and she can come after 7 days to you so that you can adjust the dose of insulin. Here 3 AM hypoglycemia is associated with either hypoglycemia, fasting hypoglycemia, or fasting hyperglycemia. So both the things that we know. So monitoring 3 AM sugar is also very important.
I would like to add one more point, that the sugar monitoring part, fasting, PPs and these things are done, but the patient when is on insulin, the intensity of monitoring should also be very high. If the patient is just on oral hypoglycemic agents in the form of say metformin or sometimes glibenclamide is prescribed, the intensity of monitoring may be once in 7 days or 5 days. But when a patient is on insulin, the patient needs to do at least 1 sugar a day, and that is also important. And these fasting PP levels, normal what people do, many times there are elderlies in the house who say, "Are jevan karun ja 2 tasani sugar द्यायची." So that is not how this is done in pregnancy. In pregnancy, we have got GCT, which is to be done with oral glucose challenge of 75 grams. So that needs to be followed. We need to give a chart to the patient, how the patient needs to come to the hospital. Many times they come fasting and give the sample and they don't eat properly, or they don't take the sugar of 75 grams. So we have those sachets available easily, which can be given to the patient, and then the sugar should be monitored.
So now we are optimizing everything. So we are trying to optimize the time also here. So I request our MOCs to please let us know. We are allotting 10 minutes per case. So we want to finish everything, because we need to give a proper message to everyone and finish every case. So which additional investigation would you like to do for Dr. Meenal? Because only monitoring only sugar is not going to be sufficient for her before she conceives. Yeah. So can you just quickly enumerate what? Yeah. Mike, please.
patient is diabetic, so we have to do the comprehensive analysis. It has end organ damages also, so we have to see the retinopathy is there or not with the fundoscopy.
Yeah.
With the renal function test and 24-hour urine protein, we have to see her nephropathy status also.
Yes.
Sometimes thyroid problems also are associated with this diabetes mellitus type 1.
Mainly when it is autoimmune. Yeah.
So we have to autoimmune causes, TFT, thyroid function tests are very important.
Yes.
And echocardiography, because we need to consider this cardiovascular
So
system also.
fundoscopy I would like to emphasize. आपण खूप वेळा थोडासा आळस करतो fundoscopyचा, but it is very important because as we all know that retinopathy itself is a contraindication to vaginal delivery. So getting her laser done, she has come to us to optimize. So getting her laser done, it is essential. So getting the ophthalmologist involved, doing because when we know that whenever there is associated nephropathy, she will have preeclampsia, preterm, IUGR and everything. So that has to be counseled properly, that these are the complications that you might have. So this is how it is not only optimizing sugar, it is optimizing the whole process of metabolic disorders caused by diabetes. So can we start oral hypoglycemic in this patient, sir, with this, or would you prefer insulin? If oral hypoglycemics, then which?
Yes, in this patient we can start the oral hypoglycemic agent like metformin. It is an insulin sensitizer. It does not increase the insulin secretion, so not associated with the hypoglycemia. The starting dose of this metformin is 500 milligrams. We can increase its dose up to the 2.5 to 3 gram per day. And main adverse effect of this drug is nausea, vomiting and diarrhea.
Yes, so sir,
we can give the metformin alone, and or we can give it with the other medicines also.
Yeah, so as we know, we practically, every patient is not acceptable of insulin. If insulin is acceptable, then insulin is the drug of choice. That is the clear take home message here. But for some reason, for monitoring proper problems or with acceptance of the insulin injections, then we might give metformin, but again it is category B drug and it crosses placenta and excreted in breast milk. But as per all guidelines, it is safety has been proved. So metformin can be given. For glyburide, as we know that it has higher incidence of maternal hypoglycemia, fetal macrosomia, later on fetal hypoglycemia. So as such, currently glyburide is not recommended. Yeah, so now if she has opted for insulin, we'll definitely go for insulin for this patient. Then which insulin and how? I mean, because we refer patient for insulin to physician, but at least we should know that which insulin they prescribe and how should we, what is their choice?
Till date, we were using the regular insulin which was available, and almost 90% of the patients still are on that. But there are various newer types of insulins that are available. And the ultra rapid or the short acting insulins are basically newer insulins like Lispro and Aspart, which has got an initiation of action within just half an hour. So the patient can just sit for a meal, then take the insulin, and the peak action is around 1.5 to 2 hours, and the duration of action is just 4 hours. So those are kind of ideal insulins which can be used in the patients. So previously the patient need to take the insulin at least half an hour to 45 minutes prior to their meals. So that can be avoided with this. The regular insulin, the human insulin which we use, is now been replaced by these newer insulins which are available who have got a better profile.
What is the cost difference? Is it,
Yeah, the cost difference is there. The regular insulin which we have is available at around 160 to 140 rupees, and the Lispro and Aspart insulins are available about 280 to 350 rupees range. So, but if you see the convenience of the patient and the whatever guidelines or the studies which are available, they support Lispro and Aspart, and the patient convenience is also important. Many times you are prescribing it to the patient, but if the patient is not taking it prior to meals, half an hour, 45 minutes, the duration of action or the sugars might not get properly controlled. So you are using a cheaper insulin, but that might land into complications for the longer time. Other types of insulin like mixed insulin which we use, like 30-70 or 50-50 which is available, that many times the type 1 diabetic patients are on those, and in sometimes those patients we need to shift the patient from those insulins to a regular insulin for proper control of the sugars, because treating those patients in pregnancy is different, and non-pregnant type 1 diabetic patient treatments
So we
different.
avoid mixed and fixed dose
Generally we
insulins,
avoid
yeah.
mixed because management of sugars is very difficult in those cases, because it's a longer acting insulin taken twice a day. with 2/3 in the dose taken to in the morning and 1/3 of the dose taken at night. But those patients, the sugars are not very controlled, the postprandial hyperglycemia is significant. And the newer insulins like long acting, which have got called peakless insulins, those can be given which have a duration of action of 24 hours. But those insulin needs to be given along with the regular insulins, because this will give you a certain range that a certain amount of insulin be secreted in the body. Adjustment of the dosage and everything needs to be explained to the patient. Generally, 1 unit of insulin decreases the blood sugar by about 30 milligrams. So based on that, you can actually educate the patient that you can adjust your dosage at home also if the sugars are high on the 7-point profile.
Yeah. So thank you. So she wants to know, I mean, this is the important part of counseling, I feel, that she and her family should know. So in spite of controlling everything, what complications she can face. So you can just enumerate. Yeah.
For the maternal complications are preeclampsia, polyhydramnios, sometimes preterm labor can happen, infections, everyone knows about it, and traumatic vaginal deliveries because of increased baby weight. And in fetal complications, we have congenital malformations, miscarriages, macrosomia, fetal growth restrictions, intrauterine deaths, stillbirths.
So in this patient, she already had bad obstetric history and she had lots of, so this emphasis has to be given for not to story repeat again. She has to, understand the process, and her relatives also should need to know that she requires rigorous control of sugars. So thank you. This was the first case. So to summarize it, the goal of preconceptional counseling in pre-gestational diabetes, we have to emphasize that it is a high-risk pregnancy. They should understand that we are high risk. We need to explain them good glycemic control for less than 6.5, lifestyle modification, explaining the risk, and this is important, and she should understand, identify, and should be able to treat her own hypoglycemia too, and her complete evaluation should be done. So over to you, Supriya ma'am.
Thank you, Revati. Thank you for all the nice inputs, panelists. And I can see Nitin sir is making the most of this opportunity. Revati इथे असून सुद्धा त्यांना इतकं बोलायला चान्स मिळतोय. And so we'll immediately go to the second case, and again I'll request you to please time us for 10 minutes. A 32-year-old para 1 living mother, married since 5 years, known case of chronic hypertension. She is on treatment, visited you for preconceptional advice. She has a first 3-year-old baby that was a preterm LSCS for severe preeclampsia, and the birth weight at that time was 1.2 kg. So obviously the baby went to the NICU and had a very rough, post-natal course probably. Since then she has been diagnosed as hypertensive. She is on treatment. So, sorry, Datal sir? Patil sir,
Pradeep Patil sir has just come. I request him to please join the dais. Yeah.
So, Datal madam na apan first question vicharuya ki what is this chronic hypertension, and can you enumerate some of the causes?
Onset of hypertension before pregnancy and after before 20 weeks of gestation, and it is continue after 12 weeks postpartum, and it is superimposed with preeclampsia and eclampsia. It is called chronic hypertension, and it is when systolic BP is rather greater than 140 and 90 to 100 called mild, and severe is 160 to 110 millimeter of Hg, when it is called severe hypertension. And causes, there are multiple causes like idiopathic essential hypertension, vascular causes like renovascular hypertension and aortic contraction of aorta, endocrine disorders like diabetes mellitus, Cushing syndrome, pheochromocytoma, hyperthyroidism, hyperparathyroidism, renal disorders like diabetic nephropathy, chronic renal failure, acute renal failure, tubal necrosis, cortical necrosis, and all this.
Okay, so now the next question is, what investigations are advised before planning this pregnancy? Yes, Virkar sir.
Investigations are totally depends upon the etiological factors, because she is a case of chronic hypertension. And already she has gone through the previous cesarean section and previous hypertensive phase. So I would like to divide the investigation in three parts. That is, one is a routine part, routine investigations, some specific investigations, and another specific, more specific investigations. Routine investigations which we are doing, blood, CBC, abdominal USG, and other urine examination. In special investigations, we must rule out the causes which are related to the kidney, renal functions, maybe blood urea, serum creatinine, 24 hours protein clearance, and other investigations which are related to rule out the renal causes. Then cardiac investigations in the form of, if she has gone in a previous normal cesarean section with hypertensive disorders. So sometimes patients may or may not be ready, but we must do 2D echos, chest X-ray for rule out the
left ventricular
hypertrophy. This should be ruled out. Next, some endocrine pathologies, maybe in the form of diabetes, blood sugar levels, then HbA1c, thyroid function test, free T4 levels, as well as what we can say T3 levels, T4 levels, and other TSH levels. And then we can go for fundoscopy to rule out any retinal pathology.
Just one quick question here. Yes, sir.
These are the investigations to be done.
Yeah. One quick question. This is just out of the syllabus here. But are any of the panelists or anybody on the floor doing routine 2D echoes before cesarean section? Because we know cardiomyopathy can come in any patient at any time. So is there anybody who is doing routine 2D echoes or anybody? Yes. Yes, Preeti, you are doing?
Hello. Yeah, actually now we have started the system of doing routine 2D echo of the patients before taking them. Actually, we don't know who will go for an LSCS. So now I have told, I recommend to all my ANC patients at term to take a physician's opinion, get a baseline ECG and a 2D echo done. Because anyone can go for an LSCS. For planned
at
LSCS,
least for our preeclampsia, mild and severe, we should advise.
The high risk ones, I insist. The others, I recommend.
Yeah. Datal madam, role of lifestyle modification preconceptionally. What would you recommend?
Lifestyle modification is very important in these cases. So regular exercise and maintaining basal metabolic BMI maintaining. Avoid alcohol and tobacco, regular exercise and maintaining diet chart, and that is restrict sodium intake 2 to 3 gram per day is very important.
आपण एक्सरसाइज म्हटल्यावर पेशंट म्हणते मी दिवसभर काम करते, मग हाऊ डू वी रेकमेंड, हाऊ डू वी काउन्सिल सच पेशंट्स? मी तर दिवसभर पायावरच असते, किचनमध्येच काम करत असते.
But just walk is, half an hour walking is also sufficient in pregnancy.
Yeah, so they need to be told that just kitchen मध्ये चालणं is not enough. At least 30 to 45 minutes of brisk walking continuously. That is the key, because they are walking, stopping. The continuous walking is important. Right. Role of low dose aspirin in chronic hypertension. Virkar sir.
Yes, it is definitely required. Actually, as we used to start low dose aspirin in such a cases, because starting aspirin, it will reduce it increases the uteroplacental circulations, as well as aspirin is required to balance the prostacyclin and thromboxane A2 levels. So aspirin should be started in each and every cases so as to reduce the chances of preeclampsia in already compromised patients. And the dose should be adjusted in such a way that actually it is 75 to 150 milligram per day at bedtime. But nowadays it is recommended that 75 milligram is enough at bedtime. It should be started from as early as hypertension is diagnosed. So it should be started at 8 weeks also.
Correct.
And it will be continued up to 48 hours prior to the induction of labor. So that period should be enough.
No
for
stopping at 37
Yeah,
weeks.
and that's the thing
There is
that
no
you know.
need to
So
stop at 36 weeks. We can continue it up to 48 hours prior to the induction of.
some
labor.
guidelines do say that start after 12 weeks, or we were taught in school or med school that it should be started in second trimester, but now the gestosis guidelines say start
Diagnosis
as soon as
guidelines,
possible. Yeah.
And now, yes.
Yeah. Next question is to Dr. Rane. What are the drugs of choice for this particular condition, and what are the drugs that are contraindicated in pregnancy? There are a whole lot of MRs visiting us, hey dya, te dya. What do we do?
Okay, so the guidelines say that there are basically just 3 drugs orally which can be given to the patient. And out of that, one is not easily available now. So first and foremost, if it is a case of chronic hypertension, we need to see what the patient already is on. So that is one important point. If the patient is already on ACE inhibitors or ARB inhibitors, those are absolutely contraindicated in pregnancy. We need to shift the patient on drugs which are available. The second thing, many times the patient is on amlodipine or metoprolol, like beta blockers, any beta blockers. Those patients need also to be shifted on drugs which are, I'll be telling next. Because beta blockers are obviously have some complications and fetal problems like IUGR and all those cases. So the patient needs to be shifted. And the drug of choice in pregnancy is always, as we know, labetalol, alpha and beta blocker, combined blocker. That drug needs to be started. And the most important point is we need to start the patient on, say, based on the hypertension, the profile of the patient, on 100 milligrams a day or twice a day. And based on that, we need to keep on increasing the dose. The maximum allowed dose is 2400 milligrams. So that is also important point. Many times it started on 100 milligrams OD or BD, and then you add a second drug to the patient, which is wrong. And if the patient is tolerating the drug and not having any signs of, say, bradycardia or any other problems related to beta blockers, labetalol needs to be shifted up gradually till the dose of 2400 milligrams. If the patient is having any complications, we can add a second line drug in the form of calcium channel blockers, which is nifedipine, which is used in pregnancy. The dose needs to be started again at 10 milligrams twice a day or thrice a day, can be got up to at least 240 milligrams is the dose which is accepted. But many times that amount of dose is not needed. And the third important drug which we previously used, actually methyl dopamine, which is not available easily now. That drug has got a central action and can be used along as a third line drug. So the first and most important thing is labetalol, and that needs to be started and dose needs to be titrated after.
Actually, alpha dopa has been relaunched by some companies. My question to you, sir, is how frequent would you want to advise your patient to check the BP at home?
Okay. Checking at home, many times now we know this electronic BP apparatus is available and patient keep on checking their BP every day. The recommendation for checking the blood pressure is 2 weeks after starting the therapy, because many times you see the patient keep on checking blood pressures and they have got variations. They give you a frantic call, doctor BP एकदम 144 दिसायला लागलाय आणि आता परत केला 120 येतोय, आता काय करू? So many times the anxiety, those things are also important. Prior to taking BP, there are some various guidelines. The patient need not have any coffee or tea or any stressful walking or any stressful event prior to that. 10 minutes the patient needs to be sitting properly without any hassles. Then the BP cuff needs to be proper. So all those things are also important. So I ask the patient to get the BP cuffs to the OPD if they come to you who are checking the BPs at home. Check the machine as well, calibrations and those things are also important. So 2 weeks, many times the patient comes to you, you can ask them to frequently have BP about every 2 weeks a day, and maybe then once a week is also important if they are doing it at home.
And once she gets pregnant, how frequently we would want to monitor her BP?
It depends upon the pressure again. If the patient is a newly diagnosed patient, you need to see the patient more frequently, maybe initially weekly. Then if the patient's BP get controlled, then twice a week or maybe every 15 days or maybe once a month is also okay.
Okay.
Sir, I have a question regarding labetalol. When using it at higher doses, do we need to think about the negative inotropic effect?
Okay. So that is, being an alpha and beta blocker, the mechanism of labetalol for causing hypotension is dual in these patients. And it is not the case that every time you find an alpha action which is prominent or a beta action which is prominent. So many times the patient gets the effect due to an alpha action which is peripheral, and the beta action again which is to the heart. So beta is again beta 1 and beta 2. There are two things. They say that the patient has asthma, so don't give beta blockers. It's not the case. Sometimes the patient tolerates labetalol in a very proper dose. So negative inotropic effect, if the patient is not having any major problems, I don't think so there would be any issue.
We are optimizing time here, so we are skipping this case and we'll move ahead with rapid fire. I request all panelists to be very precise while answering this. We have 5 minutes per case. Yeah. So first case is hyperthyroidism. I know we do not frequently find, but we do come across many patients, and rather we come across hyperthyroidism reports mainly in our first trimester, which is physiological mostly. But now she has come to us preconceptionally for advice. So when to advise, if she is a known case of hyperthyroidism, Dr. Virkar sir, when to advise pregnancy in such cases?
If she is known case of hyperthyroidism, patient should be euthyroid at least 3 months.
Yeah.
Or she should not have, or she should defer pregnancy at least 6 months if she has undergone thyroidectomy or radioactive iodine therapy. In that cases, she should defer, and the value should become to normal, means euthyroid.
So yeah, so 3 months is very important, for to optimize her. And if she is on any drug like if methimazole or carbimazole or PTU, so which is the safest drug? Do we need to change if she is on another drug? Which is the safest drug here?
Actually, PTU and methimazole, these two drugs are used in early and second trimester. Liver, means fulminating liver diseases are more common with the PTU. So these two doses, these two drugs should be titrated very systematically. Methimazole should be used in the second trimester, while PTU should be used in first trimester. Those should be titrated, and the chances of congenital anomaly with methimazole is more, so it should be used in second trimester, mainly esophageal atresia or this, and the fulminating liver failure is more with the PTU. So in first trimester, PTU is used in a titrated dose, and in second trimester, methimazole should be used.
Quick question to our physician here, Rane sir. Sometimes you put the patient for symptomatic relief on drugs like propranolol. When they get pregnant, whether we should continue those drugs, stop, what should we do?
It has been shown that propranolol causes all the problems related to beta blockers like IOGR and those things. Propranolol basically started for the sympathetic overdrive which the patient has. And if you see the patient is not symptomatically showing any of those signs, no tachycardia, no diarrhea, no sweating, so you can just down titrate the dose initially, see giving a half dose. Many times the patient is on 40 milligrams of propranolol, shift the patient to 20, try and reduce to a minimum possible dose, and sometimes get it off. So that it doesn't cause any major problems. It directly not you acting on the thyroid or anything, it is just controlling the peripheral symptoms of the patient. So if the patient is asymptomatic, you can take the drug off.
As an obstetrician, we have to consider what complications she can face, mother in her and in her baby. So this question is to Datar madam. What we should explain her, what complication we should look for?
Maternal complications are preeclampsia, heart failure, cardiomyopathy, thyroid storm, sudden heart failure. Fetal complications are miscarriages, preterm labor, placental abruption, in perinatal mortality and morbidity.
Yeah, so we have to explain them the obstetric complications also. Next case, this is a case of epilepsy. So we know that epilepsy is a common neurological disorder, and it has prevalence of 5.2% per 1,000 pregnancies. And we do come across patients who are on anti-epileptic drugs, and we need to manage them. So what is the effect of pregnancy on epilepsy, Dr. Meenal?
Hello. Women, 1/3 of women who have epilepsy, the seizures increase during pregnancy because it is attributed to the physiological changes that are leading to altered this anti-epileptic drugs clearance. So basically that clearance of anti-epileptic drugs can happen problems related to nausea, vomiting, which may cause missed doses, altered GI absorption, increased renal and hepatic clearance, and it has expanded intravascular volume, decreased albumin levels, and also there is a poor compliance due to fear of teratogenicity.
So basically, we need to see that she continues her drug and her efficacy of the drugs are decreased. So we have to consult the neurophysician or physician and get her doses adjusted.
Yes.
Which drugs are safe in pregnancy? Means which drugs, if she is on, we need to stop, and which drugs we should continue.
Dr. Rani.
We know about this that valproate, phenytoin, if the patient is already on, then carbamazepine, these drugs and already have known side effects on the fetus and development of the fetus. So these drugs need to be shifted, but the shift is not sudden. We need to gradually taper them off. If it's possible preconceptionally, we need to shift the patients early on. The basic safest drugs which we have right now are lamotrigine and levetiracetam. The next congener of levetiracetam, brivaracetam is also available in market, but the studies are not there on it, but being a class effect, I think so that can also be given to the patient. So the safest drug which presently the patients are put on is levetiracetam. The dose is about 500 milligrams a day. Then the shift maximum of 2500 milligrams a day is the dose that can be given to the patient. Many times we need to tell the patient that polytherapy leads to more complications. So if the patient is on 2 drugs, try and get the patient to on a single drug or get it to a minimum possible dose so that the patient's complications are decreased. So that is one important point.
Sir, if this patient is on Levipil and we have to do cesarean, so 2 days she is going to be NBM, how would you advise the injectable schedule?
Okay. Many times the people think that the duration of action is just for the dose that is taken to the patient. So it's not the case. It's when you give the drug to the patient, the drug levels are reached. So the drug levels remain. So even if you skip a dose of, then the patient generally won't have a convulsion. But many times we advise that you give a loading dose to the patient. Loading is 1 gram in these patients. So we have a readily available drug, ready preparation that can be given 1 gram, and you can skip 2 doses of the patient so that the night dose and the morning dose is there. If the patient is NBM for 48 hours, you might think of continuing the drug, and the patient started orally, then you can reshift the patient on oral drugs.
Okay, so this is a case of previous venous thromboembolism. Dr. Preeti Deshpande, what are the risk factors of developing venous thromboembolism in pregnancy? Can you just enumerate them?
Yeah, basically based on her prior obstetric history, if she is an APLA positive patient with a history of recurrent miscarriages or second trimester problems of preeclampsia and IUFD and stillbirth and all, and she has these lupus anticoagulant, ACL antibodies, beta glycoprotein antibodies positive, then she is high risk for and a candidate for thromboprophylaxis. Then other histories, like she has history of venous thromboembolism, which could be following a surgery and prolonged immobilization, or history of venous thromboembolization secondary to prolonged use of OC pills. Or then the patients who are known cases of thrombophilia, inherited thrombophilia. Then chronic medical disorders like renal problems, nephrotic syndrome. Then other things would be like patients with high risk factors who are elderly patients, which come in the low risk categories. They may not be having a history of venous thromboembolism, but due to their inherent factors like their obesity, elderly patients, she needs immobilization for a very long time. They might not need thromboprophylaxis, but we have to advise them all the preventive measures like keep moving your legs, prevent dehydration and such things. So, and then if a pregnant lady is going in for some surgeries, all these patients would be high risk.
Smoker also nowadays, more and more women are starting to smoke. When we were students, we used to happily say not applicable to our group of people.
It's more of tobacco in our area and smoking in big cities.
Yes. So, and also family history of thromboembolism equally important, because I had such a patient where her sister had landed up with pulmonary embolism, and I knew this, and this in spite of actually low molecular weight heparin therapy, she still landed up with because she missed some few doses when she went home. She still landed up with a pulmonary embolism. So this is also equally important. Yes, so now the next question of Dr. Patil, when do we start low molecular weight heparin, if at all?
We have to categorize whether she is a high risk patient or low risk patient. In patients with high risk, we can start in the first trimester, immediately after sonological appearance of the heartbeats. And in low risk risk patients, we can start it up to 28 weeks maybe.
Also, I guess patients, if she is like a known case of SLE and she is on warfarin, so maybe we would like to advise her pre-conceptionally
We have to switch over.
to switch over. Yes. What are the doses that we would advise? Low molecular weight heparin.
So it also depends upon the weight of the patient. Enoxaparin is the common drug used as 20 milligrams subcutaneously, a single dose with weight less than 50 kilograms. And if the weight is higher, we have to increase the dose up to 90 kg, it is 40 milligram, and up to 60 milligrams subcutaneously daily if it is 90 to 130, morbidly obese patients.
Dr. Nathan, how would you monitor such a patient? How frequently, how to monitor? And pre-op, how many days in advance do we stop? Suppose we are planning a cesarean.
Okay, I'd like to add one more point. These are the prophylactic doses that have been given to the patient. So prophylaxis is different and treatment is different.
Yes.
So these prophylactic doses are very less. Treatment is twice a day, 60 milligrams twice a day. That is the dose that needs to be given to the patient.
Correct.
So that is one important point. So you said about shifting also. The shifting also needs to be done early and the patient needs to be on heparin. For first 12 weeks of the pregnancy, again the patient can be shifted on warfarin again. So after 12 weeks till term, the patient can still be on warfarin again. So your question was?
How frequently to monitor and how to monitor?
So when the patient is on heparin, there are two heparins which can be used, unfractionated heparin and these are the low molecular weight heparins. Low molecular weight heparin per se don't need any monitoring, but if you need to monitor, if the patient has some kind of evidence of bleeding, there are anti-10A levels that can be done. So 10A levels need to be monitored and those 10A levels are different for prophylactic doses which is 0.6 to 0.1, 0.2 and for treatment for part it is from 1.2 to 2. So those are the different levels. The patient needs to be in that level. So what amount of 10A is decreased that needs to be seen. So doses can be adjusted.
So
accordingly.
PTNR for monitoring?
No.
Yeah.
Warfarin, PTINR is different. PTTK monitoring is done in unfractionated heparin. And
Yes.
INR monitoring is done in patients who are on warfarin or acenocumarol, the other drug which is
So this is
available.
an important point to be noticed.
So-
Yeah.
And how many days in advance do we stop
Okay, so the
before
duration
planning
of action
surgery?
for the drug is 12 hours. So if the patient is on low molecular heparin, just skipping of one dose is important. Many times 24 hours is also skipped because the patient is on long therapy. Warfarin has got a longer duration of action. So if that is on, that we need to stop early. They shift the patient in last week of trimester on low molecular heparin and just 12 hours you can skip one dose and take the patient. Unfractionated heparin can be given till 4 to 6 hours prior to the surgery because the duration of action of IV unfractionated heparin is just 4 to 6 hours. So till if the patient is very high risk or you know that the patient has a VTE or a PE, give heparin in the form of IV infusion in the dose of 18 units per kg and then stop the patient.
Yeah.
Okay.
So ma'am, we have, so we can take
Yeah.
this as rapid fire.
Yeah, we'll
and
take this
ask
as a
them-
rapid fire. We
Yeah, we have
skip
2
the
minutes.
thyroid
So in
case,
one
we have
line,
minute.
yeah.
So in one line, if all panelists can tell me what they would advise pre-conceptionally thyroid patients, how would you go about? One line for each panelist.
Hypothyroidism.
Hypothyroid cases.
Or we can ask the questions also. We have. like
Okay,
2
the
hands.
questions are ready. Dr. Patil,
Yeah.
if she is a hypothyroid and she is already conceived and come, can she continue the pregnancy?
Her TSH
and
is more than
frankly,
60.
at what level of TSH would you actually advise her to go for an MTP, if at all?
Actually, she can continue the pregnancy if she is not overt hypothyroid, or even with the even in the nowadays some guidelines say that in overt hypothyroidism as well, she can continue pregnancy. Then we can check. We can start with the
Treatment part,
thyroid
and-
treatment for the baby.
Yeah, so
Okay.
TSH per se is not the indication for advising termination. Yeah.
So Preeti, what are the optimal levels that you would want your patient to have before she plans her pregnancy as far as TSH is concerned?
As far as TSH is concerned, in general public, the normal 3 to 10 levels is there. But when she's going in for pregnancy, I would prefer that she would come in the range of 2.5 TSH. And when she is pregnant, like the ranges are for in the first trimester, the upper limit being 2.5. And in the second and third trimester, 3 should be the upper limit for TSH.
For Rani sir, isolated FT3 or FT4 level is low, TSH is normal. Do you recommend treatment?
So physiologically, normally we see that the TSH levels are low because the HCG is also taken over the first, second trimester overlap. There are very rare cases that we have just isolated T4 which is high or isolated T3 which is high. There are some nodules in the thyroid which are secreting that hormone per se in the form of prior to malignancy, pre-malignant state. So those cases. But that reports need to be seen properly by an endocrinologist or a physician properly, because just isolatedly having those are very rare cases. And so treating those patients, I think so it should be taken with a pinch of salt.
Okay. How frequently to monitor thyroid function, Preeti?
How frequently would be in the first ANC visit. Now in the routine ANC investigations, we put in investigation of TSH from the beginning. So if we find that the TSH is above 2.5, I would start her treatment. So in that case, when I'm starting the treatment, every 4 weeks, I would be monitoring the TSH levels till I get the desired levels. And then at that time, if the TSH is in the desired level, I would again repeat once in the second trimester and once in the third trimester. And otherwise, every 4 weeks, till the levels are reached, then again at 28 weeks and near term.
This is the, why it is hanged? It's hanged.
Oh, because we have finished our time.
Yeah, only the take-home message here, Gorakh sir wanted us to know that the universal screening per se, many guidelines say it is not recommended, but this is what the NHM has suggested, that all pregnant females must be screened at first antenatal visit by measuring TSH level. This is our old NHM guidelines. So we should, given a chance, monitor TSH and do TSH levels.
Also, when we treat with thyroid, it is important to stick to the same brand. Whatever we are using, that is something that we need to tell the patient, that stick to the same brand.
Preferably levothyroxine.
Sorry, sir?
Many important reasons to screen the patients for TSHs. Many of the clinical symptoms of hypothyroidism, they are in common with the pregnancy symptoms.
Absolutely, yes. Very correct, very well said, sir.
And even for
we
that
do still see patients
also.
with TSH 100, and she is otherwise had no problem in the past, and now with the pregnancy she comes to us. So that's very well said.
Thank you, ma'am, and thank
One-
you all the
one
panelists.
One more message, ma'am. In every high-risk pregnancy like hypothyroidism, hyperthyroidism, take the help of physician like umbrella in Barkha.
Like we took
Like
today.
umbrella
We did
in
it today.
Barkha.
And like we took today also.
And if you are smart, marry a physician. I'm saying that with a lot of conviction because my husband is also a physician.
We request moderators to felicitate all panelists.
Thank you so much. Thanks once again to Team Barkha and Solapur and Akluj Society. And thanks to Gorakh for letting me stand in his place.
Yeah.
Big shoes to fill.
And thank you, delegates, for staying
I
for our...
request Dr. Rashmika Harman, Madan Kamble sir, to felicitate moderator.
We are taking break for only for 15 minutes for lunch, and then we are going to start with very interesting session on Code Blue and important talk. So please come back. Yeah.
स्कूलपासून करायची दोन गोष्टी त्याच्यात असतात माझं
Chairpersons, Madhura Virkar madam, past secretary Solapur Vijay Society. Archana Khare madam, past secretary Solapur OBGY Society. Sushil Sarde sir, past secretary Usmanabad Society. Please. Also like to request to come Dr. Rashmi Kahar madam, our next speaker, for early assessment and stabilization of critical ill patient.
I request chairperson, just a second. Khurcha arranged. Actually, after this lecture, immediately we are proceeding with code blue session. That's why they've made these arrangements. नाही बसा ना लेक्चर झाल्यावर मग खाली येऊ आपण I request Dr. Sushil Sade sir to please introduce Dr. Rashmi Kahar madam. Can you see the CV sir? Yeah. This sir. Sidha, mic se sir.
Good afternoon. Dr. Rashmi Kharodkar Kahar. She is a consultant gynecologist, Amravati. She is the organizing secretary, AMOX 2020. She was secretary of Amravati OBGY Society, 1920.
I'm a part of the team only and I'm all yours, so there is no need of formal introduction. We can cut down the time actually.
Just to highlight that she is working tremendously in High-Risk Obstetric Society, AMOX, and she is very loving and supporting. That's what I would like to say. Yeah.
Thank you, Revati. Very good afternoon, respected chairpersons. And very good afternoon, respected seniors and dear friends who are in the audience. I extend my heartfelt congratulations to Dr. Madan Kamble, Dr. Revati Rane, Team Akluj, Usmanabad, Latur, Solapur societies for such a wonderful organization of Barkha. It's a massive hit, very successful. And I'm Dr. Rashmi Kahar and I will be talking on initial assessment and stabilization of critically ill pregnant patient. So what is the best indicator of a country's health and development? The best indicator for any country's health and development is the maternal mortality rate of that country. So we have come a long way and we have been very much successful in reducing the maternal mortality rate of our Maharashtra state and India also. But still we have 800 maternal deaths per day worldwide. And the deadly triad of knowledge deficit, communication gaps, and poor resuscitation skills is what it is responsible for maternal mortality during the management of a critically obstetric ill patient. So are there any specific issues to consider while treating critically ill patients? Yes, critically ill obstetric patients are totally different from critically ill non-obstetric patients. Why? Because there are lots of anatomical and physiological changes that are occurring in the pregnancy. And how the pregnant patient, critically ill pregnant patient is going to present to the clinician is totally different because the normal physiological variables are completely changed in a pregnant patient. How the patient is going to respond to your treatment, that is also different, and both mother and fetus are affected by both the treatment and the pathology. And what sorts of which obstetric patients are going to require critical care? They may have conditions specific to pregnancy. Like she may be a patient of preeclampsia, amniotic fluid embolism, postpartum cardiomyopathy, or obstetric hemorrhage. She may be having increased susceptibility in pregnancy, like thromboembolism, aspiration syndromes. She may have underlying medical disorders like congenital or chronic heart diseases, pulmonary hypertension, and acute kidney injury. Or there may be coincidental findings like she may be in diabetic ketoacidosis, pneumonia, or asthma. So let us assess a critically ill obstetric patient, and what are the principles of assessing? That first and foremost thing is the outcome of a critically ill obstetric patient is going to depend upon only and only initial treatment and management. We can say time is the most crucial thing in management of a critically obstetric patient. We can actually say that time is tissue in a critically ill obstetric patient. Assessment and management of the patient should go hand in hand. It's no use going on assessing the patient and then starting the management. Both the things should go hand in hand. And in the treatment of a critically ill patient, we have to always go by the prompt and the protocolized resuscitation regime. And one more thing, in critically ill obstetric patient, correcting the abnormalities in the patient should be more important than arriving at a diagnosis, because in a critical ill patient, there is no use of debating over the diagnosis of the patient, whether she is having PRES or eclampsia or eclamptic seizures or seizure disorders, but correcting abnormalities should be given priority. So what are the initial steps to be taken for a critical ill obstetric patient? The first and foremost is resuscitation when the respiratory rate is less than 5 or more than 35, pulse rate more than 40 or more, less than 40 or more than 140, systolic blood pressure less than 80 or more than 180. And this will be demonstrated very nicely after this talk. The second and most important step in the resuscitation is always give left uterine displacement. Always do left uterine displacement for the patient. Take very quick history from the relatives and go by organ-based systemic evaluation in the patient. We have to give a very special consideration to the gestational age of the fetus, and we always have to check if there is any sudden decrease in the level of the consciousness of the patient. And what are the vital signs to be assessed? The respiratory rate, pulse, systolic blood pressure, oxygen saturation, Glasgow Coma Scale, temperature, and urine output. As we all know, we have all learned respiratory rate, normally it should be between 12 and 20. It's the most sensitive indicator in a critically ill patient. Rising respiratory rate is a very early indicator of impending deterioration. And also check for the position of the patient. Is the patient using accessory muscles while respiration? Is there increased laborious breathing? What is the color of the skin of the patient? And is she getting exhausted while speaking? And also check if she is sleeping, or when she is sleeping, does she need to sit down to speak? The second important parameter is obviously heart rate, normally 60 to 100 per minute, and we have to note volume, rate, and regularity, and any abnormality has to be followed with ECG. Blood pressure, which is we routinely take, is a very late sign of deterioration in a patient. Inadequate perfusion leads to organ damage. So what is important is record of the blood pressure on the admission. It is very important. And systolic BP fall more than 30 millimeter or mean arterial pressure less than 60 millimeter of mercury indicates shock. Oxygen saturation, as we all know, pregnancy is a very hyperventilatory stage. Requirement of the oxygen in a pregnant patient is very high. 95% is the target saturation in pregnant patients. An acutely ill obstetric patient should always receive supplementary oxygen. And we should also go for ABG for in-depth analysis. And we have to check for the level of consciousness. We can see it by Glasgow Coma Scale and AVPU. AVPU is to note down if the patient is alert, if she is responsive to voice, does she giving very good response to painful stimuli, or she is unresponsiveness. And our anesthetist friends, they are very fond of using this Glasgow Coma Scale. They check the level of consciousness of the patient on these three parameters: eye opening, verbal response, and motor response. If this eye opening is spontaneous in a patient, or to the sound, to the pressure, or none, what is the verb? How she reacts to the verbal commands? Is she oriented? She is confused? Does she respond? Is she able to utter the words, or only sounds, or no response? And how she is reacting to motor? How is her motor response? How she is responding to commands? She is obeying the commands, or she is not able to obey the commands. Accordingly, we can categorize the patient into mild, moderate, and severe category. Urine output, a very important and a very sensitive parameter, 0.5 ml per kg per hour should be the normal range, which it indicates hydration and tissue perfusion, because most of the critically ill obstetric patient may also have concurrent acute kidney injuries. So urine output, recording of urine output is a very important parameter in assessment. Urine protein creatinine ratio should be, if it's more than 0.3, it is very significant. 24 hours proteinuria more than 300 milligram, urine albumin creatinine ratio more than 30 are very significant factors, and we should always go for complete urine examination in critically ill patient. Temperature is very highly sensitive indicator. Both the extremes, high or low, they are very indicative of deterioration in the patient. High temperature indicates sepsis. When there is sepsis, we have to check if she should not go into dehydration. We have to maintain the volume and hydration. If the temperature is more than 38 degrees, we need to go for blood culture. If there is extreme low temperature, then we have to know that hypothalamic regulation has been dearranged. And this is the multipara monitor. We all have this in our labor room. If we monitor diligently and carefully, it shows pulse, BP, oxygen saturation, heart rate. And it is, I think, it is for our level. As an obstetrician, it is more than sufficient. So diligent monitoring with multipara monitor in our lab, which is commonly routinely present in our operation theaters and labor room, is more than sufficient for us. So sometimes when the patient is critically ill and she is admitted, so sometimes we also need to go for invasive monitoring in the patient. When, for example, a critically ill patient has been hydrated, so how she is responding? Or she has been given some medicines and now how she is responding. In these cases, invasive monitoring, it is going to help us, because it will give us quantitative information about vascular capacity, blood volume, tissue perfusion, and cardiac pump effectiveness. But the best prognosticator of a critically ill obstetric patient who is admitted to you is a serum lactate level. So when it decreases, when the levels of the serum lactate decreases by 10% in 6 hours, we can say that the chances of mortality has decreased. So best prognosticator in a critically ill obstetric patient is serum lactate levels. And some laboratory parameters like acid blood gas analysis, metabolic acidosis, when the pH is less than 7.35 are also very suggestive of criticality in the patient. Another important thing in all critically ill obstetric patient is we have to think that for all critically ill obstetric patient, we have to think if she is in DIC. So when the platelet count is less than 1 lakh per minute, PT-INR is more than 1.5, prothrombin fibrinogen is less than 200 ml per liter, or degradation products are high, then we can say that the patient is in DIC. And this is the International Society of Thrombosis and Hemorrhages score system for diagnosis of overt DIC in humans. I think this is a very important chart, and we can put this chart in our labor room or operation theater, and we can monitor accordingly. So there is, and then a major constituent of our critically ill patient will also have PIH or preeclampsia. So we have a PIRS model, that is the preeclampsia integrated estimation of risk, or our own Gestosis Society's Gestosis score, which is going to help us in monitoring the patient if she is having high chances of going into preeclampsia, eclampsia accordingly. So with all this cumulative information, we can arrive at a diagnosis. So what is the diagnosis for this critically ill patient? So we will know that maximum cases of critically ill patient, 38% are due to hemorrhage. Other conditions constitute 34%, and the other important conditions are sepsis. She might have sepsis. She may be a patient of venous thromboembolism, or she may be a patient of some underlying medical disorders. So when we go for the detail, or say for example detailed investigation of a case, or we go for maternal death surveillance and response. So that when we attend those meetings, we come to know that what is the major cause of mortality in a critically ill patient. And it's very important to note that only the early warning signs and symptoms we could note, we can save the patient. So there are some clinical markers. They can help us to show some early warning signs and symptoms, like shock index. We all know that shock index is the ratio of heart rate and systolic blood pressure. Shock index, if it's more than 0.9, it needs serious attention in obstetric patients because it indicates hypovolemia and shock. And then there is very helpful rule of 30. So for example, in a critically ill patient, there is 30% loss in blood volume, or in any obstetric patient, there is 30% loss in blood volume. If her systolic blood pressure falls by 30%, if her heart rate is increased by 30, if her pulse rate is increased by 30, if urine output is less than 30 ml per hour, if her hematocrit drops by 30%, we can say that the patient is in critical condition. And this is a very simple rule of 30 by which we can monitor the patient. And then there is quick SOFA score, Q SOFA square. So this is very helpful for assessing if the patient is in sepsis or organ failure. So obstetric sepsis is a great enigma because even if we identify the pathogen and if even accordingly we give the antibiotics, most of the times we never know why the patient is deteriorating, even after complete treatment. And the critically ill patient, they tend to remain admitted to the hospital for quite a longer time. So obstetric sepsis is a great dilemma for the treating critical emergency obstetrician. So Q SOFA score is a very helpful tool. What we judge by this score is hypotension. The systolic BP is less than 100. If she has altered mental sensorium, or she is in tachypnea, respiratory rate more than 22. So score, if it comes more than 2, this criteria suggests a very great risk for poor outcome in the patient. How can we remember these Q SOFA variables? So we can think about the HAT, hypotension, altered mental status, and tachypnea. It gives a clear idea of obstetric sepsis or sequential organ failure assessment. The systolic blood pressure less than 90 millimeter, respiratory rate more than 25, and altered mental condition on Glasgow Coma Scale, which is less than 15. And if the infection is added to it, we can definitely say that the patient is in critical condition. So now how we are going to stabilize this critically ill patient? The principles of stabilizations are very simple. ABC assessment, airway, breathing, and circulation. And we have to transfer the patient to the appropriate level of care. So she has, accordingly we can label the patient like 0, 1, 2, 3, 4, 5. She may be admitted in the ward. We can identify high-risk patient. Then if more critical, we can shift to HDU. We can go for invasive monitoring. She might need advanced respiratory support or ECMO. And there is a trend in critically ill obstetric patient. Like what is good for mothers is good for fetus. And always we should give precedence to the health of the mother than the fetus. Not in the old movies they used to say like, kisko bachana hai, maa ko bachana hai, bacche ko bachana hai. So always and always, only and only maa ko hi bachana hai. What is good for mother is going to be good for the fetus, always. So airway maintenance should be the top priority. Pregnant patients, we know they tolerate hypoxemia very poorly. Pregnant patients desaturate very rapidly. And we also know that intubation is sometimes or most of the times very difficult in pregnant patients. Revati will say, what common things you are telling, ma'am? We are talking about artificial intelligence and hi-fi things, but I think this is the basic and we all know. And the second important thing is breathing and ventilation. We all know that patients might require supplemental oxygen, which can be given by high concentration oxygen mask or transnasal humidified oxygen, NIV, or we can also consider prone ventilation. We can also consider peripartum hysterotomy for helping the patient, and we definitely will need a multidisciplinary team regarding the management of fetal hypoxemia. A team of neonatologists, anesthesiologists should be involved. One important factor is GI support in a critically ill patient because we know pregnancy is a very high caloric state And pregnant patients are very prone for early ketosis. So in all pregnant patients, starvation should be avoided. We can also go for enteral route for maintaining the nutrition of the patient. And the most important part is maintaining the circulation.
Slides, please.
I think this is a very good slide. It has been obtained from the internet only. See, like the soil is yellow, then this is the lava, which is yellow, then the soil, which is gray, then grass, then the pink is the flower, and then the sun. Accordingly, when the patient is very critical, use yellow colored intracath. Then less critical, gray, then green intracath. Pink is for normal patients. Pink intracath is for normal patients, and that is the pediatric age group. And this is something I would like to say. This is a modified early obstetric warning system chart. This is a Carle's modified Muse chart. And it is of great use for our sisters and staff can monitor the patient accordingly. We can print and put these charts in our labor room. We simply monitor simple parameters like what is the respiration, oxygen saturation, BP, systolic BP, diastolic BP, heart rate, level of consciousness. And accordingly, we put the patient into green pathway, amber pathway, and red pathway. The green pathway suggests that the patient is comparatively better. Amber suggests that she might need intervention by treating obstetrician. And if she comes into the red pathway, we come to know that she is in a critical condition and she might need help of an intensivist along with obstetrician. Some other points to be considered are all the organ support should be given to the critically ill patient. Patient is going to remain admitted for quite a longer time. So sepsis control is very important, critically ill obstetric patient. Decision to deliver and mode of delivery has to be a combined decision. The anesthesiologist, the obstetrician, the relatives, and the neonatologist. What should be the type of anesthesia should be discussed prior. And specific obstetric disorders like HDP, DIC, AFE, PPCM, sepsis, they should be taken care of. There should be also a talk about if she is a parturing patient postpartum, then can she breastfeed the baby? So for example, she is in peripartum cardiomyopathy, and we know that the cardiac ejection factor is very less, and breastfeeding for such a patient will be a laborious job. So can we advise really breastfeeding in some patients in ICU? And there can be some ethical dilemmas in the treatment of critically ill patient also. Then some important considerations are consent. Whatever the procedures we are going to do for the patient, maybe starting from blood transfusion, blood cultures, or other procedures like anesthesia, operative procedures, everything should be taken consent. We have to respect the critically ill patient, and we have to communicate best communication with the relatives of the patient. The communication should be kind and compassionate. And because we know that we are treating a critically ill obstetric patient, now we are at the receiving end. And what is the most important thing is a very proper documentation of all the things that are happening, all the drugs that are given, all the clinical situation stages in the patient. Sepsis prevention, and if she is very critical, we can also consider organ donation in the patient. So what are the take homes? The treating critically ill obstetric patient is a very challenging job. It's very important to note that pregnancy alters the physiology of the organ system. What matters most is the earliest detection and intervention when it comes to decreasing maternal mortality. Thank you very much.
We request Chairperson to felicitate Madam. We also request Organizing Secretary and Organizing. Please join.
Hello. Now we will move towards the next task, that's Code Blue live demo session. The Code Blue live demo team is having Dr. Shraddha Patel ma'am and team from JNMC Wardha. As an obstetrician, we all must know the resuscitation part, because anytime emergencies come and if we are not prepared, then everything goes wrong and we have to affect it. Giving a brief intro of Dr. Shraddha Patel ma'am. She's having BDS in 2008, MDS in oral medicine and radiology, then fellowship in head neck imaging. She is pursuing PhD in oral medicine. She has additional qualifications.
Can I?
Yes, yes.
Yes. So good afternoon everyone. I think that you all are had a good lunch and you might be having a bit sleepy also. I am not going to take much of time, your time. See, I am in front of the August gathering who is already having an excellent clinical experience in their own profession. So I am not going into much detail of what exactly you need to know about CPR and why you need the CPR in the patients that you all are very much aware of. So I am going to focus that if you all are having such situation in your own premise, then how you are going to tackle it. For that, me myself, Dr. Shraddha Patel, who is an Director Academics in a simulation center in Datta Mege Institute of Medical Research, Savangi Mege, Wardha. It is a NAC A++ accredited university. I am having two of my colleagues, Dr. Teja Venu Yedla and Dr. Apurva Giri, both are the instructors and faculty in a simulation center. So, starting with, we all are aware that if your patient is going into an cardiac arrest, what are the reasons why your patient goes into a maternal collapse, how it should be recognized. The basic things are been already discussed by Rashmi ma'am. So, in all those situations, when your patient is or when you are not able to manage that patient and unfortunately that patient goes into an cardiac arrest, in that situation what you are supposed to be doing, that is what I am going to tell you. The first and foremost thing which is very important is recognition of those cardiac arrests, that we all know that if your patient is an unresponsive patient, if he or she is not having pulse and if he or she is not having respiration, in those scenario we need to go for an CPR. The one thing which ma'am has mentioned, that if your patient is in gasping, then specifically she is in an respiratory arrest, so you need to maintain the airway or you need to go for an airway management. Those all things are very critical. See, when things go good, then it is not at all an issue. But a single thing, if it is missed and if it goes wrong, then it is a pinpoint which can have a very much effect in our life. Me myself having a sister who is a gynecologist, the family is of doctors, so I can very much appreciate the tension and panic which can create that single issue. Okay. So, first and foremost thing, how you are going to recognize the patient if he or she is an unresponsive patient. In that, you are going to go for an recognition by tapping the shoulder. So, by tapping the shoulder, you can check that the patient is unresponsive. So, if patient is unresponsive, your second important thing is to check for pulse and respiration. We are going to check for carotid pulse and we are going to check for respiration by checking for the chest rise and fall. We are going to do all this thing in less than 10 seconds. You yourself are very much great in all those things. But for your paramedical team, you need to take a regular drill for all those things in your hospitals. So likewise, she has already checked for pulse and breathing for less than 10 seconds, and now if it is not there, then she is going to call for help. So whenever she is calling for code blue activation, if it is a private hospital or private institute, you need to have a team for a proper resuscitation module for your patient. In that resuscitation team, you should be having one inside team, and might be you will be needing a team who is coming as an expert from outside. In that case, in your inside team, your all paramedical staff should be knowing that they should be recognizing the condition aptly and they should be calling for help. Calling for help सिर्फ इतना नहीं, अरे कोड ब्लू हो गया, no, it will not work. It will work that if patient is in ward, they will be shouting that code blue is activated in ward. If it is in labor room, code blue is activated in labor room or wherever it is. So that should be created in your team. Second thing, the one person who is calling for help, the help will arrive from internal team. But one more person should be there जिसने code blue सुना है. He or she activating the experts by calling them outside your hospital premise. Okay, so that will be the second team. The call can be given to a medicine person and an anesthetist person or whosoever is a helpful people for you. Okay, after activating the code blue team, the person who has recognized the condition, he or she should be aptly starting the CPR within 10 seconds. Okay, so as soon as she has started with the code blue activation of code blue, she has started with the CPR. For that, we all know where we should be keeping our hand. The hand should be kept as she has already given in lower half of the sternum. You are going to check that your wrist, your elbow, your shoulder should be in one plane. Okay, and you should be giving compressions of 30 chest compressions and 2 ventilations. While doing it, there are 5 important points which you should be keeping in your mind, and you should be regularly get practiced by your paramedical staff team. In that, while doing the chest compression, the depth should be 5 cm deep, it should be 100 to 120 per minute, it should be having a complete chest recoil, and you should be having a minimized interruptions in between. Okay, so these are the key points which you should be keeping in mind while performing a CPR on a patient. But yes, your patient is a patient of maternal collapse. तो यहाँ पे आपका ये regular CPR थोड़ा सा alter होता है. We all know the CPR, but the protocol based things are important. So as soon as we have started with checking the scene safety, she has started with the chest compression, she needs a team. So who are the important team members from inside? One person who is going to do the chest compression, the another person who is going to take care of airway, the third person will be a defibrillator or an automated external defibrillator or defibrillator, whichever is available, and the fourth person who is taking an IV access for your patient. Okay, so these are the important points or important parts which should not be missed in that critical situation. If one of the point is missed, the result might be in an opposite direction. So to avoid that, we should be having this much team members in their own team or in their own institute. So as the compressor will be on chest side, the one person who is giving for an airway, he or she should be on a head and side of the patient. What is an important for an maternal collapse is at left uterine displacement. So the one person who is assist of that defibrillator will be either standing on the opposite side of the patient, opposite chest side of the patient, and from there they can do the left uterine shift, or you can have that 15-degree tilt. If you all are having that, that will be a good thing. Otherwise, at least the left lateral uterine displacement should be done. Okay. Likewise, in your first 2 minutes, as soon as your patient has collapsed, you have started with the CPR, your team has arrived. Now when your team has arrived, the trained people knowing their roles have taken their own responsibilities. after taking their own responsibilities, now what are the integral parts which you should be doing in minute to minute manner. So in first 2 minutes, as soon as your patient CPR has been started and the person who is on AED or defibrillator is coming, he or she should be starting with the defibrillator. If it is a manual defibrillator, you have to attach the leads, you have to check for the rhythm, whether it is a shockable rhythm or it is a non-shockable rhythm. So for that you have to have a team member who is knowing that how to place those leads in an emergency situation. That will be an important thing. Otherwise, you can have this sort of AEDs or automated external defibrillators, which are portable devices in which the commands are being given by their own, and even though there is a paramedic staff, he or she can use it very well. Okay? So this sort of AEDs can also be used. In those situations, if you are having manual defibrillator, then after attaching the manual defibrillator, you will be having those shockable or non-shockable rhythm. Accordingly, as soon as possible, you have recognized that rhythm is shockable, you should be able to discharge the shock. If it is a biphasic manual defibrillator, you will be going for an 200 joules shock. Okay? So in that you can have an PVT or you can have an ventricular fibrillation, and you can go within shock. As now right now they both are doing. The one who is started with the compression, she will be continue with the compression, and the person who is accompanying her will be going for an AED. If even though the AED is not working, the one person who is there, she will not be stopping the CPR. That is the main part. Okay? So likewise, the person who is on AED,
analyzing heart rhythm.
now AED is giving an command that do not touch the patient. So they are not touching the patient. Right now, if the first rescuer is thaka hua hai, so they can switch the roles. The one who is on compression can be on defibrillator, and the another person can continue with the chest compressions. So after all, giving the shock, they will continue with the chest compression. Okay? In those situations, the 2 members are already been started. By the time the third member who was on an IV, he or she should be taking an IV access immediately, because afterwards it will be very difficult to get an IV access for the patient. So by the time these actions are completed, the person who is an IV will be taking an IV for the patient, and the left lateral uterine displacement should be continued. So in first 2 minutes, what we have done, we have recognized the condition, we have started with the CPR. By the time if defibrillator is been attached, if it is showing the shockable rhythm, we have given the shock, and after giving the shock, we have again started with the CPR. So in first 2 minutes, we have given first shock and we have started with the CPR. In the next minute, by the time the CPR has been continued, we can go for a drug, epinephrine 1 milligram IV. Okay? So by the time they are doing it, the IV person can get it ready for you, and after completion of those 4 minutes, we are again going to analyze. So after every 2 minutes, you should be analyzing. In maternal collapse, after going for this 2 shocks and 1 epinephrine dose, if your patient is not showing any chances of revival, or if the condition is not improving, you need to activate your third important expert team, who is going to go for an emergency C-section. So by the completion of your 5th minute, you should be going for an emergency C-section. That is what the protocol says. Okay? So these are the something pick points which should be completed during your during any victim of cardiac arrest in a maternal situation. Now coming on to respiratory arrest, if your patient is having whatever madam has shown that she is having an gasping, or she is using an accessory muscles, or she is having a very low respiratory rate, in that case we have to maintain 3 things. We have to go for airway patency, maintenance of airway patency. Either we can go with head tilt chin lift, or we can go with jaw thrust. If your patient is having some spinal injuries or spine problem, then we are not going with head tilt chin lift, we will be going with the triple maneuver. So right now, if your patient is not having any spinal injuries, we are going with head tilt chin lift, and if you are not able to go for an advanced airways, you should be going with bag mask ventilation. The first and prime important thing is at least you should be having an airway patent, and after maintaining that airway patency, you should be at least going for an bag mask ventilation. So maintaining those seal in a bag mask, it is E and C clamp technique. With the C, you are going to compress the mask against the face to have a proper seal, and with this your 3 fingers which are showing the E, you are going to just lift the chin and having an patency maintained for your airway. So likewise, you can go for the ventilation, and the patient is in respiratory arrest right now. So we will be going one breath after every 5 to 6 seconds. So in 1 minute, we are going for 10 to 12 breaths per minute. Okay? These are the situation when your patient is in respiratory arrest. During the patient of cardiac arrest, the basic airways are been already started, but if we want to go for an advanced cardiac life support for that patient, we should be going for an advanced airways. Rashmi madam has told that intubation is a bit difficult for the pregnant ladies. So yes, if the intubation needs expertise, everyone can't go with the intubation, but in that case we can always go for an advanced airway, that is an supraglottic airway, LMA, laryngeal mask airway, which is very easy to put. It can be taken with a minimal expertise for any person, and it takes hardly 10 seconds. Also, the one point which we have said that during our high quality CPR points, we should be having minimized interruptions in between chest compression. So by keeping that advanced airway in place, LMA in place, we can minimize that interruptions in between compression. Why? Because as soon as you are getting the advanced airway in place, in that scenario, you will be now going with one breath every 5 to 6 seconds. So after 30 जो आपका 2 breaths के लिए discontinuation हो रहा था compression, that will be avoided, and it will be continued with 30 compressions, and by the time the respiration will be also taken care of. Okay? So these are something big points which can be utilized in the resuscitation attempt. After putting this particular advanced airway in place, we can attach ETCO to it, which can give a very good indication that how our compressions are going on. Okay? So while going for all these things, these are the big points which you should be keeping in mind. That first, recognize aptly. For recognition, check for response pulse breathe within 10 seconds, call for help, and start with apt CPR. And whenever the team is coming, the team should be going for their own roles and responsibilities. They should be going one for compression, one for airway, one for defibrillator, one for IV access. Okay? And as soon as the defibrillator is been attached, you should be going for giving a shock, and after delivering a shock, again continue with the compressions. So these are some pinpoints which we should be keeping in mind for dealing with cardiac arrest in a maternal collapse. And in maternal collapse, one more thing which I have missed right now, that left lateral uterine displacement should be done. So that's it from my side, because we are having that time management constraint. So if anyone wants to ask anything, they can ask.
Any questions particularly?
Yes, ma'am.
Yeah.
Ma'am, yes, that's what I have said. As soon as you have started with the CPR, okay, so if it is in shockable rhythm, then after delivering 2 shocks, you will be going for an first dose of adrenaline, and you can repeat that adrenaline till after every 3 to 5 minutes. In your maternal collapse, it should be going 5 minutes के बाद में आपका इमरजेंसी सी सेक्शन हो जाएगा, तो फिर उसके बाद में आप लोग आपकी ये रेजिम कंटिन्यू कर सकते हैं. 2 drugs which will be very important. After 2 shock, first dose of adrenaline, and after 3rd shock, amiodarone 300 milligram. Okay. Anything else? And second dose of amiodarone will be 150 mg. Anything else anyone want to ask? Thank you. Thank you, Teja Apurva.
Excuse me, ma'am. I request organizing chairperson and organizing secretary to felicitate ma'am. Also join our president, Dr. Vinod Chetty sir.
An academic feast for everyone. And the panel discussion, I have attended it for a very short time, but whatever the panel discussion was going on, it was really fantastic.
All us, you have traveled from such a long distance. So
That's very fine. Thank you. Thank you. Sir, किसी एक को
I request Dr. Vivek Joshi sir to come on stage.
And we request our chairpersons to please kindly join back. Dr. Sushil Sade, Dr. Archana Khare, and Dr. Mrs. Virkar. I request Archana Khare madam to please introduce Dr. Joshi sir.
Dr. Vivek Joshi sir, he has many publications on averting clamping for limiting blood loss at C-section, pectineal ligament suspension of prolapse vaginal wall, partial ischemic necrosis of uterus following a uterine base compression suture, a new technique of uterine suspension to the pectineal ligament in management of uterine prolapse, and internal iliac artery ligation for arresting postpartum hemorrhage. Sir is MD Obstetric and Gynecology, Diploma in Endoscopy, and Director at the KM Hospital, Pune. Over to you, sir.
Thank you, Chairperson, for that nice introduction. Now, what I am going to talk to you is about the future of pelvic hemorrhage. Now, with the help of good uterotonic agents, good obstetric care all over, even including the district places and availability of blood and blood products, the maternal morbidity and mortality due to PPH is decreasing. But now we have got another enemy on the horizon, and that is rapidly increasing incidence of placenta percreta or placenta accreta spectrum. Probably the incidence is rising so much that today, as I am speaking to you, the incidence of this disease is almost 1 in 256. And we are responsible for it because we have got increased rate of cesarean section, elderly people are conceiving, and of course the IVF conceptions, myomectomies, etc. So why the placenta invades is because the same reason why Russia has invaded the Ukraine. And the reason is greed. Greed for money, greed for power. Here the greed is for oxygen. The baby or the fetus needs more oxygen, and in a scarred uterus the oxygen supply is limited, and therefore the placenta keeps on invading. Initial stages it is just accreta, then it becomes goes inside the myometrium, which is called as increta. Finally it invades outside, then we call it percreta, and then it arounds the surrounding organs like the bladder, rectum and the parametrium, making situation more and more worse. So this is the classification which you should know. The grade 3C is invasion of other pelvic organs and tissues. Now what is important here, can I have a pen drive? Pointer? What is the difference? What happens when, as long as it is increta and when it becomes percreta? You can see in that Look at this. These are called as newly formed vessels. This is what you should know. These newly formed vessels invade from the placenta through the bladder and the surrounding tissue. These are the vessels which are of large caliber and they lack the muscular force. Therefore, when they are injured, if you try to dissect in this particular field without a good proximal vascular control, they are going to bleed massively. Now I am going to show a video taken 13 years back when I was just being exposed to this placenta accreta spectrum, and two take-home messages. One, how it really looks, and when you identify it and we are not used to it or you are not prepared for it, the best is to close the abdomen and send the patient to a tertiary care center. And number two, whatever is the initial diagnosis of placenta accreta or not, by sonologist or by MRI person, the final diagnosis of placenta accreta and increta and percreta is on the table. So you should be prepared when a patient comes to you with previous cesarean section or a previous myomectomy and a placenta which is low down. It is placenta accreta unless proved otherwise. So you be prepared for it. If you are not prepared, then you are going to land up in code blue. Look at this now. This was the patient referred to me with previous 2 cesarean section and a low-lying placenta, and I was demonstrating this for internal iliac artery ligation. So I excised the scar and went into it. And see this, get it engraved in your mind. There are 2 things which look. One is the uterus is bluish, and number 2, there are big vessels which are running across the uterus. This is frankly a placenta. I was not aware of this because the sonologist has reported as a placenta previa. So I started dissecting the bladder, thinking that let me take out the baby. Maybe this patient requires hysterectomy, so I'll be quickly clamping the uterine and saving the patient. So this is something which never ever should be done. Can you see that bluish view and the vessels? So if such thing is encountered, you please close the abdomen. Or in case there is a fetal distress, you may do a classical cesarean section, take out the baby, suture the uterus and shift the patient to a proper place. So see this. Once you injure these newly formed vessels, so this is the importance of newly formed vessel. They bleed massively because of thin muscular layer and big lumen. The blood which comes out is always bright red and it is massive. You know that 700 ml of blood flows through the intervillous space every minute. So a patient can bleed at that rate and nobody is able to replace that much blood loss. Therefore, the patient undergoes a cardiac arrest or anything. These patients also should have blood and blood products kept ready. So I just wanted to show you this video for these 2 reasons, how the placenta percreta looks like and what is the thing which you should not do. Okay. So anyway, I managed this somehow, did a hysterectomy on her. You can see that after removing the placenta, it is completely adherent and the uterus was thinned out. The bladder also had some injury which was repaired and the omental flap was taken. The management of placenta accreta spectrum is in 4 stages. The classical, most recommended is cesarean hysterectomy with or without proximal vascular control. About that we'll talk later on. Classical section followed by delayed hysterectomy. That means you take out the baby through a classical incision, don't disturb the placenta, close the abdomen and the uterus of course, and then open the patient again after 4 to 6 weeks, hoping that the blood supply is decreased, the vascularity is less and the bleeding will be less. The problem is the patient gets 2 laparotomies at the interval of 1 month. Number 2, the tissues, though they become less vascular, there is tissue friability and some amount of sepsis. So I found out that this technique of what is called as a deferred or a delayed hysterectomy does not help much. Uterine conservative resective surgery is coming up where if there is a focal adhesion, placenta is not completely adherent, but it is focally adherent, that much part of the placenta with the uterine tissue can be excised and the uterus can be repaired so that in a young patient you may conserve the uterus. And the last is the classical section with placenta left in situ, means a total conservative approach if the patient insists on it. But remember, if you do this, you are responsible for next 1 year for the patient because it takes 1 year for the placenta to get absorbed. Anytime she can come with sepsis, secondary hemorrhage and other problems. Therefore, this is not really advocated except when the patient insists on it, especially in our scenarios. Informed consent, multidisciplinary team, you all know this. What is more important is that the vertical incision and classical cesarean delivery to avoid the placenta. At any cost, you should not touch the placenta, because once you touch the placenta, you are going to injure the newly formed vessels. There are some people who do an intraoperative ultrasound to know exactly where the placenta is, up to what level it is extended to it. Now, what is important is the proximal vascular control. So, how to avoid or decrease hemorrhage in these cases? That is by proximal vascular control. You can have proximal vascular control at many levels: uterine artery, internal iliac artery, common iliac artery, and finally the aorta. The control can be obtained by various methods. You can ligate it, you can clamp it temporarily, you can embolize it, or you can put a balloon catheter. Balloon catheters are now becoming more and more popular, wherein you put the balloons through the vessel, through the femoral, and right up to the aorta you can put. So you can see that the balloons can be put. This is of course what is called as an infrarenal aorta, that is the zone 3 which is ablated. Now if you ligate the internal iliac artery, I have found out that the results are not good because of the extensive communications between the external iliac and the aorta and the internal iliac. And therefore these people, if you do internal iliac artery ligation, do not benefit much so far as the blood loss is concerned. So what I devised is that now this is the abdominal aorta, as you can see, lots of branches. Now where we do this is here, just above the common iliac artery. Because all the vessels are given away, the renal vessels, the ovarian vessels, and the lumbar vessels, all are given away. And therefore, when you temporarily clamp it here, you are not going to jeopardize blood supply of any other organ, except that you are obliterating the blood supply to the common iliac and the median sacral artery. Now, previously, what was being done with aortic clamping was that you go behind the aorta, as you go behind the internal iliac with the help of a mixture. The problem with this is the fourth lumbar artery. So if in this process, you may injure the fourth lumbar artery. Now, if you are a vascular surgeon, it's fine, you can repair and all these things. But for an obstetrician to do this procedure, I found it is dangerous. Therefore, what I thought, that let us not go posteriorly, just dissect the lateral portions and then take the advantage of the convexity of the vertebra. That takes care of the posterior part, and just apply the clamp on the lateral side, and it gives full occlusion of the. So this is what is done. This is the operative photograph. You can see this is the fascia that is resected. That means when you open, just open the peritoneum over it, and there is a fascia. You follow? Now dissect between the fascia and the aortic wall. Therefore, the vena cava which is on the right side is automatically protected. You do not see the vena cava. Believe me, this is a very simple procedure. We have done it now 50 times without any complication. I have published it. I'll show you that. So what is important? This is an intrafacial dissection. Therefore, we are not bothered about the vena cava. That is the only structure which is comes here. On the left side, there is nothing. Anteriorly, there is nothing. We are not going posteriorly. So it is a very, very safe procedure so far as intraoperative problems are concerned as compared with the balloon occlusion. And then you apply this DeBakey clamp. This is called as the DeBakey clamp. Costs 5,000 rupees only, very traumatic, and this can be applied just above the bifurcation of the common iliac arteries. Just go laterally, don't go posteriorly, and then confirm that the pulsations are gone by the pulse ox on the dorsalis pedis artery. Now this is one operative photograph showing that this is the newly formed vessel which I described to you, going from the placental bed to the bladder. Now these vessels, if they are more than 7 millimeter in diameter, they should be individually ligated, because normally what I use is the vessel sealer devices like the ligature. You use it for laparoscopy. It is available only also for open surgery. Ligatures do not work if the vessel size is more than 7 mm. So a big vessel should be individually dissected and ligated. The bladder is identified by filling the bladder with about 30 to 40 cc of fluid, and then it is elevated. You can see B is bladder. So it is elevated, and then these are the vessels and then you can do dissection here at this level. If the vessels are small, you can use ligature. It cuts and coagulates, and therefore you save a lot of time. These are some of the specimens of placenta percreta, as you can see, going right, coming right outside the serosa and going into the bladder. Now I will show you what is the right technique that is being done. I showed you the first video was the wrong, taken back, no, and that can lead to morbidity and mortality. So what is the right technique? Take a vertical midline incision, a big incision. Don't be confused in taking this incision. You can go at least 4 to 5 centimeters above because you have to reach the aorta. Then take a classical incision avoiding the placenta. Now you can go at the fundus or even you go posteriorly, it doesn't matter, but at any stage do not disturb the placenta. Then take out the fetus and close the uterus, yes, so that the bleeding, whatever oozing is there, is not there. So once this is sutured, then you start with the round ligament. After round ligament, you take the tubo-ovarian ligament. So part of the blood supply to the uterus and the placenta is cut off. At this stage, now clamp the aorta. Because there is no need to clamp the aorta when you are doing these first steps, and therefore you decrease the aortic clamping time. So this is the aorta and that is clamped. Right? Once this is clamped, now the bell rings. Now you have got limited time. So now start dissecting the bladder. You can see here how the bladder is being dissected. It is a very, very delicate dissection as far as possible. But the reason is that once the aorta is clamped, the bleeding is minimum because there is no blood there. In absence of an aortic clamping, I have encountered massive hemorrhage. Patient always used to go bleed at least 2 liters, 3 liters. And massive blood transfusion was required. Patient always used to go to the ICU for some reason. There was morbidity and they had one mortality also. So that is now all gone with the aortic clamping. So this is the individual vessel ligation which I have shown. So that is cut. Once the bladder is dissected down, the bladder may be adherent. Many times the bladder is injured. Very rarely you have to excise the posterior bladder wall also. But in the majority of the cases you can save this. So that is how you can see how the bladder is dissected. And now this is the use of ligature. So you can easily cut tissue. So in between the bladder and the lower segment, use ligature, right? More than 7 mm vessels individually ligated. So with ligature, you dissect the bladder down. You can see with one hand, I am holding the bladder and in the other using the ligature. Once that is done, these are the uterine arteries. They are cut, clamped, cut and ligated with the help of 1 number polyglactin, that is Vicryl. Then the Macken rods and then the specimen is out. As soon as the specimen is out, then the clamp is removed. While removing the clamp also, the clamp is so slowly removed because there is what is called as a reperfusion injury, and therefore you send the patient's blood gases immediately. Now here you can see that there is bladder has undergone a demuscularizing injury, that is the Foley's bulb, you can see balloon. So that part has to be repaired with 2-0 polyglactin sutures. And then the catheter must be kept for at least 1 month because some placental bits can be there near the bladder. So these patients can have a fistula later on. So the bladder should be repaired and the bladder should be supported with the help of the omental flap. So that is mandatory in such cases. Now this is one study which we did. You can see clearly how as a proximal vascular control, internal iliac artery ligation compares with aortic clamping. And you can see clearly the blood loss estimated was extremely high, whereas with aortic clamping it is reduced. The ICU admissions have been reduced, morbidity is less, ureteric injuries are less. So it proves that aortic clamping is much superior to bilateral intervention, and this has been proved not only by me but by many other authors also. Now this is comparison of balloon occlusion of aorta. Now balloon occlusion of aorta may or may not be available in many centers. Number 2, you have to put balloons in all cases. Even if it is placenta acreta suspected, it may not be there on laparotomy. Number 3, balloons have got complications like damage to the aorta, then there can be thrombosis. Some people have undergone even the ischemia of the lower limb. And if you see the series, the blood loss is not much reduced. The reason is probably the balloon does not occlude completely the aorta, but aortic clamping completely occludes the aorta. So this is another disadvantage of balloon occlusion as compared with the aortic compression. And we have done this now in more than 50 cases, and of course we published this report. Now this is just a triple brief. Now we have published this article as the first case series in the world literature of aortic clamping by the obstetrician in the FIGO journal, that is International Journal of Obstetrics and Gynecology, FIGO journal. And we have done it in many cases, 20-25 cases. The occlusion time was from 15 minutes to 70 minutes. There was no intraoperative complication. Post-operatively also, there was no damage to any organ, any vascular injury to the limbs. And there was one incidence of a vesico-vaginal fistula, which we repaired later on. So it's a very safe and sound procedure and can be easily followed. And believe me, it is not all that difficult. In fact, internal iliac artery ligation is much more difficult than aortic clamping, because there you have to do it at two places. There is internal iliac vein, ureter, external iliac artery, so many other structures are there. Here you have to be careful only about one, and that is the inferior vena cava. And that is, if you do intrafacial dissection of the aorta, then the inferior vena cava will never ever be injured. However, for medical legal reasons, you have to keep the vascular surgeon on standby, which we always do. We always tell them he may or may not be in the OT, but he should be there at least when you are doing first few cases. So thank you very much for the patient listening. And I thank the Occlusive Obstetric Society, Dr. Kamble and Dr. Rane, for giving me this opportunity to come and talk to you about the future of this thing. The reason is that younger generation must know the incidence is 1 in 256 now. 10 years down the line, it may be 1 in 200. And then there are lots of morbidities, mortalities not reported because these are accidentally recognized on table, and then enthusiastically you go on doing something. So this is a warning sign, or rather a warning for everybody, that this is not a simple thing. It has got 40% mortality if done in a center which is not equipped to manage placenta accreta spectrum. Thank you so much.
Thank you, sir. Thank you. I request our chairperson to please felicitate, sir. I would just say की आता आम्ही म्हणजे सर हाडाचे शिक्षक आहेत, हाडाचे सर्जन आहेत, आणि आम्ही ब्लाइंडली सगळ्या प्लासेंटा, ॲक्रिटा आणि परग्रिटा सरांना रिफर करतो. सो वी आर रिअली ऑनर्ड टू हॅव अ सर्जन लाईक दिस फॉर अवर सोसायटी. थँक्यू सर.
I feel like an obstetrician rather than an obstetrician, orthopedician now.
I request organizing chairperson and organizing secretary to join felicitation. I request felicitation of speaker Dr. Vivek Joshi sir by chairperson. And please join me.
अरे अजून एक? डिलीट करून टाक. माझ्यासमोर डिलीट करून कुठलं वालं सर?
हां बाहेर आहे तुमचं हो आहे
सगळं डिलीट करून
एकच आहे ना एकच कॉपी
एकच आहे.
Thank you so much for chairing this session.
Oh, thank you.
For chairperson.
I request Dr. Minal Chidgupkar ma'am, Dr. Kanchan Jadhav ma'am, and Dr. Vijay Deshmukh sir join as a chairperson for next session. I request our next speaker, Dr. Jaya Kore Tulaskar ma'am, please come on stage.
We request Dr. Jyoti Sood to please join as a chairperson for the next session. We request Dr. Minal Chudgupkar Madam to please introduce Dr. Jyoti Kore Tulsakar Madam.
Kore. She has done her MS OBGYN with gold medal. She has done diploma in reproductive medicine and infertility from Germany. She is consultant at Tulaskar Hospital. She is a former assistant professor, Savangi, DMIMS.
Ma'am, it's okay.
Okay. So she has done lot of publications. She has got lot of gold medals. Here to you, madam.
Thank you so much, ma'am, for the kind introduction. Respected seniors, good afternoon, and my dear friends. Today, I'm going to talk on current updates in medical management of severe preeclampsia. We know over 10 million women around the world develop preeclampsia annually, and 76,000 pregnant women die each year from preeclampsia and other hypertension disorders globally. In our country, incidence of preeclampsia was found to be 10.3% and 1.9% eclampsia cases in all the pregnancies. 1 in 16 preeclampsia patients develop one or more complications in future. They will have, in future, can have end-stage renal disease or many severe cardiovascular diseases. Many maternal and fetal deaths or near misses are associated with the substandard care which can be improved. Preeclampsia has ambiguous presentation and predictable progression. We often see one day we have patient with blood pressure 140/90 and patient convulses the next day or may go into the renal failure. So it's not always like preclinical preeclampsia, then overt clinical preeclampsia or eclampsia. Less than 40% women only exhibit both hypertension and proteinuria before the development of overt preeclampsia. And 22% have diastolic blood pressure less than 100, still they have the eclampsia. So there is so much diagnostic challenge to diagnose the cases such as atypical preeclampsia. There are major changes which has occurred in the classification of preeclampsia. No more PH we are using, the SDP is there, eclampsia term has been removed, chronic hypertension has been added, and there is no diagnostic criteria which has only proteinuria. The term mild have been excluded, and we have early onset or late onset preeclampsia. So we are classifying hypertensive disorders into 4 major groups: preeclampsia, chronic hypertension with superimposed preeclampsia, and gestational hypertension. So this is the revised classification we know. When the new onset hypertension, blood pressure more than 140/90 at 2 separate occasions, 4 hours apart after 20 weeks, associated with proteinuria or other maternal organ dysfunction, renal insufficiency more than creatinine 1 milligram per dl, or liver involvement or neurological complications or hematological complications such as thrombocytopenia, DIC or hemolysis, or uteroplacental dysfunction such as fetal growth restriction. Because of the use of this inclusion of the fetal growth restriction, the number of women fitting into the diagnostic criteria have been increased. So we have clinically early onset preeclampsia where less than 34 weeks of gestation, and late onset preeclampsia more than 34 weeks of gestation. In early onset preeclampsia, it's associated with the more severe maternal complications, low birth weight, iatrogenic prematurity, and IUGR as compared to the late onset preeclampsia. We classify no more mild moderate because if we use the term like mild or moderate, our approach also becomes mild or moderate. So we have now severe preeclampsia and non-severe preeclampsia. In non-severe preeclampsia, when the blood pressure is more than 140/90 but less than 160/110, no premonitory symptoms, normal SDP laboratory parameters. Severe, when blood pressure is more than 160/110 with or without premonitory symptoms, with or without the abnormal SDP parameters. If the blood pressure is less but with premonitory symptoms or abnormal SDP parameters, we also label that patient with preeclampsia with severe features. So going on to the main thing, that is management of preeclampsia. We have maternal surveillance and fetal surveillance. In maternal surveillance, risk stratification scores, markers, we have biophysical and biochemical. Earlier we had nice prediction score or ACOG 2018 where we used the high risk factor, if one high risk factor or more than one moderate risk factor, then we used to label patient as at risk of preeclampsia. Our own is SDP gestosis score. Ma'am has already told about it, but I will just brief. It is simplified, feasible, systematic quantification of maternal risk factors, which is good for our low and middle income countries, easy to use. It involves all the existing and emerging risk factors. The score of 1, 2 or 3 is allotted to each clinical factor. If the score is more than 3, then we mark patient as at risk for preeclampsia. So this is the gestosis score where we give 1, 2 or 3 respectively to the mild, moderate and severe features. The significance of gestosis score over the other prior risk scores is that it gives weightage according to the severity. Whereas the prior screening test had, according to it had similar each factor was of equal significance. It allows points to be kept blank. If patient doesn't give any history, then we can keep that point as blank. It can be done by any health worker. If suppose our staff, our sister also at the OPD or registration counter can make ticks over the risk factors, she can calculate the score and she can make a mark over our OPD paper as patient at risk of preeclampsia. Then we can see to it and we can apply the prevention strategies, like we can start aspirin at the bedtime as early as 6 weeks. We can give elemental calcium 1 to 1.5 gram in divided doses. We can advise her to have low carbs, high protein diet. No need of salt restriction, but no excess salts. Then we have biomarkers in the prediction. Mean arterial pressure, it is better predictor of preeclampsia than systolic or diastolic blood pressure. There are so many emerging and already evolved prediction factors, but the blood pressure remains cornerstone of early diagnosis. So in the biophysical factor, we knew the uterine artery Doppler, generally done at 11 to 13 weeks. High umbilical artery resistant waveform, increased SD ratio, or the uterine PI more than 95th percentile, notching in the uterine artery. So, the newer one is our ophthalmic artery Doppler. Ophthalmic artery is the easily accessible vessel for Doppler assessment. It provides information about the less accessible intracranial circulation. In pregnancy, we know there is decrease in the impedance to flow, so decrease in the RI or PI and increase in the flow velocimetry waveforms. We can see this in this picture, the waveform of the ophthalmic artery. In the systole, we have two peaks, first and second, PSV1 and PSV2. So PSV1 to PSV1 ratio, 2 to 1 ratio is increased in women developing preeclampsia. So these are the few studies which said that this PSV ratio can predict subsequent development of preeclampsia within 3 weeks of assessment. This ratio is superior to the MAP, uterine artery PI, PIGF or SFLT as individual biomarker in prediction of both preterm and term preeclampsia. When combined, it has better prediction rate than any other biomarkers. So moving on to the biochemical markers, we know there are 4 major pathways of etiopathogenesis, that is placental hypoxia, vascular endothelial injury, oxidative stress and immune dysregulation. In pregnancy, normally the angiogenic factors like PIGF increases, but because of the endothelial dysfunction in preeclampsia, SFLT like anti-angiogenic factors increases in the pregnancy. Biomarkers can be used for prediction, for identification and for prognostication. The PAP-A, we know it is glycoprotein by the plasma. It's also used for trisomy screening. In first trimester, there are decreased levels of PAP-A. So it can be used as a single marker, but the performance is poor. So PAP-A is useful if measurements of PLGF and uterine PI are not available according to FIGO guidelines. We have PLGF, it is pro-angiogenic protein. Reduced levels of reduced level of PLGF are significant. So reduction is significant in the first trimester, making PLGF ideal marker for the early screening. We have SFLT1. It is secreted by the placental cell. It is anti-angiogenic factor. Increased amount of SFLT are apparent in the second trimester. But the ratio of SFLT to PLGF is important in preeclampsia screening. So when to use this ratio? This ratio can be used from 20 weeks till the 36 plus 6 weeks for the short-term prediction of preeclampsia. So I want to quote few studies here. So if the ratio is less than 38 or lower, according to the prognosis study 2016, short-term absence of preeclampsia in women with clinical suspicion can be predicted if the ratio is less than 38. We can also predict absence of adverse maternal and fetal outcome within 1 week. So this study, this ratio, the study was confirmed by the INSPIRE study in 2019. It confirmed this SFLT and PIGF ratio less than 38 as rule out test in third trimester. If SFLT PLGF ratio is more than 85, so it is significant in early onset preeclampsia. If it is more than 110, significant in late onset preeclampsia. We have one test called glycosylated fibronectin test, where the finger stick sample is used. Maternal blood has glycosylated fibronectin. It reacts with the stick where the antibodies are present, and it is impregnated with the dye. The color changes and the intensity of the color is read by the reader, and it interprets the values. If it is normal, then less than 250, abnormal 251 to 350. If it is positive, then the value is 351 to 600, which denotes the high risk of preeclampsia. And if the value is more than 600, presence of severe preeclampsia with high risk of imminent delivery. In GDM, obviously if it is the glycosylated, so the threshold increases, and normal test result is less than 350. We have other markers like placental protein 13 and cystatin. I am not going to go in detail of it. Then we have full Pies model, which was introduced in 2011. It identifies the women at increased risk of adverse outcomes up to 7 days before complications arise. Then we can modify the direct patient care. We can modify the timing of delivery or the place of delivery. We can shift the patient prior. So it used the gestational age, SpO2, then blood parameters such as platelets, creatinine, and AST. For places like PSCs or community, it was not possible to do lab parameters. So the mini Pies model claimed it is a simplified version of this model where only the demography, signs and symptoms are used. Then the Fetal Medicine Foundation introduced one risk calculator which is free of charge, available on the web page for the preeclampsia risk calculation. It has maternal characteristics, biophysical markers, uses MAP and uterine artery PI, biochemical PLGF and PAP-A. So we can fill this data and we can calculate the risk of preeclampsia. Then there is, for the triage, PLGF test is there. This test is used to measure the maternal circulating PLGF in EDTA anticoagulated plasma specimen. The result is available in 15 minutes. If the PLGF is less, that is less than 12 picogram per ml, then the test is positive. If the patient is high risk, what we can do is we can start patient aspirin, we can optimize the calcium dose, and we can advise take the patient as at risk, and we can do the serial growth scans. We can advise the more ANC visits to the patient. So according to the SPREE study 2018, if you use these multiple markers such as maternal characteristics, mean arterial pressure, uterine artery PI, PAP-A and PLGF together, then the performance can be significantly improved. As we can see, if less than 34 weeks, detection rate is 90%, then 81%, and 43.5% when it is more than 37 weeks. We know the investigations what we go in preeclampsia. The significant proteinuria when more than 0.3 gram per day in 24 hours, abnormal protein creatinine ratio, more than or equal to 30 milligram per millimole, significant proteinuria in singleton pregnancy, and if for multiple we take value as more than or equal to 40. The renal parameters in pregnancy changes, the normal creatinine becomes 0.4 to 0.9, which is in 0.5 to 1 in non-pregnant stage. We know the alkaline phosphatase pregnant value is 125 to 250, whereas LDH level upper end is up to 600 units per liter. Then role of Doppler is not only for the fetal surveillance, for also to decide the time of delivery. If we know in the FGR, fetal growth restriction Doppler and AFI, we estimate if it is there, FGR is there in the study, then we should do it every 15 days till delivery. If there is absent end diastolic flow, then we can monitor patient by doing Doppler twice a week till it is reversed. And if it is reversed, it's an indication, it becomes indication for the delivery of the patient. Ductus venosus and umbilical vein abnormality is significant. It tells us about the fetal acidemia and the prognosis is poor. If the patient is less than 34 weeks, we have to go corticosteroids, and role of Maxelf comes for neuroprotection if it is less than 32 weeks. There is dilemma and many schools of thoughts whether we should use antihypertensives for mild and moderate hypertension. There is required less tight or more tight control of blood pressure. Then 2002 meta-regression analysis said that lowering of maternal BP decreased placental perfusion and exposure of the fetus to the potentially harmful effects of medication. But the CHIEFS trial came in 2015 which said that there was no significant difference in the rates of major maternal or fetal complications, and less tight control was associated with the higher rate of severe maternal features. The antihypertensives we know use labetalol, nifedipine, methyl dopa or hydrochlorothiazide, but labetalol is the first line drug. Why? Because it is free of side effects mentioned by the methyl dopa, that is sedation, and the dose of drug which is to achieve the blood pressure is required is more in methyl dopa. It results in good and sustained control of blood pressure. There is no tachycardia. It has no effect on uteroplacental blood flow and also has increased lung maturity. In hypertensive crisis, we have hypertensive emergency and hypertensive urgency. Labetalol, we are using 10 to 20 milligram IV. Then every 20 to 30 minutes, we have to double the dose till 300 milligram. Just one or two slides I will mention. Again, whether we should induce the patient or expectant management. HYPETITE trial came in 2009, which concluded that induction of labor is associated with the improved outcome, which was then revised in 2015, which said immediate delivery can cause reduce the maternal adverse outcomes. However, significant neonatal risk is there, so the routine immediate delivery does not seem justified, and strategy of expectant monitoring until the clinical situation deteriorates can be considered.
Thank you so much.
This last slide.
We request
Thank
the
you so much.
chairpersons to please felicitate Dr. Jaya Kore Turaskar ma'am. All the chairpersons kindly join. अजून आहे ना. We call upon our next speaker, Dr. Ritu Santwani, for the next lecture on silent feto-maternal hemorrhage and anti-D prophylaxis. This talk is sponsored by BSV, and we would like Madam to please introduce her.
Dr. Ritu Santwani ma'am, welcome. As we all know her very well, ma'am is an obstetrician, gynecologist, sexologist, cosmetologist and infertility specialist, and CEO of 360 Degree Healthcare Studio. She is founder of MMAM.
I think this much is sufficient, Kanchan, otherwise you will cut out my talk time. So, hello everyone.
She is a multifaceted personality. Welcome, ma'am.
Thank you, dear Kanchan, Jyoti, so many friends are there here. Yeah, hello everyone. A very good evening to all of you. I am very delighted here today in the city of the textile industry, the Solapur, which is blessed by Lord Siddheshwar and Mata Tulja Bhavani. So let's change the gear and going to start the talk of the today. And thank you so much my dear friend Revati and Dr. Madan Kamre for inviting me here. My all presentations will start with Mata Durga Stuti. Ya Devi Sarva Bhuteshu Chikitsa Rupen Sansita Namastasyai 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 Namo Nama. So friends, today we are going to discuss a very important topic, the silent feto-maternal hemorrhage and the anti-D prophylaxis. How we can nurture and preserve the miracle sac. So as we know, this silent feto-maternal hemorrhage in the asymptomatic pregnancy, in the unborn child, in the expecting woman, and the bleeding. So friends, as we know, this silent feto-maternal hemorrhage refers to antenatal or postpartum entrance of the fetal blood into the maternal circulation due to failure of the placental barrier. The clinical consequences of feto-maternal hemorrhage ranges from non-significant to catastrophic outcomes and depends on the volume of fetal blood loss and whether the blood loss is acute or chronic. Clinically, the insignificant FMH occurs in most pregnancies, less than 1 ml in approximately 75% of the pregnancies, and significantly it has been reported more than 30 ml in 3 per 1000 births. Audio please, audio is not coming.
कुछ भी नहीं मेरी दुनिया है कुछ नहीं कहीं तेरे बिन मैं क्या दुनिया.
So clinically unimportant feto-maternal hemorrhage is likely occurs in most pregnancies with the fetal blood volumes less than 0.025 ml in 75% of the women, 0.5 ml in 96% of the women, and less than 15 ml in 99% of the women. And when we are using the term the important or massive fetal hemorrhage, usually there is no standard definition. Some use the 30 ml as the clinically significant, while other uses as 80 ml or 150 ml of fetal blood or to define the massive large fetal hemorrhage, especially in the cases of the big placenta as the gestational diabetes, anemia and twins. In the spontaneous FMH where there is no history of trauma or clinical abruption, or the traumatic feto-maternal hemorrhage as a result of the invasive placental procedure or abdominal trauma. So, how we classified this, acute or chronic? In the cases of the acute feto-maternal hemorrhage, the rapidity of the fetal blood loss leading to the perinatal hypoxia, which can lead to IUD or severe anemia and hypoxia at birth. Chronic feto-maternal hemorrhage is maybe the intermittent or recurrent fetal blood loss, compensatory increase in hematopoietic activities, development of hydrops, if there is inadequate compensatory mechanisms. So what the incidences has suggested, 0.2 per 1000 births for the fetal blood loss more than 150 ml, 0.9% per 1000 births for fetal blood loss more than 80 ml, and 3 per 1000 birth if the FMH is more than 30 ml. So as we all know, the incidences has been reported 4% in first trimester, 12% in second, and majorly in the 45% in the third trimester. So as we know, the causes for this either the maternal abdominal trauma or the obstetrical procedures like ECV, percutaneous umbilical sampling, amniocentesis, CVS chordocentesis, placental or umbilical cord abnormalities, placental abruption, placenta previa, vasa previa, chorioangioma, and intraplacental choriocarcinoma. So friends, as we all know, normally the placental connections in the trophoblastic layer allows the minute bidirectional blood flow between the mother and fetus. Breach in this layer, which causes the fetal blood cells move away from the higher pressure of the fetal circulation into the lower pressure intervillous space and ultimately into the maternal circulation, causing a temporary maternal chimerism. So we all are aware of this pathophysiology. So due to paucity of the time, I'm skipping some slides. So what's the usual clinical presentation? The persistent decrease or absent fetal movement is the first sign of the massive feto-maternal hemorrhage or fetal death. Other non-specific symptoms may be the sinusoidal heart rate pattern, in which the peak systolic velocity of the MCE of more than 1.5 MOM warrants a FMH testing, the fetal height drops, unexplained stillbirth after the 20 weeks of gestation, unexplained elevated MCA Doppler consistent with anemia and early neonatal anemia, uterine tenderness or vaginal bleeding. So the diagnostic modalities which has been reported are the Clay-Horse-Betke testing, flow cytometry and Rosette testing. So depending on this, we can go directly to the chart. If the maternal RHD status, if the D negative, the Rosette screening, if it shows the negative, the FMH requiring the 1 vial of the immunoglobulin will be negative if the fetus is D negative and can be false positive if the fetus has a weak D phenotype. While it is positive, then Clay-Horse-Betke test or anti-HbF cytometry. While in the cases of the maternal RHD status is positive or the D antigen variant, then Clay-Horse-Betke test or anti-HbF flow cytometry has been reported. So what are the consequences has been reported with this? We all know. The sensitization in the Rh negative patients lead to sensitization of the mother for future RHD positive fetus, the hemolytic disease of the newborn, fetal death, excessive blood loss causing anemia or hypovolemic shock, respiratory distress or immature lungs, metabolic acidosis, neurological injuries, renal disorders and liver damage. So friends, what are the options are available for the management of this? We are going directly for the pregnancies of the more than 32 weeks and FMH of 20 ml. Immediate cesarean section recommended with the neonatal transfusion. For the pregnancies less than 32 weeks with severe FMH, the intravascular intrauterine transfusion is recommended. For the pregnancies of more than 23 weeks, corticosteroids for lung maturity and magnesium sulfate we all are using these days for the fetal neuroprotection has been required. Then coming to that what's the role in the antenatal management? As we all know, for the fetal lung maturity, the antenatal corticosteroids has been reported. Rh immunoglobulin to RHD negative women within 72 hours after any potentially sensitizing event to prevent the aluminization. The role of antenatal corticosteroids has also been reported, either the use of the betamethasone 12 mg intramuscularly every 24 hours for 2 doses, or these days we are all using the dexamethasone 6 mg intramuscularly every 12 hours for 4 doses. Now coming that when to use this anti-D, as we all know, the unsensitized RHD negative woman should be offered a prophylactic anti-D immune at 28 weeks of the gestation unless the father of the baby is unknown to be RHD negative and within 72 hours of the delivery if the infant is confirmed to be Rh positive. Suppose if the patient is not ready by 72 hours, either due to social constraints or some other problem, we can give it up to 13 days or up to 28 days also has been reported. Now what are the ICOG FOXI recommendations guidelines for this? So we can see for this antenatal prophylaxis for the first trimester, event significantly bleeding during the threatened abortion, spontaneous miscarriage, medical termination, surgical termination, ectopic pregnancy, vesicular mole, chorionic biopsy, and embryo reduction. Friends, here I want to emphasize one very important point for the medical termination of the pregnancies. These days, so many youngsters are coming to us for the MTP. So it's very important when we are giving them for the MTP pills, at that time only we have to know about the status of the blood group. Because once we give the mifepristone and misoprostol, ज्या टाइमला क्रॅम्प्स येतात त्या टायमाला फिटोमॅटर्नल सेन्सिटायझिंग होते, नंतर याची अपेक्षा आपण पहिलेच टेस्ट करून पहिलेच ॲडवाइस केला, सो दॅट विल बी मच मोर बेटर. तसंच एक दुसरा क्वेश्चन येतो रिगार्डिंग हायड्रेटेडी फॉर्म मोल. भरपूर अशा विचारतात मॅडम जिकडे पार्शियल मोल आहे तिकडे तर ठीक आहे द्यायसाठी, जिकडे कंप्लीट मोल आहे तिकडे आपण देऊ की नको देऊ. तर युजली द स्टडीज आर गिविंग द फेवर इन द cases where you are having the partial mole, but to be on the safer side these days we all are giving in the cases of the complete mole also. Now in the second trimester all the patients should be tested for RHD sensitization at the time of the registration and again at 28 weeks. Studies and guidelines have been suggested all all non-sensitized RHD negative women should be given 100 microgram at 28 weeks and 34 weeks again, or a single dose of 300 microgram at 28 weeks. But in our setup, I think the 300 is easily available instead of the 150. So we all are giving at 28 weeks. According to Canadian guidelines, they are giving at 28 weeks and then 34 weeks also. But currently we all are using at 28 weeks. Again in the third trimester, if events like amniocentesis, abruptio placentae, blunt trauma, IUD, ECV, placenta previa with bleeding, in all these cases we are giving. आता इकडेच एक प्रश्न येतो, मला कालच कोणी विचारला होता वेबिनारमध्ये की मॅडम आत्ताच आपण पेशंटला अँटी-डी दिला आणि पेशंट आता 3 दिवसामध्येच डिलिव्हर झाली आणि बच्चू पॉझिटिव्ह आहे, तर काय परत द्यायची गरज आहे? नाही, 3 दिवसामध्ये डिलिव्हर झाली तर नाही, बिकॉज ह्याचा हाफ लाईफच अराउंड 21 डेज असतो, तर तेवढा लवकर द्यायची गरज नाही आहे परत आपण. सो नाव व्हॉट आर द थिंग्स येट टू डू, व्हॉट आर द रिकमेंडेशन्स? आय एम टेकिंग द विच आय हॅव हायलाइटेड. First and foremost, a very important, instead of gluteal muscle, the anti-D should be given in the deltoid or in the anterolateral thigh to avoid the delayed absorption. All non-sensitized women should be given prophylaxis to avoid the risk of sensitization in late pregnancy or postpartum. So what are the guidelines from our FOXI? What's the update by 2022? So again, I am emphasizing that all Rh negative women should have a ICT test for screening of the Rh antibodies at the first visit. If ICT is negative at first visit, then repeat ICT at 28 weeks. In the case the woman has anti-D immunoglobulin, either of following a sensitizing event, the routine antenatal prophylaxis, the subsequent ICT is not preferred. I will take only 2 minutes. Hopefully organizers will permit me for 2 minutes. If ICT is done after anti-D prophylaxis, the result should be interpreted with the specialist consultation. This already have included. So, FOXI recommendation for routine antenatal anti-D prophylaxis, the last line we can see, a single dose regimen is equally effective as a 2-dose regimen, and it is recommended if only if the ICT at 28 weeks is negative. This already I have covered. So in this only the first and the last lines are very important. The mild FMH is seen in 95% of the pregnancies. However, 1 in 5,000 deliveries have severe FMH more than 150 ml. Again, coming to the last, a prophylactic dose of the 300 microgram of anti-D is recommended in all non-sensitized mothers after the 28 weeks of the gestation. So thank you friends for your patient hearing. Hopefully all of you have enjoyed my lecture.
Yes ma'am, thank you so much.
So please the voice, audio please.
We request the chairpersons to please felicitate.
Thank you once again.
It was nice presentation. Thank you so much, ma'am.
So now we can go for the tea.
चाय पिएंगे हम तो चाय पिएंगे, हरे कर दो कान पे चाय पिएंगे, चाय पिएंगे, चाय पिएंगे, चाय पिएंगे हम तो चाय पिएंगे, हरे कर दो कान पे चाय पिएंगे, चाय पिएंगे. चाय पिएंगे, चाय पिएंगे, हम तो चाय पिएंगे, हरे कर दो कान पे चाय पिएंगे, चाय पिएंगे, चाय पिएंगे, चाय पिएंगे, हम तो चाय पिएंगे, हरे कर दो कान पे चाय पिएंगे, चाय पिएंगे.
We call upon our next speaker, Dr. Kishori Atmurkar. Kishore Atmurkar. चाय की जरूरत है. I am so sorry for that. Dr. Kishore Atmurkar sir, for the next session, next lecture, pharmacological aspects of commonly used drugs in obstetrics.
Dr. Kishore Atmurkar sir is MD OBGY. He did PhD in social science. His areas of interest are cesarean section, population control, sexuality in adolescent girls, and pre-marriage and preconceptional counseling. He is consultant in private sector for last 34 years, and he published 4 scientific papers and written few books on in Marathi. तिच्या आरोग्यासाठी सर्व काही and on contraceptives like निर्णय तुझा माझा हम निर्णय together we decide.
Thank you.
Welcome sir.
Thank you very much. मी शेवटचा आहे ना, म्हणजे मला माझ्या वेळेस बेल वाजणार नाही.
वाजणार आहे सर.
मला तेवढं तरी ॲडव्हान्टेज द्या ना.
लास्ट लेक्चर आहे म्हणून बँजो बोलवलंय.
No, we are sorry to inform there are 2 online lectures also.
Okay.
With the
Anyway, thank you very much. Since yesterday I am enjoying the conference. I reached Solapur on Friday evening, and I was waiting for this event of my talk till this time. I have been observing for the last 2 days that everybody is congratulating Madan and his team for organizing such a wonderful conference. Well, it is my pleasure and duty to thank the Cluj OBGYN Society and the organizers of this conference, but I really thank Madan. It's a special thanks to Madan, because when I received the brochure for the first time, maybe 2 months back, I was really impressed by the whole agenda and the CMEs and topics, and I thought that I should be a part of this. And I requested Madan to call me as a faculty. He took 1 week and he called me back. Okay, on which topic you would like to talk? I said की माझ्या मनामध्ये फार दिवसापासून आहे की फार्माकोलॉजीचं एक बेसिक रिव्हिजन आपण जे औषधं वापरतो. द टायटल मे बी एनिथिंग, अप्लाइड फार्माकोलॉजी ऑफ रुटीनली यूज ड्रग्ज इन ऑब्स्टेटिक्स वगैरे, हे ठीक आहे, पण जी औषधं आपण रोज वापरतो अनेक वर्षापासून ती कुठं काम करतात, कशी काम करतात, त्यांची खरी नावं काय आहेत, ह्याचं एकदा रिव्हिजन झालं पाहिजे, एवढीच इच्छा. थँक्यू व्हेरी मच. You know this person, I am missing this, I am in Solapur and I really do not have company of this person. Sir, Dr. Kurdukaranचं पुण्यस्मरण करून मी माझ्या बोलण्याला सुरुवात करतो. The objective, as I said, it is essential to understand the pharmacological aspects before we prescribe. This is a revision. All those who know need not, for them it will be a revision. And all those who do not recall, for them also it will be a revision. To make our prescription more rational, I have come here to talk to you. Folic acid is the first drug which we write during pregnancy. It is a preconceptional folic acid. It is to prevent neural tube defects. It is also called as vitamin B9. Daily dose is 400 microgram. folic acid deficiency lead to megaloblastic anemia. As you all know, vitamin B12 and folic acid are called, these are all maturation factors. B12 and folic acid are maturation factors, essential in the synthesis of nucleoprotein of erythropoietic cells. Deficiency leads to defective synthesis of DNA. या सर्व कारणासाठी आपण folic acid देतो. Second drug which we give is doxylamine succinate. Doxinate किंवा doxinate सारखे म्हणजे during my talk I use a few brand names. त्याचं काही मला please forgive me, but these are popular brand names, therefore I am using those brand names. Nothing, anything else. It is an antihistaminic. Doxylamine, please remember, it is classified under group of antihistaminic, and the absorption is slow. Half-life is 10 hours. Side effects are drowsiness, dryness of mouth, and recommended dose is 10 to 20 milligram at bedtime. And there can be some modification in the dosage schedule also. Pyridoxine is vitamin B6. Along with doxylamine, pyridoxine is the first line of treatment for morning sickness. The dose is 10 milligram. Iron is another drug which we are routinely using in each and every pregnant woman. So anemia still remains as a major cause of maternal mortality in our country. So be careful while prescribing iron. There are so many iron salts available in the market, but which iron salt is better? So while prescribing iron, oral iron is safe, cheap and effective, to be continued for 3 months after correcting hemoglobin. Ferrous sulfate, ferrous gluconate, fumarate are the time-tested salts. They are cheap. Ferrous sulfate is in non-spensule. Please remember, ferrous sulfate in non-spensule and non-time released is the best, cheap and effective. Please check the iron salt, how much elemental iron is provided in that iron salt. It is, आपण medical representative आले आणि सांगितलं आणि iron हे पण कुठलं सॉल्ट आहे त्याच्यामध्ये किती एलिमेंटल आयर्न आहे एका गोळीत किती आहे वगैरे बघायला पाहिजे. 10% ऑफ एलिमेंटल आयर्न इज absorption is better in presence of vitamin C. Ask yourself, are you prescribing to prevent anemia or treat anemia? In India, most of the pregnant women are anemic, so require curative dose. 200 milligram daily is inadequate to treat. For example, 600 milligram is required if hemoglobin is 8 grams per cent. So increase the dose gradually. Iron supplementation to pregnant women is started from second trimester to be continued for 3 months after delivery. You must have seen so many prescriptions of our colleague gynecologist prescribing iron right from the first trimester and increasing the problem of morning sickness. Iron is better absorbed if taken before food. ही गोळी जेवल्यानंतर घ्या सकाळी असं नाही आहे. Taken care, unless there is intolerance, take care that the patient is not taking iron with calcium. Albendazole, you make a habit of prescribing albendazole 400 milligram or mebendazole 100 milligram twice a day for 3 days. And albendazole 400 milligram, one shot. People are prescribing carbonyl iron. It is having better gastric tolerance, absorbed from intestine over a long time, but the bioavailability is only 3/4 that of ferrous sulfate. So ferrous salts score here. We are giving parenteral iron therapy. Calculate before starting, calculate the requirement of iron. The formula, if you have forgotten, 2.2 into weight in kilogram into deficit of hemoglobin in percentage. Say percentage is given 11 gram percent hemoglobin, plus we don't forget to add 500 milligram for iron stores. Remember, FCM is ferric carboxymaltose. Ferric carboxymaltose. अरे FCM लावून टाका ना. FCM काय आहे हे जरा पाठ करावं लागेल. These are the popular brands, and if ferric, it is ferric hydroxide stabilized by carbohydrate shell. rapidly absorbed, taken up by reticuloendothelial cells, subsequently released to target cells. Dose is 500 to 1000 milligram in 100 ml of normal saline over 15 to 20 minutes. Infusion may be repeated after 1 week. 1 to 3 sessions may be needed. It takes 2 to 3 weeks for hemoglobin to rise. Then calcium, पाण्यासारखं लिहितो आपण आयर्न आणि कॅल्शियम. WHO recommends dietary intake of 1200 milligram per day of calcium for a pregnant woman. We all need plenty of vitamin D to be able to absorb and use calcium from food and avoid calcium loss from bones. It is recommended that women consume 400 international units per deciliter of vitamin D and 1000 to 1300 milligram of calcium. The most commonly, which calcium salt? The most commonly available salt forms are calcium carbonate and calcium citrate. Calcium carbonate provides with 40% of elemental calcium, better absorbed and well tolerated, especially when taken with a meal. It is most commonly used and least expensive calcium salt as cost is consideration for many patients. Calcitrol is active form of vitamin D. Enhances absorption of calcium and phosphate from intestine. Calcium supplementation can prevent preeclampsia in women with low dietary calcium. High dose of calcium supplementation, that is at least 1000 milligram per day during pregnancy, reduces the risk of developing hypertension and preeclampsia. Ecosprin is another drug which we are commonly prescribing these days. Aspirin, it is acetyl salicylic acid, is a non-steroid NSAID. It inhibits platelet thromboxane A2, which is the potent vasoconstrictor and promotes platelet aggregation. The effect of aspirin is dose dependent. It can be anything between 50 to 150 milligram. Mithargine हे एक अगदी commonly used drug आहे. मिथार्जिन द्या. अरे अजून फ्लॅबी वाटतं. मिथार्जिन द्या ना. नाही नाही दिलं ना आत्ताच. अरे रिपीट करा. पण केव्हा करा काय नाही. Acts immediately after IV in 5 minutes after intramuscular injection. Routine use in all cases is not justified. Used as second line of treatment after oxytocin. Action is on smooth muscles of uterus, passes into state of spasm, has vasoconstrictive action also, and the plasma half-life is 1 to 2 hours. एकदा आता मिथार्जिन दिल्यानंतर पुढचा डोस किमान 2 तासानंतर. Pitocin or oxytocin, it increases force and frequency of contraction by influx of intracellular calcium. The contraction compresses the blood vessels. Contractility is restricted to fundus and body. Plasma half-life is less, only 6 to 12 minutes. म्हणून infusion मध्ये द्यावं लागतं. It's the first line of drug in prevention and treatment of PPH. 10 to 20 units, maximum 40 units. अरे पिटोसिन ड्रिप वाढवा किती झालं मॅडम 40 युनिट टाकले अजून 40 टाका काही अर्थ नाही 40 पेक्षा जास्तला. 40 units in one IV infusion 10 ml per minute needs to be preserved. हां हे एक फार महत्त्वाचं आहे की needs to be preserved between 2 to 8 degree असंच पडलेलं असतं ॲम्प्युल्स कुठेही ऑक्सिटोसिनचे. जर फ्रीजमध्ये नाही ठेवलं तर त्याची पोटन्सी कमी होऊन जाते. ॲक्शन स्टार्ट्स इमिडिएटली आफ्टर IV इन्फ्युजन. इंट्रामस्क्युलर ऑक्सिटोसिन कॅन ऑल्सो बी गिवन. ईज ऑफ ॲडमिनिस्ट्रेशन आहे इंट्रामस्क्युलरला. And effect starts in only 3 to 7 minutes. Action lasts for 30 to 60 minutes. Carbetocin, long-acting synthetic analog of oxytocin. Half-life is 40 minutes. Half-life of 40 minutes. घड्याळाकडे बघितल्यामुळे वाचता येत नाही बा. काय तुम्ही थोडंसं तिकडे बघा. Action similar to oxytocin, a rapid onset of action within 1 to 2 minutes, lasts for 1 hour. Dose is 100 microgram IV, and a single injection appears to be more effective than continuous infusion, but it is more expensive. Epidocin is another drug. अरे एपिडोसिन देऊन टाक. कोणत्याही पेशंटला एपिडोसिन प्री लेबरमध्ये लेटंट फेजमध्ये केव्हाही एपिडोसिन देऊन झालं ऑक्सिटोसिन देऊन झालं सगळं म्हणजे तर पण काय एपिडोसिन? इट इज व्हॅलेथामेट ब्रोमाइड. It's anticholinergic medication. It works by blocking the effect of acetylcholine, thereby relaxing smooth muscles of cervix. Available 8 milligram injection in 1 ml. Onset of action is 20 to 30 minutes. Half life is 4 hours. दिलं, आता दिलं, पुन्हा द्या, काही नाही. Half life 2 to 4 hours आहे. It is supposed to cut short the first stage of labor. More useful after 4 centimeters of dilatation. अगदी 2-3 प्री लेबरमध्ये एपिडोसिन देऊन झालं असं समाधान घ्यायची गरज नाही. प्रोस्टाग्लॅन्डिन्स, सर्विप्राईम जेल पण काय आहे? डायनोप्रोस्टॉन जेल येते. नॅचरल प्रोस्टाग्लॅन्डिन E2.5 milligram. Dose can be repeated after 6 hours. Maximum 3 doses are permitted. Unfavorable cervix can be made soft and compliant. Labor can be induced after 12 hours of oxytocin. 12 hours with oxytocin. Misoprostol, prostaglandin E1 आहे. फॉर PPH आपण विसरूनच जातो. फॉर PPH 600 to 1000 microgram rectally, orally or sublingually, proved inferior to oxytocin in PPH. This for MTP also. First trimester MTP, misoprostol alone 800 microgram, repeat after 3 hours for 3 doses. Second trimester, misoprostol alone 400 microgram every 3 hours up to total 5 doses. Uterus is more sensitive to prostaglandins than oxytocin. Remember, synthetic prostaglandin E1 is analog for induction of labor. Vaginally 25 microgram, repeat after 3 to 6 hours. Oral 50 to 100 microgram, repeat after 3 to 6 hours. Contractions within 30 to 60 minutes. The drug is absorbed from vaginal, oral and buccal administration. Prostodin सुद्धा 15 methyl PGF2 alpha है. Carboprost used in PPH, available in 1 ampule. Don't give IV, give only intramuscularly. The dose can be repeated if necessary after 15 to 90 minutes. Maximum intervals and maximum 8 doses you can give. Bronchial asthma contraindication. आता काय झालं? संपलं का? ठीक आहे. बर. पॉप्युलर ब्रँड्स डुफास्ट्रॉन, नॅचरोजेस्ट हे आपण रोज वापरतो. पण काय आहे? ड्रायड्रोजेस्टेरॉन म्हणताना जीभ फार अवघड जाते. Highly selective synthetic progesterone binds exclusively to progesterone receptors. It is found to inhibit myometrial contractility, readily absorbed bioavailability in only 2.5 hours. Micronized progesterone, प्रोलिटॉन डेपो सुद्धा रेग्युलरली वापरतो. प्रोलिटॉन डेपो म्हणजे 17 अल्फा हायड्रॉक्सी प्रोजेस्ट्रॉन कॅप्रिएट. हे सगळं लक्षात राहिलं पाहिजे. बाकी डोसेस सांगत नाही तर वेळ कमी आहे. नेफिडिपिन इट्स अ कॅल्शियम चॅनल ब्लॉकर used as an antihypertensive to treat pregnancy induced hypertension. आणि याच्यामध्ये एकच गोष्ट सांगायची इच्छा आहे, बाकी तुम्हाला माहिती आहे की निकार्डिया रिटार्ड आणि प्लेन निकार्डिया किंवा नेफिडिपिन, सिंपल नेफिडिपिन आणि निकार्डिया रिटार्डमध्ये फरक आहे. इट डिपेंड्स अपॉन द निकार्डिया इज ऑल्सो बेटर, बट निकार्डियाचा इफेक्ट येईपर्यंत ते टेपरिंग डोसेसमध्ये येत नाही, तेव्हा कधी कधी सिंपल नेफिडिपिन पण द्यावं लागतं. टोकोलायटिक एजंट माहिती आहे. लॅबेटेलॉल is a preferred antihypertensive agent. Drastic reduction, okay. मॅग्नेशियम सल्फेट बऱ्याचदा झालंय. आता एक आम्ही स्टॉलवर चक्कर मारत होतो तर एका कंपनीने 100 ml सलाईनमध्ये 4 grams असे इन्क्लूड करूनच दिलेलं आहे. त्या म्हणजे ते 50 mlच्या 1 ग्राम 50% वेट बाय वॉल्यूम या 1 ग्राममध्ये 1 ग्राम 2 ml मध्ये 1 ग्राम आहे का किती आहे आता विचार करायची गरजच नाही.
सर बेल मारत नाही इथे, वाजवत नाहीये, पण वी आर रिअली रनिंग ऑफ टाइम.
ओके ओके ओके. मग आता काय करणार?
थँक्यू ची स्लाइड.
थँक्यू. आणि एक सांगतो मी, या प्लाझ्मा व्हॉल्यूम एक्सपांडर्स वगैरे पण बोलायचं होतं. एनिवे, रिंगर लॅक्टेटची बॉटल घेऊन कधीतरी एकदा बघा. की काय देतोय आपण. आणि हां, अँटीबायोटिक्सचं एक वाक्य बोलू द्या की नो फार्माकोलॉजिकल बुक मेन्शन्स अबाउट हायर अँड लोअर अँटीबायोटिक्स. कधीच हायर आणि लोअर अँटीबायोटिक नसतं. आणि रॅशनल यूज ऑफ अँटीबायोटिक्स करा, कुठेही गरज नसताना अँटीबायोटिक देऊ नका. आणि एवढं सगळं 2 दिवसाची कॉन्फरन्स ऐकून सगळं मदरहूड, मॅटर्नल मॉर्टॅलिटी, अमुक ढमुक, तरी अनसर्टॅनिटी आहे, तेव्हा देवाची प्रार्थना कशी करायची ती एकदा सांगतो. ते म्हणजे जे टाळणे अशक्य दे शक्ती ते सहाया. जे टाळणे अशक्य दे शक्ती ते सहाया. जे शक्य साध्य आहे दे निर्धार ते कराया. मज काय शक्य आहे आणि अशक्य ते काय. मज काय शक्य आहे आणि अशक्य ते काय. हे सारे कळाया दे बुद्धी देवराया. एवढं बोलून माझं भाषण.
थँक्यू सो मच सर.
थँक्यू व्हेरी मच.
लगेच we request our president Dr. Shetty sir to please felicitate the chairpersons too. We extend a special gratitude to other chairpersons who have stayed so long and enjoyed the session. Thank you so much. And to all the delegates also. We start with an online session by Dr. Girija Wagh. The lecture is a keynote address on WHO PPH care bundle.
Hello. Giving a brief introduction of Dr. Girija Wagh. She is the professor and HOD Department of OBGYN at Bharati Vidyapeeth Medical College, Pune. Senior consultant at Cloud9 and Apollo Hospital. She is the faculty professor, chairman of Medical Disorder in Pregnancy Committee, FOXI. She is the vice president, India Chapter Justices, member of Governing Council, Joint National Secretary of FOXI in 2010, and assistant coordinator. Over to you, ma'am.
Hello, good afternoon, and greetings from Pune. And I'm extremely sorry and apologetic that for some other prior commitment I could not attend the today's meeting, which I had actually promised that I'll be there. And in the next 20 minutes, I'll quickly get through the task that has been allotted to me and consider it as a privilege to speak upon care bundle approach to postpartum hemorrhage management. Now, we all know that PPS is a very, very devastating occurrence and is responsible for a huge amount of maternal morbidity and mortality. And it has been found that hemorrhage is a leading direct cause of maternal deaths worldwide, representing about 27% of maternal deaths as per the FIBO statistics. And if you look at the postpartum hemorrhage, per se, 52% of maternal deaths are attributable to 3 leading causes of hemorrhage, sepsis and hypertensive disorders, and every year nearly 14 million women around the world suffer from postpartum hemorrhage, and it's the quickest of the maternal killers, and nearly 25% of deaths are due to postpartum hemorrhage, while in India, if you see, the incidence is supposed to be about 35 to 56%, which is quite remarkable. But most PPH-related deaths are preventable through the implementation of effective interventions, and the recent shift from the home births to facility births across low and middle income countries raises new opportunities for saving women's lives. And definitely this is going to help us in achieving the goal in 2030 of the target MMR of less than 70, and India actually is propulsing itself towards this, especially the state of Maharashtra, and we all have to be proud of these contributions from each one of us. We have to congratulate ourselves because we are definitely getting there. And the maternal mortality ratio is going to be improving to 103, and India may definitely hit the global goal of 70 much in advance as has been proposed. So I really want to congratulate the organizations of Barkha 2023 Monsoon Obstetrics Summit for bringing up this wonderful initiative about the high-risk obstetrics in their armamentarium of organizing this wonderful meeting. Deaths continue despite all these measures, and inconsistent or delayed use of effective interventions for prevention and treatment have been identified. Systemic problems in health services also has led to continued unacceptable rates. For example, let's see the evidence. If you are looking at impact of treatment delay for severe hemorrhage, here you can see that tranexamic acid is to be given urgently to save lives. If you give it immediately as a treatment, there will be 70% of possibility of improvement in survival, while every 15 minutes delay would cause 10% decrease in the survival benefit, and after 3 hours of the occurrence, tranexamic acid is found to be of no use to control this postpartum hemorrhage. So taking all these evidences and situations and background in mind, while we were suffering through the pandemic, the WHO brought around loads and loads of stakeholders to create the emergency care bundle approach to postpartum hemorrhage management. Now, care bundles have been associated with improved patient outcomes when adherence is high, and this concept is like that of packages and checklists, which have been used by healthcare providers for decades with a similar goal of standardizing and expanding care. And they may include behaviors such as widely used ABCs designed to help practitioners remember the sequence of resuscitation, or a number of interventions packaged together, such as the AMCEL package used to prevent postpartum hemorrhage, what we typically call as active management of third shock labor. So if you look at the history of care bundles, the Institute of Healthcare Improvement developed a formal approach to bundling care to increase the quality and efficiency of care delivery. And the IHI defined bundles as small sets of evidence-based interventions for a defined patient population and care setting that, when implemented together, results in significantly better outcomes than when implemented individually. So the compliance to recommendations and achievement quality is what was the purpose of this bundle. So the bundles approach was designed to increase uptake and compliance to the intervention, and the compliance for the bundle implies higher rates of compliance for its individual elements, and the care bundles would differ from other care packages in that compliance is achieved only when all the bundle and interventions are completed and recorded and documented, and teamwork, communication and cooperation are emphasized because these health systems processed are required for quality and sustainability. Now, the challenges do exist. In 2012, WHO published its recommendation for prevention and treatment of postpartum hemorrhage to provide evidence-informed clinical care recommendations for hemorrhage due to atony. And still today, it's been nearly 11 years since that time, the adherence to these recommendations continues to be a challenge, and the bundle approach has been proposed as a potential solution to the suboptimal adherence to PPH guidelines. Now, we all know that there are various bundles that are there which have been proposed for maternal conditions, including placenta previa, elective induction, labor augmentation, vacuum delivery, maternal sepsis, obstetric and sphincter injury, but evidence of their success or failure is lacking. And although many current patient safety programs target PPH, there are no patient care bundles for PPH as defined by the institution. In early 2017, the WHO decided to explore whether bundling current WHO recommended evidence-based interventions for PPH due to uterine atony may accelerate adoption and adherence to these guidelines. And therefore, the first step towards the goal was the adoption of a bundle definition, PPH intervention selection criteria, and development of 2 PPH care bundles. So the process involved defining PPH as bleeding that a skilled birth attendant feels is excessive. So no 500 ml, no 1000 ml. The one which the SBF feels is excessive and worrisome for days exercise. And in addition, in the absence of an accepted definition of refractory PPH, it was defined as bleeding that is unresponsive to initial treatment and that triggers an additional set of interventions. So this was the algorithm as I have put in here. Looks like a busy slide, but we don't have to go into the details. The panel of experts with geographic and professional diversity were brought together to do the literature search, to define the bundles, to assess the definitions, and then select the interventions based on evidences which were available. And then the proposition was done in various rounds and final results were obtained, and then the final consensus mentioned that pH prevention bundle should be eliminated. So AMCIL is not necessary, it has to be universally practiced, there is no second opinion about it. But the PPH care bundle would include the PPH first response bundle, this was approved, and response to refractory PPH bundle was the second one which was approved. So now we all know that AMCIL contains delivery of the placenta by controlled cord traction as its second component of the AMCIL, and the first response bundle here mentions about AMCIL, which has already been taken for granted, that you've already offered it universally to every birth, whether a cesarean instrumentation, breech or a C-section or a normal delivery. And then when you are seeing postpartum hemorrhage, that is where you call for help, and that is the first response to PPH bundle, which includes IV fluids, uterotonics, tranexamic acid, aortic compression, and then supportive measures such as treat the lacerations, here even the bimanual compression, treat the lacerations, sorry, not the compression, the uterine massage, then treat the lacerations, empty the bladder and empty the uterus, and then you have the response to refractory postpartum hemorrhage through aortic compression or bimanual compression, uterine balloon tamponade, anti-shock garments, and supportive measures in the form of blood transfusion and transport to the higher care center. So when we know about the AMCIL, which was proposed in 2012, it was found to be that controlled cord traction was coming in and out of this particular guideline, but then it was observed that it is important that it is offered correctly so that there will be no uterine inversion, which can happen in case if it is not appropriately corrected. So controlled cord traction was accepted and effective for decreasing the blood loss, and the meta-analysis, it was shown that although the risk of blood loss of more than 1000 ml was not reduced with controlled cord traction, mean time of the third stage, mean blood loss and risk of blood loss less than 500 ml were all definitively decreased by offering controlled cord traction. Now, so the consensus mentioned that the controlled cord traction still had a place in active management when performed by experienced personnel, and it is also a recommended method. Again, at a cesarean section delivery is what I would like to say, and this is a demonstration that when you have had a patient who has just now delivered, do not pluck out the placenta, or please do not go and put your hands inside. You please continue to offer the uterine massage, and here you can see that I was just demonstrating to my students to show them that sometimes one cornual end of the uterus may still be hypotonic, and let it completely contract, because when the uterus will effectively contract, then only there will be a sharing effect and the placenta would separate. If you try to pluck out the placenta before the proper contraction of the uterus, because you've already taken the uterus by surprise when you are cutting it open and taking the baby out, allow it to contract, let the placenta gradually separate, so that you will definitely be able to achieve a much reduced blood loss in this entire gamete. And then at the same place, when you have taken the placenta, gradually sheared it off from the lining of the uterus. It is important that in the same place you can just place the placenta on the woman's body there and immediately check whether it has completely been delivered or not, and that would complete your process of controlled contraction at the time of cesarean section. So bundle compliance and appliance measurement should be affected by the conditional application of CCT, A bundle should not be developed for prevention of PPH, and care should continue as recommended with independent interventions, was what was mentioned. So these were the two bundles which were proposed. The first response postpartum bundle, as I discussed, and the response to refractory PPH bundle was the second one. Now this was converted into an abbreviation, which is the E-motive, where utrotonics, intravenous IV isotonic crystalloids, and TXA, that is tranexamic acid, and uterine massage was taken into account. And this was so that you do not forget the steps. So early detection of PPH would mean massage, oxytocic drug, tranexamic acid, IV fluids, and examination of the genital tract, and maybe escalation to the care, also if the PPH is refractory. So initial fluid resuscitation is always performed together with IV administration of utrotonics. And if utrotonics intravenously are not available, fluid resuscitation should be started in parallel with sublingual misoprostol or other parenteral utrotonics. And in PPH, in the context of placental
We are running out of
the
time, ma'am.
placenta should be extracted and a single dose of antibiotics should be administered. The bundle received high relevance rates and agreement from the experts for implementation at the PHC and hospital levels. Group expressed concern that there might be barriers to implementation in many community settings, and the bundle might require a substantial number of resources such as equipment, supplies, training, health policies and regulations. And the group approved the bundle of treatment of PPH due to uterine atony in hospitals and PHCs and in the community if implemented by a skilled birth attendant who was appropriately equipped and trained. And the expert panel suggested acronyms that may be used for this bundle, such as the Motivate or the Motive 8, meaning massage, oxytocic, tranexamic acid, and IV fluids. So these were what were the part of this. Now, oxytocin, as we know, is a drug of choice in AMCEL already, which is known to increase the amplitude and frequency of contractions used after delivery of the front shoulder of the baby or expulsion of the placenta. And generally, in the AMCEL protocol, we give 10 units of oxytocin intramuscularly and can also be used intravenously, which is typically preferred during C-sections. And currently, there is an oxytocin tablet also which has been available, but it is still under analysis and study. Methylargometrin was one another best utrotonic drug, as we had seen it over time, and it is known to cause the lowest blood loss during the third stage and reduce the duration of the third stage of labor, but it is known to cause a continuous contraction of the uterus, and there is not enough evidence about its use as a single agent, and is typically administered at 0.2 milligrams intramuscularly and is definitely to be avoided in patients who have hypertension. Symptometrin, which is a combination of oxytocin and ergometrin, is found to be more effective than oxytocin in a review, but this is something which is not very easily available in our country and definitely cannot be used in hypertension, and nausea and vomiting may cause restriction of its use. Misoprostol, the synthetic prostaglandin E1 derivative, is an inexpensive drug, does not cause high BP and can be used in patients with asthma and is a common adverse effect in flushing. Amount of blood loss has been shown to have been reduced with prophylactic use of 600 to 800 micrograms in many studies, and it is not as effective as oxytocin. So consequently, oxytocin is the first choice for the prophylaxis of PPH, and currently now we have carbetocin, which is freely available, especially LMICs, where we do not have cold chain available to store oxytocin appropriately, which may undergo degradation. We can consider using the heat-stable carbetocin, which is a potential alternative to oxytocin, affirmed by two large ongoing clinical trials, the WHO and the IMOX, for use in prevention of PPH in vaginal deliveries, and the recommended dose is 100 milligrams per IV, and it has a long action than oxytocin. But remember, friends, at this point in time, it continues to be a drug in the AMCEL group and not as the treatment for postpartum hemorrhage. So whenever we look at what we have for patients of AMCEL, you can administer injectable utrotonics if they are available. Ask the question. If they are no, then one can give per orally 400 micrograms of misoprostol. If cold chain is available, then you may consider giving either the carbetocin or high heat stable of carbetocin or misoprostol. If the answer is, this cold chain is not available, then these two are the alternatives. If it is available, then find out if oxytocin is available. And if oxytocin is available, then you may consider giving it venously or intramuscularly. If oxytocin is not available, then the options you have is carbetocin, misoprostol, ergometrin, or symptometrin, as we say, which is not, comes from the BMJ Global Health 2019. And one can consider these kind of algorithms in your own birthing centers, depending on what is your availability, and so that you can
Ma'am, we are
use
running
this
short
as
of
the
time.
first approach to prevention of PPH. And only quality assured measures should be, regardless of whichever uterine option you're using, you to ensure that they are stored and placed properly.
बंद करो हाँ सुन And this is the last session and the last lecture of the conference. Dr. Priyankar Rai, an online session again. Sir is a consultant in fertility and gynoendoscopic in Nova IVF and Roy Clinic, Silguri. So we'll be having this lecture from Silguri. Sir has published more than 60 articles, international and national journals, and authored more than 15 chapters. There are many awards in his favor, like gold medal for topping the MS University examination. CV Foxy Future Award, AOFOG Shan S. Ratnam Young Gynecologist Award. Please on the slides.
Everyone. I'm Dr. Priyankar Roy from Siliguri, and thank you first of all for giving me this opportunity to talk on this wonderful conference, Barkha 2023. I would like to wish the organizing team all the very best, and I'm very sure it's going to be a wonderful conference. I thank Madan sir and Dr. Devati Rani ma'am for giving me this opportunity, and I would like to apologize for not being able to come there physically because of my dad's ill health. And I hope that you will pardon me, and this talk is going to be of some clinical benefit to all of you. So I'm going to talk on vaginal delivery and its urogynecological implications. And first of all, let us look at the genitourinary system. So we all know injury from childbearing due to prolonged obstructed labor without any timed intervention, ideally LSCS is what preferred. Women left with chronic incontinence, women often absconded by husband and family, and of course outcasted by the community, and prospects of healthy life greatly is diminished. So William Smellie set of anatomical tables in the year 1700 and in the year 1752 said it was an 18th century obstetrical drawing of obstructed labor from absolute cephalopelvic disproportion, and this is somewhere where there's a high chance of urogynecological implications in vaginal delivery. So, vesicovaginal fistula first let us look at, and this is the most debilitating sort of a disease that we can think of, especially after an obstructed labor. Thankfully, because of the advances in obstetrics, this urogynecological or fistulas have come down to a great extent. So it's a pathological communication between the bladder mucosa and the vaginal epithelium, which allows free and continuous involuntary flow of urine from the bladder to the vagina, such that the woman is wet all the time. It could be uterine fistula, as you can look at. It could be vesicovaginal fistula, that's the various types of fistulas, urethrovaginal fistula, and rectovaginal fistula, again, which is very, very debilitating. It's got a lot of socioeconomic factors. African women are most predisposed to dystocia due to narrow pelvic architecture, because of which probably African women are known to have most of the fistulas, the highest fistula incidence in the world, and even FIGO has got a FIGO clinic of fistulas which is situated in Africa. It could be because of marriage at early age, because the pelvis is incomplete, malnourishment, which retards the maturation, lack of access to emergency obstetric services, and poverty, illiteracy, etc. Fistulas are more common in young girls because of the increased incidence of CPD, pelvic bone immaturity, of course, because the birth canal is very narrow before 18 years of age. Thankfully, in the country, we have the law because of which pregnancy before 18 years is not legally permissible. It could be because of late onset of puberty as well as malnutrition. Low gynecological age, that is chronological age minus the age of menarche, is an important factor, and that is talked about as one of the factors to assess whether CPD could be something that can happen. It can have more devastating than physical injury, that is the psychological damage. Divorce and abandonment is seen in most of the cases, especially in low socioeconomic families. Cast out of the families, there could be depression, anxiety, and other forms of mental health dysfunction is common, and it can sometimes even lead to suicides, attempts, etc. The etiology, of course, most common that you can see is an acquired factor that could be because of prolonged obstructed labor. It could be in case of cesarean section as well, where the incision involves the posterior bladder wall without getting noticed, or sometimes it gets noticed, but because of probably improper techniques during suturing, it can lead to fistulas. There can be accidental passage of a suture through the posterior wall of the bladder as well, which is often seen in cases of hysterectomy as well, and there it is probably a little more common in today's advanced obstetric world. VVF could also be congenital, but that is very, very rare. Uterine rupture could be other factors, which is the acquired factor. That could be because of the rupture of previous cesarean scar, rupture of unscarred uterus from obstetric manipulations. There could be direct trauma during operative vaginal deliveries and gynecological operations like hysterectomies I've already mentioned. We will not waste too much of time in the classification, but we need to know the anatomical classification because we need to classify them and mention that in our case sheet. In today's medical legal world, it is very, very important for us to diagnose everything properly and mention it in the case sheet as per the medical legal terms. Otherwise, we could be in medical legal suit. So type 1, it does not involve, not involving the closing mechanism. Type 2, involving the closing mechanism, that is not involving the subtotal urethra without circumferential defect, with circumferential defect. And type 3, there is miscellaneous, example, ureteric fistula. Classification as per the sizes, which is I think most important for us: small, medium, large, and extensive. Small is less than 2 cm, medium 2 to 3 cm, large 4 to 5 cm, and extensive is more than 6 cm. There could be classification according to the site of injury based on where it is, and you can see all the names present over here. The ones which happen or which can happen are of course classified here. There is juxtaurethral fistula, mid-vaginal fistula, juxtacervical, very large fistula, walled fistula, combined fistula, circumferential fistula, as well as vesicular fistula. Classification according to the type. Now this I have mentioned already in the first slide, and again to reiterate the same point: vesicovaginal, vesicouterine, vesicocervical, vesico-utero-cervicovaginal, ureterovaginal. So this is to classify so that we know the mode of management in the best way. So what could be the clinical presentations? There could be uncontrolled leakage of urine into the vagina, which is the hallmark symptom. Soon after prolonged obstructed labor, operative vaginal delivery or cesarean section. Most surgical and obstetric fistula symptoms develop between 3 or 5 days to 14 days. secondary amenorrhea, secondary infertility, and post-operative urinary leakage, oliguria, abdominal distension, pyrexia, etc. Prevention, of course, the most important prevention factor is delay in childbearing until full pelvic growth is completed, elimination of traditional customs that promote early marriage and adolescent pregnancies, supervision of labor of every woman, including monitoring with use of partogram to detect CPD early and to prevent development of obstetric complications. So one of the main important things that we need to look at is, of course, universal basic education for women. This, according to Harrison, plays a major role in promotion of maternal health, education of women concerning the importance of women's reproductive health, and creation of specialized fistula clinics, which have come in very many countries now, including our neighboring country, Nepal. So one of the major things when I talk of prevention, I talk of history taking. My dad, who is a senior gynecologist in Siliguri, he keeps telling me one thing. Probably in today's day, the gynecologists think their right hand to be a laparoscope and a left hand to be an ultrasound probe, but we forget the very two important other skills that we have. Number one, very good important history taking skill, and number two, the two important fingers that we have that will give us a very good per speculum and a per vaginal examination, which is very, very important to assess the passage in history taking, to know whether there has been any the age plus there has been any complication, any tuberculosis of the bones which could affect the pelvis, etc. And knowing all this is very, very important. So fistula following an operation for benign condition is preventable. Sutures for close of the vaginal cuff or for hemostasis placed inadvertently through the bladder wall, clamps placed on the anterior wall of the vagina, unrecognized perforation of the bladder, accidental or intentional incision into the bladder, and total hysterectomy requires considerable bladder mobilization. And if done all of this, then the chance of complication is very, very less. We need to remember and understand that in today's medical legal world, whatever we do, we need to mention it in the case files, otherwise it's going to be a complication for us. So if something goes wrong, especially in cases of placenta accreta spectrum, we know there can be intentional opening of the bladder. We need to take a proper consent prior to the surgery itself, because we know we might land up with this sort of a thing we might have to do. In case we do not, we can come out, tell the patient relatives we haven't, we can take a negative consent again, and we can finish it off there. But important, take a consent, because otherwise there can be trouble for all of us. Measures to prevent BPF, instrumental plus operative, an important slide. Instrumentation after emptying of bladder. Cervix should be fully dilated. Do not do premature things. Only outlet or low forceps should be applied. Do not go into the pit cavity. End repair looks like, and the overlap repair, but end to end is the one which is considered better. Post-operative care is very, very important. Antibiotics is a must and should be given. Use broad-spectrum antibiotic like metronidazole. Laxative for 7 to 10 days. Better to give the patient NPM for at least 2 days before the passage of stool, before some bit of healing already happens. Offer physiotherapy with pelvic floor exercise, and you can do an endo-anal ultrasound and rectal manometry later to look at any chances of incontinence. Evaluation of symptoms is based on a scale, and the patient will, a score of 0 implies complete continence and 20 complete incontinence. A score of 6 suggested as cutoff to determine need for further evaluation. Now, avoiding obstetric injuries and evidence-based approach, routine or restricted use of episiotomy, ideally in today's day speaking, should not be done. Episiotomy should be performed when only clinically indicated. RCOG recommends mediolateral episiotomy for all instrumental births, much lesser. Hot compress for perineum reduces the risk of trauma, can be used. Lignocaine spray for the perineum is a must, and if given, it reduces the pain, but NICE concluded that lignocaine spray should not be routinely used. Birth after second and third degree and fourth degree trauma, it's a psychological aspect for the mother, and she usually says that I will go for an operative or a cesarean delivery for the next pregnancy, but there is some evidence that the symptomatic woman with vaginal birth does increase the severity of those symptoms, and thus we need to take proper care, talk to them, counsel them, and maybe go a little bit by their choice. But again, as per guidelines, routine episiotomy is not recommended, but in clinical practice, in a case where a previous third degree or fourth degree tear happened, I usually prefer giving episiotomy in these patients. So I would like to thank all of you for giving me this opportunity. But remember, one of the very important things that I would like to talk about before ending this, discuss about the intrapartum care current symptoms of dysfunction of inner sphincter, risk of recurrence, success of previous repair, and psychological aspect of trauma, and based on that, take a combined decision concerning subsequent mode of birth and intrapartum care that should be made. Thank you so much once again for giving me this opportunity. Sorry I could not make it this time, but I assure next time I will be there. Thank you so much once again.
Thank you, Dr. Priyankur Roy, for wonderful talk, obstetric injuries in vaginal birth. Thank you. I would request Dr. Kavita Kamble to give vote of thanks.
They say gratitude sweetens. Okay. Yeah. I should thank all the delegates first for this, till this staying here and listening to this. We come to the end of the session. And they say that gratitude sweetens all the small moments which have come in our life. So this is a moment we take to express our gratitude to all those who have made this Monsoon Barkha Summit a grand success. We congratulate each and everyone and express our gratitude in our own way by thanking all the AMOX office bearers, the FOXY office bearers, the ICOG office bearers, all the associated farmers, and all the associated societies. And we would like to extend a special thanks to the Solapur Society because they have been sitting here right from Saturday morning to the last lecture, and we express our gratitude to them. So a grand applause for all the Solapur Society people. Also the Latur Society people and Osmanabad Pandharpur sir. Dr. Doshi has been here and has been very actively participating in all the stages. All the delegates, and we are very happy to announce that MMC has given us 4 points and ICOG has granted us 8 credit hours for the session. The gratitude won't be it won't be finished if we don't express our thanks to the AV audiovisual persons who have been here and making efforts to deliver what we have to say and what you have to listen on a very expressive way. They have helped us. So we thank all the AV audiovisual persons. And of course Balaji Sarovar and the conference, all those delegates who are there here from Saturday morning, online and offline. We express our sincere gratitude to them and thank all of them. And with this, it won't end by, the thanks won't be finished if we don't thank our organizing chairperson and secretary, Dr. Madan sir and Dr. Revati Rani madam. So we clap for each one of us because we are taking a piece of knowledge today. From the last 2 days, we have been knowing each other, sharing the wisdom, and had a great cultural night also. So thank you everyone, each and everyone.
Before that, we are going to give the prizes for paper and poster presentations and poem. We would like to declare, and we would like to felicitate the farmers and others associating.
There was a poem competition. It was arranged on the theme of monsoon rains. ह्याचे रिझल्ट्स आपण आधी डिक्लेअर केलेले आहेत. द फर्स्ट प्राइज आता आहेत का पोएम कॉम्पिटिशनचे कोणी पार्टिसिपेंट्स? अच्छा, फर्स्ट प्राइज वॉज वन बाय डॉक्टर मृदुला. कवितेचं नाव होतं पाऊस. सेकंड यू अँड मी इन द रेन बाय डॉक्टर प्रतिभा बलदवा.
We call upon the secretary.
Yeah, I request Dr. Pratibha to come ahead, and I request Dr. Madan Kamble sir and Dr. Vinod Shetty sir to kindly felicitate. I request Gujar madam to kindly join. And third prize is won by Dr. Kavita Kamble. डिस्क्लोज करायचं आहे का? अच्छा, आता मृदुला कोण होती माहीत नव्हतं, पण आता मृदुला कळली आहे. तर ही ऑरेंज साडीमध्ये ती मृदुला आहे. दॅट इज अ सरप्राईज फॉर अस. अँड इट सीम्स 2 poems they were submitted. So here she gets 2 prizes for number 1 and number 3, Mrudula and Dr. Kavita Kamble. And I would like to say this poem competition was arranged and organized by Dr. Amit Chopde. He is a very good poet. तू आता म्हणून दाखवायला पाहिजे एखादी कविता जो अंगाई. There was poster and paper presentation also. It was conducted for 2 days and we got a very good response because we have 2 medical colleges and all the lecturers, HOU and HOD really cooperated well. So we had total submission 8 papers, and for this thing, for posters we had 6 posters, and it was judged by none other than Dr. Pradeep Patil sir and Chaudhary madam. So thank you sir for coming both the days, coming at early in the morning and helping us with judging the papers. त्याचा रिझल्ट आपण डिक्लेअर केला आहे. सो फॉर इन सिनियर कॅटेगरी इन पेपर प्रेझेंटेशन द फर्स्ट प्राइज गोज टू डॉक्टर राधिका थिटे. I can proudly say that she is from Akluz OBGYN Society and she presented a very good paper on the Doppler studies in endometrium, and she has recently done her fellowship with Dr. Panchulia ma'am. So she has, I request Dr. Nitin Thite sir to please kindly join. And irony of the situation is he is a radiologist and she has presented all the radiological findings. So I guess आता सरांचं काम नो मग सरांना आता करायची गरज नाही बिकॉज यू डू इट सो वेल. हां सर्टिफिकेट. Second prize in senior category goes to Dr. Pratibha Valdava again. I must say we got very good support from Solapur OBGYN Society. She presented, no, thank you. She presented, can you please tell you the topic?
It was concomitant use of letrozole and clomipene along with gonadotrophins.
Thank you ma'am, so please be on stage. I request our, I request our seniors to please kindly felicitate.
Amit, Pharma.
In junior category, there was a lot of competition, and we were very happy to see that juniors were very enthusiastic, and I could listen to their and see their presentation. They were very precise. Of course, they got guidance from all their mentors, but we have good gynecologists in pipe. So for junior category, the first prize was to Dr. Raksha Gaikar. Is she here? And second prize goes to Dr. Avantika Thomre. Big round of applause, I must say. ते अजून ज्युनियर आहेत, त्यांना ऑब्स्टेटिक गायनेकमध्ये अजून पडायचं आहे, सो दे नीड लॉट ऑफ एनकरेजमेंट अँड सपोर्ट आय फील. Also, we would like to felicitate our judges for the paper and poster presentation. So I request Dr. Pradeep Patil sir to please come forward. Madam nahi hai na? Chaudhary madam must not be there. येस येस 2 बुके चालतात. ठीक आहे. Now over to you, Mrudula, for next. Next.
That was nice one. Yeah, we felicitate all the pharmaceuticals we call upon first the Corona Remedies Private Limited and ask a chairperson and president to please felicitate them. Corona Remedies. All the farmers have been they have helped us economically. The next will be Blisson Medical Private Limited, Shivam Surgical, Solapur, Bella Pharma, then Samsung, Shivam, Acha Blisson, Shivam Surgicals. पुढे या पुढे कुठले शिवम पहिला पंप आधी शिवमचं Samsung, Sun Pharma, Abbott India Limited, Acumentis Healthcare, the Viviana Division. Sir, yeah, Shivam सांगितले, आधीच सांगितले. Shivam Surgicals, Sun Pharma. या ना पटपट. Abbott. Yeah, sir. Yes. Acumentis. The Viviana division. Viviana. येतो ना आता सगळेच येतात. Gynocare Services, QRS Healthcare, Doto Healthcare Private Limited, Sambric Medicines Private Limited, Intas Pharmaceuticals, Yantriki Medicos, Yantrika Meditech, Galchem, MCure Pharma, yes, sir. Nivian Pharma, without all the pharmaceuticals, this conference would not have been possible. So again, we express our gratitude to you. Yeah. Galchem Pharma, no one from there? कुठलं राहिले? ॲक्युमेंटस आधीच बोलवलं होतं. ॲक्युमेंटस सॉरी क्रिएटिव्ह फार्मास्युटिकल्स ॲक्युमेंटसची क्रिएटिव्ह डिव्हिजन ओके तर बोलवलं तसं विव्याना दे अच्छा विव्याना क्रिएटिव्ह डिव्हिजन अजून कोण या
Just I want to say something for that, sir. Just myself, Sandeep Fodkar, I'm working as a ZSM, Acumitis Healthcare Creatives Division. We actually, I would like to say on the behalf of the all pharma companies, sir, giving me the chance of the participate in this conference, and really big thanks to that, ma'am. Just it is arranged by very well manner and very good, and just in future also we'll participate in that. Just big thanks to all of you. Thanks, sir.
Which pharma? Galchem Pharma. Please come. अजून कोण राहिलं का विचार सॉरी भारत सिरम्स अँड वॅक्सिन्स अजून कोण राहिलं बिकॉज द लिस्ट इज इनकम्प्लीट अजून कोण राहिलं का सर राहिली का कुठली If any pharmaceuticals is remaining, please let us know. Gufic, yes. Gufic Pharmaceuticals. Yeah, सुवेनरला कसं सी माझ्याकडे लिस्ट आली आहे त्याच्यामुळं जे लिस्टमध्ये आले ते नो द सोविनियर गुफिक फार्मा सोविनियर राहिलं ग हां 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 Last not the least, the Souvenir Pharma who has helped, given us a memento with this conference of a revolving video. So we extend a special support to them. Souvenir Pharma. Gol. Please come. Any pharmaceuticals remaining, please let us know. Oh. That's such a nice gesture. We request all the Occlusovs Gynae Society members and all the delegates, please come on the stage because the farmers have to thank all of us. So please, all who are present on this, as delegates, please join us here.
Thank you, madam.
Thank you, sir. Sorry, जे राहिले असतील तर the seniors बसले का
स्टेज मजबूत आहे स्टेज मजबूत आहे इतके लोक
सर या ना वरती
एक्सक्यूज मी या ना सर
हॅलो मी एकबोडे RC MQR फार्मा आहे. सर्व कंपन्यांकडून मी सर्व सोसायटी जे सोलापूर, लातूर, उस्मानाबाद, लातूर हे सर्व सोसायटी एकत्र येऊन आमच्या सोलापूरमध्ये त्यांनी जे ग्रँड सक्सेस केलेलं आहे CMEचं, जे सुरुवातीला आम्हाला पण वाटत नव्हतं की इतकं होईल चांगलं, पण ज्या पद्धतीनं त्यांनी अरेंज केलेलं आहे त्याच्याबद्दल मी पूर्ण सर्व सोसायटीच्या मेंबरचा मी पूर्ण फार्मा कंपन्यांकडून त्यांचा आभार मानतो आणि आम्हाला संधी दिल्याबद्दल आम्हा फार्मा कंपन्यांना त्यांचा मी आभार मानतो.
चला सर.
We continued our felicitations to the two volunteers, the AV persons. Saminder sir, please come on the stage. Two volunteers. Saminder sir.
सर असतील ना
विचारा ना.
सर्टिफिकेट वगैरे काही नाही आहे फार्मा कंपन्यांना
सरांच्या हस्ते आपल्या हेल्प
हां.
आणि आधी व्हॉलेंटियर्सचं घेते गिंच
त्यांची नावं काय? We request Dr. Dabde sir to felicitate our volunteers. ते पाठवा ना.
हेल्पर म्हणजे तो जाधव परत आपला
तुम्ही सांगा ना. जाधव,
नाव सिद्धांत
सिद्धांत
जाधव लोखंडे आणि गेला
Mr. Siddhant, Mr. Jadhav,
तर त्या तिघींचे
please come on the stage. This we also extend.
त्या मुलींचं
We express our gratitude to the girls who have been helping us with the trophies and with the teas at time also. Vanshika Garg, Neha Fere, आणि and Ramani Joshi. Mr. Jadhav, Mr. Siddhant. कोण राहिलं अजून?
लोखंडे
Mr. Lokhande.
लोखंडे गेलं काय? लोखंडे यावर सर. मदन
And the one who has given us moments which will be remembered throughout, the photographers and the videographer. We would like to express our gratitude by giving them a memento. Please come on stage. Photographers next. झालं?
नाही ना पुण्यात तुझ्या माहितीप्रमाणे
नाही, फोटोग्राफर्स राहिले होते अजून.
हॉटेल पर्सन
सांगितलं होतं मी तेव्हा. Any hotel personals, if there are any there from Balaji Sarovar, please can you come? So we declare this conference as ended on this day.
Hello. All the delegates from Aklus are requested to come on the dais. We'll take a common photo. Dr. Archana Gavri, Dr. Vaishnavi Shete, Dr. Nitin, Shilpa Rohit, Sahil lage, Nitin Tide sir, Pramod Kamble sir, all please are requested. डॉक्टर शिल्पा फडे मॅडम, डॉक्टर रोहित, फिजिशियन उठा जागेवर जा. चला प्लीज नितीन, सगळ्यांचा एक ग्रुप फोटो घ्यायचा जे आपल्या आपलं जेवढे आहेत ना.
काय
द्या द्या बरं झालं. या, मदत
नाही मस्त हे घे.